malignancy which is throwing distant mets. Staging, that's separate staging system that I will discuss, separate WHO classification for pathology. And relapse pattern is also different compared to other head and neck malignancies. So I'll take initially the symptomatology based on the axial anatomy. So this is a cadaveric section at the level of the nasopharynx. And give me 1 minute. Okay, let me take the pointer. Okay, so this is at the level of the C1 vertebra. So this is the fossa of Rosenmuller. That is a lateral pharyngeal recess. So most of these tumors, if the tumors are confined to this lateral pharyngeal recess, they may be asymptomatic due to the primary, but the patient may have lymph node involvement. So this is the torus tubaris. This is the levator velae palatae muscle. This is the tensor velae palatae muscle. This is opening of the eustachian tube. And when the tumor spread to the prevertebral muscles, this is the longest capitis and this is the longest collar muscle, then that becomes T2. And this patient can present with neck stiffness, difficulty in moving the neck. And you can have the retropharyngeal lymph node that is medial to the internal carotid artery. This is the carotid sheath. And you have the parapharyngeal space. When the parapharyngeal space is involved, then it becomes T2. This is the medial pterygoid muscle, which is arising to the medial edge of the lateral pterygoid plate. And this is the lateral pterygoid muscle there. And this, once the medial pterygoid or lateral pterygoid is involved, then it becomes T2. So if the tumor is confined to pharyngeal mucosa, then this area, then it becomes T1. Either it spreads to the prevertebral muscles, the parapharyngeal space or medial pterygoid, then it becomes a patient can have T2. And when the patient spreads laterally, the patient can have ear symptoms. When the tumor spreads anteriorly, the patient will have nasal symptoms like nasal blockade, nasal discharge or epistaxis. Once the tumor spreads anteriorly and laterally, then the patient can have pterygoid plate destruction, and then patient can have the masticator space involvement, and patient can have trismus. So when the tumor spreads, this is the boundary. So you can see that this is the superiorly it is the basis sphenoid, and posteriorly is the basis occiput. Anteriorly it is communicating with the nasal cavity. Inferiorly it is communicating to the oropharynx. That's the boundaries of the nasopharynx. So patient may present with either due to lymphadenopathy or due to symptoms which we have discussed. So the patient will undergo the nasal endoscopy and a biopsy. Then if there is any doubt, then we will do the cytokeratin for the immunohistochemistry. The next investigation is to have the image, the local disease. That's the MRI is superior to CT scan, the base of skull, the nasopharynx and the whole neck. Then we should do the distant metastatic workup. It can be done either by a single shot PET CT or can be done by the X-ray chest, ultrasound of the abdomen or bone scan. Then we should have the baseline blood counts, renal function test, including the creatinine clearance test. Then the EBV titer, either by the EBV EBER or the EBV DNA assay. Then visual field testing, audiometry, and dental prophylaxis. We're coming to the axial view in CT scan and MRI. This is how you stage because we need to know that. So this is the fossa of Rosenmuller, and this is the torus tubaris, opening of the eustachian tube, the pterygoid plate here. And whenever any tumor, even if it is T1, which spreads anterior to this pterygoid plate, and this you can see that there's a nasal extension is present. This is the prevertebral muscles, and it can be very make out in MR. It is only possible by an MR to differentiate whether a prevertebral muscle is involved or not. And the muscles which we can very clearly see in MR, not seen in CT, are one, this is levator velae palatae muscle, this one, and this is the tensor velae palatae muscle. This is a medial pterygoid muscle. This is a lateral pterygoid muscle. In a tumor, it spreads lateral to the lateral pterygoid muscle, then it becomes a T4 disease. And this is the T1 disease. This is a pharyngeal mucosal space. So the prevertebral muscle involvement, the parapharyngeal space involvement, or pterygoid muscle, then it becomes T2. And this is the sagittal view of the CT scan. This is the basis sphenoid. This is the clivus C1. The caudal edge of the C1 vertebra, based on the Gray's anatomy, is considered as the caudal limit of nasopharynx. So this is the caudal limit of the nasopharynx. Superiorly, you have the sphenoid sinus. And this is what you see in a normal MRI sagittal view. This is the nasopharynx. This is the soft palate. And it is the tumor can spread from the nasopharynx to soft palate, but still it is T1 only. Now, if the MR is superior to CT scan because it is more sensitive to know the base of skull involvement, extent of intracranial extension, the parapharyngeal space, the prevertebral muscle involvement, retropharyngeal lymph nodes, and also for perineural invasion, based on the various authors, this MR is superior to CT scan. The tumor which is confined to nasopharyngeal mucosa, oropharynx or nasal cavity, it is T1. Earlier, it was the nasal cavity and oropharynx was considered as T2A. But when they analyzed the 5-year survival, it has found that the patients who have oropharynx or nasal cavity extension, the survival is same. The survival curves are hugging with the patients who have tumors confined to nasopharynx. That's why the T1 disease is nasopharynx, oropharynx, or nasal cavity. If you have a patient with oropharynx, if it is P16 negative and the tumor is extending into nasopharynx, it is T4B. But in nasopharynx, it is only T1. So it can be extension into the oropharynx or nasal cavity. Nasal cavity, you look for the pterygoid plate. If any tumor which spreads anterior to a pterygoid plate, then it becomes a nasal cavity extension. Lower down, you look for any tumors which is coming down below the level of the C1 vertebra, then you will take it as oropharyngeal extension. You need to know that the nasopharyngeal tumors have spread for superiorly rather than downwards. So most of the tumors who have oropharyngeal extension will have tumors either a base of skull involvement or in the sphenoid sinus involvement. Then T2, this I have already discussed, that I will skip. Then this is a typical T2 disease. The patient he is having, this is the normal parapharyngeal fat on right side. You can make out this is the carotid sheath, the prevertebral muscles, the pterygoid muscles, but you can see that the prevertebral muscles are involved. The parapharyngeal fat is obliterated and also involvement of the pterygoid muscles. So it is a classic T2 disease. Even if you have infiltration into the carotid sheath, it is only T2 disease and it is not T4. In oropharynx, a carotid sheath involvement or encasement of the carotid artery is considered as T4B. And you can have, this is a patient who have the tumor which is confined to the pharyngeal, the lateral pharyngeal recess on right side, but you have a contralateral retropharyngeal lymph node. The retropharyngeal lymph node can extend from cranially from the cranial limit of C1 vertebra to the cranial limit of the hyoid bone. So that's the limit of the retropharyngeal lymph nodes, and it lies medial to the internal carotid artery, anterior to the prevertebral muscles. And it extends from C1 to C3 vertebra. 75% of the retropharyngeal lymph nodes are seen along with C1 vertebra, 18% along C2, and 8% along the C3 vertebra. Even if you have bilateral retropharyngeal lymph nodes and there is no change in staging, it is considered as N1, whereas bilateral, the cervical lymph nodes, it's considered as N2. Lateral retropharyngeal lymph nodes are more common, and it is in the medial retropharyngeal lymph nodes are not included in the updated classification nodal staging. And the size criteria is different for retropharyngeal lymph nodes and cervical lymph nodes. In cervical lymph nodes is 1 centimeter or above, but retropharyngeal lymph nodes, it is 5 mm. If you look into the nodal pattern, we can see that the 75% of the patient can have nodal presentation. Most common lymph node involved is level 2. The most characteristic lymph node is retropharyngeal lymph nodes. And this may be the first manifestation. And this tumor size or the nodal involvement is not related to the size of the primary tumor. There is a high tendency for bilateral retropharyngeal lymph nodes, and mostly they follow an orderly fashion. And if you have this, you can see this is a CT scan showing a prevertebral muscles, the parapharyngeal fat is obliterated, the medial pterygoid involvement. Even if you have multiple nodes on one side, it is not considered as ipsilateral or contralateral, it is called unilateral or bilateral. Then even if you have multiple nodes on one side, it is called unilateral. Even if the tumor is on one side and the node is on the opposite side, but still it is considered as the unilateral. It is not considered as the contralateral. Now, T3 disease is the bony structure involvement. Say in head and neck squamous cell carcinoma, yes, I need one more minute. Okay, any tumor which is having a bony involvement in head and neck squamous cell carcinoma, then that is considered as a T4 disease, T4A, but in nasopharyngeal carcinoma, it is only T3. You can see this patient had a clivus destruction. Actually, this patient presented to us after a meningitis. So when the patient was after the meningitis, and they evaluated, and the neck stiffness was persisting. So they evaluated, they did a CT scan. They found that there is a clivus destruction. It's another patient with base of skull involvement. So a clivus destruction, base of skull involvement. Then you have any paranasal sinuses involvement. You have a maxillary involvement. Then these are all considered as T3 disease. Sphenoid sinus involvement, C1 vertebra involvement. These are all T1. Pterygoid plate destruction is also T3. And then you have the nodes. Even if you have bilateral nodes, that is bilateral mets, 6 centimeter or smaller above the caudal border of the cricoid cartilage. Means the caudal border of the cricoid cartilage is considered as the level between the level 3 and level 4 anteriorly and level 5A and 5B posteriorly. So any node which is seen at the level of the level 4 anteriorly 4A or 5B, then it becomes N3 node irrespective of the size. And this is you can see that this patient is having a sphenoid sinus involvement. Because due to lack of time, I'm not showing any foraminers or anything because that needs a lot of time. These are bilateral nodes are there. It is at the level of the thyroid cartilage. So it is at the level of the level 3. So it's a bilateral. So it is an N2 disease. So it is a T3N2. It's a stage 3 disease. And if comparing this I have already told, bilateral retropharyngeal lymph nodes, it is N1, but bilateral cervical nodes, it is N2. And you can see a medial retropharyngeal lymph node. This I have taken from the internet because I searched for a medial retropharyngeal lymph nodes. So this is a medial retropharyngeal lymph nodes. Okay. Yes, coming to the last part of the talk, that is T4 disease. So it is T4 disease is no T4 and T4B intracranial extension. 20% of the T4 disease present. You can make it out in your clinic because this patient, any patient present with cranial nerve, it is T4. So 20% of the patient present with cranial nerve involvement, hyperpharynx, orbit, parotid, or any tumor which spreads beyond the lateral border of the lateral pterygoid muscle. So I will give you one or two examples, then I will wind up. So this patient had a lesion involving the medial cranial fossa through the foramen rotundum. So this is one of my patient teacher presented in 2013. Patient had a lesion involving the nasopharynx extending into cavernous sinus. So this extension into the orbit, and also the patient had proptosis and also abutting the midbrain. So it is difficult, brainstem, sorry. Then you can see that it is very difficult to treat. This patient was given induction chemo, and then you given chemo radiation, and the patient have given 2 oleums, and still the patient is coming for follow-up. And when the patient is having cavernous sinus involvement, usually 3, 4, 6, and the first and second division of the 5th cranial nerve is involved. So 3, 4, 6, and the first division of the 5th cranial nerve is the exit through the superior orbital fissure, and this the level, the V2, which it is the foramen rotundum. Usually the V3, that the mandibular nerve, is paired in patients who have cavernous sinus involvement. And this is a patient who have the parotid involvement, parotid gland involvement. So the parapharyngeal space involvement is T2, prevertebral muscle is T2, but once the parotid is involved, then it becomes T4. N3, any size of any node more than 6 centimeter, whether it is extracapsular extension or not, or any node at the level of the level 4 anteriorly or level 5B, then it becomes an N3 node. The size is immaterial. And this is another patient. This patient presented with a large nasopharyngeal carcinoma that is spreads beyond the lateral border of the lateral pterygoid muscle, pterygoid plate destruction, the prevertebral muscle involvement, the parapharyngeal fat obliteration. So this is the last slide. Okay, the coronal view, because I didn't purposely discuss the coronal view. This is the normal, the pharyngeal mucosal space. You have, this is the lateral pterygoid muscle. This is a medial pterygoid muscle. This is a mandible. You have to look into the perineural invasion between the lateral and medial pterygoid muscle here. So that's the area where you see the perineural invasion of the mandibular nerve. And this is a masseter muscle. So you can see a lesion, enhancing lesion in the coronal view, filling the pharyngeal mucosa, but you can see there is a perineural invasion between the medial pterygoid and lateral pterygoid, and also involving the cavernous sinus. So that's a T4 disease. So any patient who is presenting with the distant metastasis is stage 4B, and there is no stage 4C in carcinoma nasopharynx. Thank you very much for your patient listening.
Thank you, Dr. Shashwat. Next talk will be on management of T1, T2, and 0 carcinoma nasopharynx. Speaker is Dr. Tanvir Shahid. He is the head of the department and the head of academics at Apollo Hospital, Kolkata. Welcome.
Thank you so much. Good morning, everyone. At the onset, I'd like to thank Dr. Nikhil, Dr. Triranjan, Dr. Rakesh, Dr. Vijay Patil, and the entire organizers for giving this opportunity. The topic on which I'm going to speak is management of T1 and T2 N0. And we know that N0 in nasopharynx is not that common as far as the incidence is concerned. To begin with, T1 N0, the treatment is radical radiotherapy alone. And for T2N0, you have multiple options like radiotherapy alone or concurrent chemoradiation, or you can give neoadjuvant chemotherapy followed by concurrent chemoradiation, or concurrent chemoradiation followed by chemotherapy. Now, if you look at what does the guideline says, and these are the common guidelines what we commonly encounter. If you look into the NCCN guidelines of last year, that is 2021, the treatment for T1 across all the guidelines is the same, that is radical radiotherapy. But for T2N0, since it is a mixed bag, you have multiple options, and this is a heterogeneous group basically. But what is interesting in this year's guidelines of NCCN, that T2N0 has been separated. T2N0 has been separated, and the treatment option is definitive RT with or without chemotherapy. And chemotherapy is added for the high-risk patients, specifically for the bulky tumor and high viral load. Similarly, if you look at the European guidelines, again, for stage 2, it is either radiation alone in the form of IMRT or IMRT combined with concurrent chemotherapy. And according to the Chinese Society of Clinical Oncology, or ASCO guidelines published in JCO last year, again, the treatment for T2N0 happens to be radical radiotherapy either alone or combined with chemotherapy, and chemotherapy has to be added with the high risk features of a bulky tumor volume or high viral load. And our own national cancer grid in T2, either concurrent chemoradiation, that's one. The slight difference is that they have proposed for a neoadjuvant chemotherapy 2 cycles followed by concurrent chemoradiation as an alternate treatment strategy. Now, one thing is clear, T1N0, no doubt it's radical radiotherapy, but for T2N0, it's radiotherapy alone, but the issue is with the chemotherapy, and we are not clear whether chemotherapy has to be given or not. Now, the concept of chemotherapy in a randomized controlled trial came from this particular trial by Chen et al., published more than a decade ago, and it was a randomized phase 3 trial, the first trial which really looked into the concept of adding chemotherapy to radiation in stage 2 diseases. Now, with this particular trial, adding chemotherapy to radiation, there was not only improvement in the loco-regional control, progression-free survival, or distant metastasis-free survival, there was improvement as an overall survival too. And this really paved the way that chemotherapy can be added to radiation in stage 2 nasopharyngeal carcinoma. But what is very important in this trial was that patients with radiation were treated with 2D-RT or the conventional RT. That has to be kept in mind. If you look at the national cancer database, like all the cancer database are retrospective studies, and this again looked into the concept of chemotherapy in stage 2 nasopharyngeal carcinoma. Now, stage 2, we do understand that stage 2 can be either T1N1, it can be T2N1, or it can be T2N0. Now, moment N1 disease comes into the play, there you have an advantage of adding chemotherapy. But if you look at only the T2N0 subset, you don't have an advantage. And despite adding chemotherapy, you're not getting an advantage. So that has to be kept in mind, that despite being a stage 2, N0 and N1 are different. N1 has an advantage, but T2N0 will not have an advantage by adding chemotherapy. Now, this I thank Dr. Sekil. He had mentioned this about this just in the morning, and ASCO post done just last week. Again, it was a trial. It was a phase 3 randomized trial, which included the low risk nasopharyngeal carcinoma patients. And there again, the conclusion of this trial published in ASCO was that concurrent chemoradiation can be, that is, chemotherapy can be safely omitted in the low risk category group. That is, IMRT is good enough. Now let's see what does the meta-analysis say about adding chemotherapy for the T2N0. And these are the 3 meta-analysis which is published in the last few years. And I'll straight away come to the conclusions of this meta-analysis. And the question was the same, whether concurrent chemotherapy in stage 2 nasopharyngeal cancer has to be given or not. And the conclusion was that conventional radiotherapy, specifically 2D, if that is added along with chemotherapy, then you have a survival advantage. But if you add chemotherapy to IMRT, then that advantage is not coming because you are able to push the dose safely. So adding chemotherapy is not going to add advantage. And IMRT alone, it is giving an equivalent result as compared to conventional radiotherapy with chemo. But having said that, despite not having a robust evidence of use of chemotherapy, but still, if you look in stage 2 nasopharyngeal carcinoma in US itself, in the last 1 decade, the concept of concurrent chemoradiation is the standard of care as far in the last 1 decade, and it hasn't changed. So though we don't have an evidence, but stage 2, still concurrent chemoradiation is the standard of care. Now, what should be the target volume for N0 disease? And this is the topic because we have a positive evidence that what should be the target volume and what should be the doses. And a beautiful paper was published from Tata Memorial by Dr. Sarbani ma'am's group, in which they tried to address this question that what should be the target volume and doses. Again, I'll just summarize it that in N0 diseases, bilateral retropharyngeal group of lymph nodes and the level 2 lymph node has to be included in the target volume. And the lower neck region for N0 disease, since it is at a very low risk of harboring the disease, so it can be safely omitted. But in N1, the contralateral lower neck, which is again at the lower risk, can be omitted. So this can just reduce the toxicity, and yet you can get the same outcome. So this is something which was very interesting. Now, what is the role of brachytherapy in early stage nasopharyngeal carcinoma? We all know that brachytherapy is ultimately the ultimate form of conformal radiotherapy. And by adding brachytherapy to early stage nasopharyngeal carcinoma, it does the dose escalation. And if the dose escalation is there, then definitely the control will be better. I'm quoting a very old paper published decades ago, but this was a randomized trial because we seldom find randomized trials in brachy. So that's very interesting. Whereas radiation was compared with radiation and brachytherapy in early stage. And with brachytherapy, the dose, it was possible to escalate the dose. And with this dose escalation, the conclusion was that the locoregional control was better, and even it had an improved survival benefit. So that's something very, very important. So brachytherapy can be given in early stage for dose escalation, and in turn, you are getting a better local control, which can translate into a overall survival. But the question always remains, how many centers in today's do brachytherapy specifically for CA nasopharynx? That's something, it's, very few centers I do. So to conclude, for T1N0, no doubt, is radical radiotherapy. For T2N0, role of concurrent chemotherapy with IMRT is definitely not well defined. Along with two-dimensional radiotherapy, which is two-dimensional, is not a standard of care for CA nasopharynx at least. So, but if any center practices there, it's fine. Several meta-analysis, of which most of the papers included in the meta-analysis for retrospective study, showed that IMRT alone can give an equivalent result without adding chemotherapy. And since we don't have a randomized evidence for T2N0 radiotherapy along with concurrent chemotherapy, but still in the presence of high risk features, that is for bulky disease and high volume load for the virus types are concerned, and then you can add chemotherapy in a concurrent setting with radiation. And brachytherapy, if a center has, can be delivered as a boost to escalate the dose and in turn get a better locoregional control with acceptable toxicities. Thank you. Thanks a lot.
Thank you, Dr. Tanvir. Next speaker is Dr. Kaustav Talapatra. He is a director of radiation oncology at Nanavati Max Super Specialty Hospital. He will be speaking on concurrent chemoradiation in carcinoma nasopharynx.
Good morning. At the outset, I thank the organizers, especially Dr. Thiranjan, Dr. Nikhil, and Dr. Rakesh. So my topic is radiation therapy with concomitant chemotherapy. And the rationale we all know, why radiation and concomitant chemotherapy work in the same space. That is because of spatial cooperation, temporal modulation, enhanced cytotoxicity, biological cooperation, and of course, overcoming radio resistance. And as Tanveer has already talked about, radiation and concomitant chemotherapy is being used in certain stage 2, stage 3, and in certain stage 4 disease. So talking about the evidence, this is the initial evidence, Intergroup 0099, Al-Saraf's publication. They use radiation alone, 70 gray over 7 to 8 weeks versus CT-RT and adjuvant CT. This trial was closed prematurely. They had used 3 cycles of cisplatin and 5-FU because of significantly better outcomes in the CT-RT followed by adjuvant arm. The criticisms of this trial were trials conducted among participants from non-endemic group, not clear whether the benefit was from concurrent or adjuvant, and there was poor compliance to adjuvant therapy. This is the publication by Chan et al. And this is conducted by the Hong Kong group. They had 350 patients. They used 66 gray of RT plus 10 to 20 gray of radiotherapy boost to the gross tumor volume, which was a very high dose. The primary endpoint was overall survival. The 5-year OS was 58% in the radiation alone group versus 78.5% in CT-RT group, which was not statistically significant, but a trend to statistical significance was seen. Of course, the subgroup analysis also showed that there was a difference between the T3, T4 staged arms, and p-value was significant in that subgroup. Following which, this is almost around the similar time, the publication from Lin came. They had 284 patients. They used standard doses of 70 to 74 gray in both the arms. That was RT alone versus RT plus 2 cycles of infusional cisplatin and 5-FU during week 1 and week 5. The median follow-up was 65 patients. And this clearly showed overall survival benefit in favor of the group which received concurrent chemo radiation. So there, as we saw that in the Chan's paper and in the previous publication, there was a difference in overall survival in all comers. In the previous paper, in Lin's paper, overall survival was significantly higher in all comers, all the groups, whereas in Chan's paper, overall survival was only seen to benefit patients who had T3, T4 tumors. And this difference was supposed to be due, this difference was supposed to be due to Chan using different staging system. It could be due to differentiated non-keratinizing squamous cell carcinoma in Lin's study versus a larger preponderance or larger enrollment of undifferentiated carcinoma in Chan's study, and different chemotherapeutic regimen. The Lin's group used cisplatin as well as 5-FU at week 1 to week 5 could be the reason for difference in enhanced overall survival in all comers in Lin's study. So this is the study by Chen et al., which has been talked about by Tanveer. This is for stage 2 nasopharyngeal cancer, and which has shown significant survival benefit in the group which has received weekly cisplatin as compared to radiotherapy alone. As concurrent chemoradiation progressed in nasopharynx over the last 1.5 decades, groups have realized that with usage of modern radiotherapeutic techniques, the local control and the local regional controls have enhanced, but there is a tendency to fail distally. So the concept of adjuvant radiotherapy came in. I will not get into the detail, but I'll be talking about the meta-analysis of that. Before talking about the meta-analysis, which has come out in 2021, just last year, I'll be talking about few trials which used adjuvant chemotherapy. So this was the Lee-Chen's trial, which was concurrent plus adjuvant chemotherapy, enrolling 508 patients, used RT plus weekly cisplatin in one arm, and RT plus weekly cisplatin, and adjuvant of cisplat and 5-FU in the other arm. And somehow this study failed to show benefit in overall survival in the group which had adjuvant chemotherapy. Similarly, the study which was conducted by Singapore by we and colleagues, they had 221 patients. Their primary endpoint was also overall survival, but in their study, the overall survival was much better in the group which received adjuvant chemotherapy. So this is Blanchard's meta-analysis. This is the updated meta-analysis which has come out just recently. It is on 7,080 patients, and 18 new trials were identified in meta-analysis. Addition of chemotherapy reduced the risk with a hazard ratio of 0.79, and benefit was seen in concurrent chemotherapy. Benefit was seen in patients who received neoadjuvant therapy followed by concurrent chemoradiation, and benefit was seen in patients who received concurrent chemoradiation followed by adjuvant radiotherapy. Of course, the largest effect was observed in patients who had concomitant chemotherapy plus adjuvant chemotherapy. The hazard ratio was 0.68, and absolute survival increased at 5 years to a tune of 12.3%, and at 10 years to a tune of 13.9%. Concomitant chemotherapy group also had a reasonable benefit of 5.2% and 7.2% at 10 years. Induction chemotherapy had 6% and 9.8%. So hence, now NCCN has mandated concomitant chemotherapy, neoadjuvant chemotherapy, and adjuvant chemotherapy, all to be considered for treatment of locally advanced nasopharyngeal carcinoma. So this is another public meta-analysis which was published in 2010 and which had clearly shown this slide I have put to see the chemotherapeutic regimes they had put. This had also shown that concurrent chemoradiation group had a significant benefit over only radiotherapy group, and most of the studies had used cisplatinum as their concurrent chemotherapy agents. Most of the groups had used weekly cisplatinums, few groups having used 3 weekly cisplatinum, and few groups having used cisplatinum and 5-FU as their concurrent regime. Most of the groups have used 40 milligram per meter square as their standard dose. But as we know, I mean, if in our setting of patients, sometimes 40 milligram per meter square is not possible. So there are groups who are using 30 to 35 milligram per meter square too. So this is again the result from the previous meta-analysis. This is a very important document to summarize. This is a CSCO, that is Chinese Society of Clinical Oncology and ASCO guideline, which has been published recently. And they talk about all about radiotherapy, how it should be practiced, and few points about chemotherapy, how it should be practiced. And I think we should go about it. A few words about radiotherapy per se. So principles of radiotherapy in view of time, I have just omitted those slides which we're talking about neoadjuvant chemotherapy, because as I learned, Vanita will be talking about neoadjuvant chemotherapy in the next talk. So principles of radiotherapy, what is the choice of technique? IMRT is the choice of technique for nasopharyngeal carcinoma, preferably with image guidance. What is the dose that's to be prescribed? 70 Gay in 33 to 35 fraction is what is supposed to be prescribed. Once daily, 5 fraction per week is the standard that's to be offered. Target volume delineation. I think there is a talk on that, but just to run through the slides, all patients of NPC, gross tumor volume, should be carefully delineated. Image fusion should be done with MRI, and it helps in seeing the basal invasion or intracranial nerve involvement. The delineation of elective nodal volume should follow international consensus guideline and cover the bilateral neck from retropharyngeal node level 4 and level 5. It also talks about that if the ipsilateral level 1B can be omitted if there is no involvement of anterior nasal cavity, and it is not mandatory to include ipsilateral level 1B in all comers. Toxicity, of course, few of the late toxicity which were seen in various series and the meta-analysis are bone necrosis, hearing deficit, symptomatic temporal lobe necrosis, trismus, massive bleeding, but none of the late toxicities were significant by addition of chemotherapy, whereas acute toxicities were. To summarize, meta-analysis have shown survival benefit by addition of concomitant chemotherapy to radiotherapy, as well as neoadjuvant and adjuvant chemotherapy to concomitant chemotherapy, concomitant therapy. IMRT technique used with image guidance is appropriate for radiation planning. Target volume delineation should follow international consensus guidelines and should be aided with image fusion, especially with MRI, and use of EB with DNA. I had skipped that slide in view of time. Marker, but there is a study ongoing by Nancy Lay, and I mean, that is a futuristic use to guide therapy under active, which is under active evaluation currently, and that could help us de-escalate therapy. Thank you.
Thank you, Dr. Kausto. Next talk is on selection of neoadjuvant chemotherapy in locally advanced CA nasopharynx. The talk will be delivered by Dr. Vinita. She is a professor of medical oncology at Tata Memorial Hospital, Mumbai. She is joining online.
Thank you so much to the organizers. Thanks, Triranjan, Nikhil, and Rakesh for this opportunity. Kaustav, you could have just done the induction chemotherapy, and I would have been quite happy with that. So I'll just start. Are my slides visible? Sorry, are my slides visible?
Yes,
ma'am. Okay. So I'll be talking in the next 10 minutes or so on how to select neoadjuvant chemotherapy in patients with locally advanced CA nasopharynx. So this is, I think, maybe perhaps the third or the fourth time this morning we are seeing this slide. So these are the current NCCN guidelines. And just to remind ourselves, induction chemotherapy is recommended for patients with T3 or T4 tumors, N1 to N3, or any T, but N2 to N3. Induction chemotherapy can also be considered in earlier stage disease with high-risk features, which include bulky primaries or a high EBV DNA titer. And quickly to go over the staging. So T3 is a primary, which is infiltrating the bony structure. So skull base, vertebra, pterygoid structures, paranasal sinuses. T4 is very locally extensive. So intracranial extension or involving the cranial nerves, the hypopharynx, orbit, parotid, or extensive soft tissue infiltration beyond the lateral pterygoid muscle. We have gone over the nodal staging earlier in detail, so I'll skip that. And T1 is very early stage disease, so only confined to the nasopharynx, oropharynx, no parapharyngeal involvement, and T2 is extension to the parapharyngeal space. So it's important to remember that advanced T stage and advanced N stage have different failure patterns. So primarily advanced T stage fails locally, so more role of local therapy, so chemoradiotherapy. Advanced N stage fails distantly, so more role of induction chemotherapy. So NACT followed by chemoradiotherapy is more beneficial in terms of distant failures, so systemic disease. And so patients with advanced end-stage disease are probably the ones who would benefit the most from induction chemotherapy. What does induction chemotherapy do? So it improves overall survival by the eradication of distant micrometastases, decreases the gross tumor volume. So it makes the delivery of radiotherapy easier. The induction chemotherapy, patients have not been heavily pretreated, so it's much easier to tolerate than adjuvant chemotherapy and can save critical neural structures during radiotherapy. The initial phase 2 data that had established the role of induction chemotherapy was this trial, which had evaluated the role of DOSI and CIS in a phase 2 trial in advanced nasopharyngeal carcinoma. And that trial showed that the use of induction chemotherapy led to a significantly improved CR rate. So the CR was 82% versus 61% in patients who received chemoradiotherapy alone. There was a trend towards an improvement in progression-free survival and a significant improvement in overall survival. So following that, there were a series of phase 3 studies. The first was the use of, and most of these have come from Sun Yat-sen University in China. So this was the study that evaluated DCF, and it's important to remember it's a modified DCF. I'll go over the regimen in the next slide. So they enrolled patients with stage 3 and stage 4B, excluding node negative, so node positive disease, CA nasopharynx, who were randomized to receive 3 cycles of DCF, followed by concurrent chemoradiotherapy versus concurrent chemoradiotherapy alone. The modified DCF, these are lower doses than we are typically used to. So DOSI at 60, cisplatin at 60, and 5-FU at 600, 3 cycles every 3 weeks, and the primary endpoint was failure-free survival. So this was a very positive trial. So they found that the addition of induction TPF improved failure-free survival. So failure-free survival at 3 years was 80% in the induction chemotherapy arm and only 72% in the concurrent chemoradiotherapy arm. There was also a significant improvement in overall survival, in distant failure-free survival. However, the improvement was not significant in loco-regional failure-free survival. And this is a finding that has been echoed across most of the trials for induction chemotherapy. The use of induction chemotherapy significantly increased toxic effects. So the grade 4 toxic adverse events occurred in 18% of patients who received induction followed by CTRT, and only 1% of patients in CTRT alone. And primarily this increase was because of an increase in hematological toxicities. So these were the Kaplan-Meier curves. So a significant improvement in failure-free survival as well as in overall survival. The other trial that evaluated the role of TPF was the GORTEC trial. This was a much smaller trial, so it was only in 81 patients. The importance from this trial was that they evaluated the compliance to cisplatin, and again the compliance was quite good. So there was a small difference, but really very good dose of cisplatin could be delivered in the induction chemotherapy arm as well. The GORTEC trial again showed an improvement in PFS and improvement in overall survival, a trend towards an improvement in progression-free survival, but in loco-regional progression, but not statistically significant. There have been other several regimens that have been studied. One of them was this mitomycin-based regimen. So patients were randomized to receive this induction regimen of mitomycin, epirubicin, cisplatin, 5-FU, and leucovorin for 3 cycles. This was again a positive study, led to an improvement in disease-free survival, in loco-regional failure-free survival, as well as in overall survival. I'm sorry, the improvement in overall survival, there was a trend, but it was not statistically significant. So the study which evaluated the use of mitomycin, epirubicin, platinum, and 5-FU found that at a median follow-up of 72 months, induction arm led to a higher disease-free survival. So the 5-year survival rate was 61% versus 50%, and the p-value was 0.026. And then most recently, we had the data of gemcitabine and cisplatin, again published from Sun Yat-sen University. So they again enrolled node positive disease. T3 and T4 were the bulk of the, almost 90% of the patients had T3, T4 and N1, N2 disease. They found again the use of gemcitabine and cisplatin led to a significant improvement in recurrence-free survival, in overall survival, and in distant recurrence-free survival. There was no improvement in loco-regional recurrence-free survival. So this was the primary endpoint of the disease, recurrence-free survival, and very significant improvement for a p-value of 0.02. Recurrence-free survival improved, overall survival improved, no improvement in loco-regional recurrence-free survival. So the other regimen used is cis-5-FU, and this is the long-term follow-up. So that cis-5-FU was one of the earliest trials published. So we have long-term follow-up in terms of long-term toxicities as well as long-term efficacy. And again, at long-term follow-up as well, the use of induction cis-5-FU led to a significant improvement in disease-free survival as well as in overall survival. So coming to the meta-analysis, this was a systematic review as well as a meta-analysis for the use of induction chemotherapy in patients with locally advanced nasopharyngeal carcinoma. They aimed to compare the effects of induction chemotherapy on overall survival, progression-free survival, distant metastasis-free survival, and loco-regional PFS and adverse events. They included both randomized controlled trials as well as observational studies. They The patients were treatment naive, had stage 3 to stage 4 nasopharyngeal carcinoma, and the selected trials that included the use of induction chemotherapy followed by concurrent chemotherapy versus concurrent chemoradiotherapy alone. So there were 6 randomized controlled trials, stage 3 or 3 to 4B. And the proportion of patients with stage 4 was about half, median age around 45 to 50 years old. Only one trial used only one IMRT. Other trials used either alternatively IMRT or non-IMRT based therapy. RT dose was up to 70 gray. And chemotherapy used were triplets or a doublet. So TPF, GEM, Carbo, Pacli, Cis, Epirubicin, Pacli, Cis 5FU, or Cis Dosi. The concurrent chemotherapy regimens were again split between 3 weekly cisplatin, 80 to 100 per meter squared, or weekly at 40 per meter squared. And you can see, in the interest of time, I'll just ask you to focus on these diamonds. So when the diamond is on the left of unity, it indicates a significant improvement in overall survival. So in both the randomized trials as well as in the observational studies, there was a significant improvement in overall survival from the addition of induction chemotherapy. There was no significant difference in the effects on overall survival between the subgroups based on the type of the concurrent chemotherapy added to radiotherapy, so weekly or 3 weekly. So the induction chemotherapy demonstrated a significant improvement in both progression-free and overall survival. Induction chemotherapy was associated with an increase in toxicity, and the similar results were also noted from observational studies. So the MAC NPC also was an individual patient-derived meta-analysis up to 2015. So earlier, studied the role of induction chemotherapy followed by concurrent chemoradiotherapy. No significant benefit in OS and PFS, but again, these were many earlier trials. And only 2 trials that were included in the earlier MAC NPC had compared induction followed by concurrent chemoradiotherapy versus concurrent chemoradiotherapy alone. And so this, the conclusion of the MAC NPC was that induction chemotherapy delays disease progression, improves survival significantly. There were no divergent results between RCTs and observational studies. The recent updated MAC NPC had included taxane-based induction chemotherapy, and they concluded that taxane-based induction chemotherapy followed by concurrent chemoradiotherapy is considered the best treatment sequence for overall survival over concurrent chemoradiotherapy alone with a hazard ratio of 0.75. So to end, we have multiple induction chemotherapy regimens. We have TPF, we have PF, and we have GEMSIS. We don't really have trials until very recently comparing these various induction chemotherapy regimens. So this was just published in March of this year. This is a kind of an adaptation of the TPF. So paclitaxel, cisplatin, and capecitabine as induction chemotherapy. So they enrolled 238 patients randomized to Pacli, Cis, and capecitabine versus Cis 5FU. Their primary outcome was failure-free survival, and they found that the use of the triplet led to a significant benefit in terms of failure-free survival. So that was at 83.5% versus 68.9% in the PF group. It was an early analysis, so there was no real improvement in overall survival, but improvement in the primary failure-free survival. So I'll conclude that patients with loco-regionally advanced nasopharynx cancer, stage 3 to stage 4A, so accepting node-negative disease, should receive induction chemotherapy followed by concurrent chemoradiotherapy. For patients with earlier stage disease, so T1 to T2 N1 or T3 N0, should ideally be treated with concurrent chemoradiotherapy alone. However, patients with high-risk features, so a bulky primary or a high serum EBV DNA titer, could be considered on a case-by-case basis for induction chemotherapy. The induction chemotherapy regimen could be GEMSIS or modified TPF at lower doses. All of these regimens, induction chemotherapy regimens, have been studied in EBV-associated NPCs, primarily in China. So the role of induction chemotherapy in non-EBV NPC is uncertain. And induction chemotherapy improves overall survival and also increases the toxicities. Thank you so much for your attention.
Vanita ma'am, Dr. Vijay here.
Hi, Vijay.
Ma'am, there was a poster this ASCO of a phase 3 study from Sanyat, which compared cisplatin 5FU to TPF regimen and actually showed that TPF didn't have an OS advantage over CF. So what would be your take on that?
Yeah, so similarly to this other one that was published in JAMA Oncology, right? The paclitaxel, platinum, and capecitabine also didn't improve the overall survival. But it's important to look at what type of patients they included and what was the follow-up. So I agree. So both of them have led to an improvement in failure-free survival, not in overall survival. Perhaps longer-term follow-up and maybe reading the whole paper may help. So as of now, I don't think that we have any level 1 evidence to say that a 3-drug or triplet regimen is preferred over a doublet, maybe GemCis. I agree with you. What are your comments on that?
I agree.
I
agree. So my thoughts was, I was confused after looking at that poster.
So, and that hasn't been published. I agree. So I kind of put this one which has been published, but very similar results, right?
Vijay, can I ask? I mean, were there differences in toxicity in the two regimens in the poster that was published?
Of course, the cis5FU regimen had less toxicities and the TPF had higher toxicities.
Because the cis5FU that they would usually try would have higher doses of cisplatin and 5FU than the modified TPF or DCF regimen. So usually the toxicity rates reported are not very different, as you might have seen in other studies. So that is the concern, that if the toxicity rates are more or less the same, then TPF probably modified DCF or GemCis probably has bigger studies supporting it than the PF.
So Indranil, I just pulled up this study which is published. So I don't have access to the full data of the poster, but this was the published study that I had talked about in the last slide. So, and you are absolutely right. So in the cis5FU arm, the dose of platinum is 100 and 5FU is 800. But in the TPC, the paclitaxel was 150, the cisplatin was 60. So definitely a difference. And CAPE was 1000. And in terms of adverse events, actually this study showed no difference in adverse events. So the grade 3, grade 4 adverse events and late onset toxicities were both exactly the same. So so this is the TPC arm, so 57.6 acute. And in the PF arm, it was 65.8. 13.6 late versus 17.9. So almost exactly the same, or maybe numerically a bit higher in the doublet. So I don't know. At least in this study, there was no difference in toxicities.
Thanks.
Dr. Sarbani had a comment.
So if you see when they first published the positive NACT trial, that is Young-Soon's, that trial also didn't have an overall survival advantage. It's only over time that you've seen it. And I think the main promise of induction chemotherapy in nasopharyngeal cancer lies in the fact that it's better tolerated, easier to deliver, compliance is better. Whereas for the adjuvant, though the adjuvant trials report superior results, it's only 60%. That's what most trials report. The compliance to the adjuvant phase is only about 60%. So the main thing is about the concurrent CTRT. So if you have to give and tackle micrometastasis, which may be what is most important about advanced stage nasopharyngeal cancer, I think induction would be the way to go. And the last meta-analysis in 2021 clearly says that it's concurrent CTRT, followed by concurrent CTRT plus adjuvant, and then concurrent CTRT, neoadjuvant chemotherapy plus concurrent, the last one that is 2021 with the 26 trials. So, we still are at equipoise if you ask me, but if you want to give induction or adjuvant, I think we've chosen the induction because that's a better way to go now. But the number of drugs that you choose, so as Indranil was asking, I think it's the morbidity or the toxicity that would matter. So if the medical oncologist is comfortable giving the 3-drug regime with the dose regime that we use, ours is again different from Young-Soon's, right? Yeah, it is different. So again, then we see good tolerance, we see an advantage. So we still prefer to do the 3-drug if we can, or the GemCis cisplat.
I totally agree with you, Sarbani. And I think the other point in this whole mix is now the maintenance, maybe capecitabine or metronomic capecitabine. So that perhaps, so there's a, I think the whole field is evolving, and absolutely I agree. We have to evolve with it and use our best judgment.
Thank you, Dr. Vinita.
Next
talk is on challenges in CTV delineation upfront versus post neoadjuvant chemotherapy and guidelines in the carcinoma nasopharynx. The talk will be delivered by Dr. Indranil Malik. He is a senior consultant radiation oncology at Tata Memorial Center, Kolkata. Welcome, Dr. Indranil.
Thank you, Nikhil. Thank you, Trinanjan, for inviting me. I'm really sorry I cannot be there in person. In the next 10 minutes, we are going to quickly go over the challenges in CTV delineation and the guidelines in nasopharyngeal cancer in the upfront and the post-neoadjuvant chemotherapy setting. So we will quickly discuss the 2018 consensus guidelines, the specific issues for certain nodal targets. We will discuss whether we can reduce volumes or doses in the post-NSCT setting and how to go about it. And we'll quickly have a slide on elective doses, which are a very interesting topic. We are not going to cover re-radiation or adaptive radiotherapy. So very quickly, we know that with time, the results in nasopharyngeal cancer has greatly improved. And at the moment, even for stage 3, stage 4 disease, the local control, disease-free survival, and overall survival are all more than 70 to 80%. Crucial and really the foundation of this success lies in the evolution of imaging. With the MRI scans, we are now able to detect very accurately local disease extension into the parapharyngeal tissues and surrounding neural structures. The PET-CT allows more sensitivity and specificity for nodal and distant metastases. Even for nodal metastases, as I mentioned in the last slide, advanced imaging helps. We have papers from several institutions which show that higher nodal volumes are better, nodal infiltrations are better identified on MRI scans. And, there is a tendency of spread beyond the conventional boundaries of the nodal regions, especially in the level 5 and the high level 2. So we also know that with time, 2D, 3D, and IMRT treatments have evolved. With the evolution of 3D over 2D, there was a significant benefit in local regional control. With the addition of IMRT, that improved slightly, but the distant failure rates dropped. The 5-year disease-specific survival is now in the range of 85% in the IMRT era. And with IMRT, the neurological toxicity rates are down to less than 2%. Therefore, with IMRT as the basic standard, we really need to identify our target volumes accurately. Till 2018, we had, conventional, traditional, suggestions for target delineation. For the local targets, we knew that the usual treatment was the whole nasopharynx with a margin. For the CTV2 and CTV3 surrounding regions, which I won't go into a lot of detail about considering the time, we would cover the surrounding regions. And for the nodal target volumes, we had Gregoire's guidelines, which very simply, whether for N0, N1 or N2, N3 disease, advocated for the elective radiation of levels 2 to 5 and the retropharyngeal nodes. So there was no difference. 1B was omitted, usually unless specific situations arose. We know that without a very specific guideline, there was a possibility of inter-observer variation, and this has been documented in this study from China, which shows that there were considerable differences amongst 10 candidate oncologists who contoured versus a standard contour. And there were differences in the volumes and in the coefficient of variation and the ratio between the standard deviation and the average. So with this in mind, the 2018 consensus guidelines are a great boon because they are expert consensus guidelines looking into the patterns of spread and the patterns of failure in these in nasopharyngeal cancer. So in terms of the primary CTV, the current guideline suggests that you contour the GTV primary, usually taking into account or often with fusion, with MRI, with a 5 millimeter margin. You could include the whole nasopharynx if that is your usual practice. And in terms of providing a margin to the GTV, the margin can be reduced to up to 1 millimeter if it is in close proximity to the OARs. In terms of a more elective subclinical CTV, it is the GTV with a 10 millimeter margin, plus the whole nasopharynx, plus at least 5 millimeter anterior anteriorly into the choana and 5 millimeter of the posterior maxillary sinus. You would include the vomer, foramina ovale, rotundum, lacerum, and petrous apex. You would include the ipsilateral cavernous sinus if it was T3, T4. You would include the pterygoid fossa and cover the parapharyngeal space fully. You would include the sphenoid sinus, inferior half if it was T1, T2, or fully if it was T3, T4, and include the clivus, if anterior 1/3 if there was no invasion, but fully if there was invasion into the clivus. If the tumor, again, is close to the critical OAR, the CTV P2 would be at least 2 millimeters outside the GTVP. Now, there is less ambiguity and less controversy in the primary CTV. However, there is a bit more controversy in terms of the patterns of nodal metastases. And this is a meta-analysis showing the patterns of nodal metastases in nasopharyngeal cancer. As you can see, about 85% in this meta-analysis had nodal metastases. The retropharyngeal lymph nodes and the level 2 nodes are the most commonly involved, followed by the level 3, 5, and 4. There is considerably less involvement of the supraclavicular fossa, 1B, level 6 parotid nodes, and the level 1A. So coming to level 1B, this is a summary table from an excellent review by Tong et al. Published in 2021, which showed that in the analyses done for level 1B failures in patients where 1B was not included, the failure rates are generally very low. And even in the study by Lee et al., which included high-risk patients, the failure rates by the omission of level 1B was only 1.6%. And in this study, however, they did point out that in practice, even if you leave out 1B, you do get an accidental dose to the 1B, which is around 50 gray in more than 60% of the patients. And but even by leaving out 1B, you actually do irradiate the submandibular glands. So the real benefit of leaving out 1B is probably lower oral cavity mucosal dose. In terms of what is defined by risk factors or high risk or low risk patients, generally larger level 2 nodes, extracapsular extension, oropharyngeal involvement, or bilateral nodes are considered to be high risk. In terms of lower neck nodes, in N0 or N1 limited to the retropharyngeal nodes, again, there have been numerous analyses which show that the rate of nodal metastases in these regions, or the rate of failure in these regions, is extremely low, definitely less than 2% in all the studies. And therefore, there is a strong case for omitting these nodes in patients where this is not involved. In fact, there is a randomized clinical trial comparing prophylactic upper versus whole neck radiation in node-negative nasopharyngeal cancer. And this study in 301 patients showed no nodal failures in any group. So there is a support for omitting these nodes. In terms of upper neck nodal extent, based on patterns of nodal spread and failure, the upper level 2B should be at the cranial border of the C1, not the caudal border. The 7B should be carefully included. And many experts advocate that the posterior belly of the digastric and the anterior space of the sternocleidomastoid should be included in patients who have retropharyngeal lymph node positive or level 2 nodes. So in this diagram, you can see the lateral retropharyngeal nodes, the retrostyloid nodes, and over here, the posterior belly of the digastric, and this is the sternocleidomastoid muscle. So this region needs to be covered and up to the cranial border of the C1. So what do the 2018 consensus guidelines on nodal CTVs say? For the CTV-N1, which is the high risk, it's a GTV-N with a 5 millimeter margin. Consider 10 millimeter if there's radiological extracapsular extension. For the CTV-N2, it is the CTV-N1 with a 5 millimeter margin. Always include the retropharyngeal nodes and ipsilateral one level below the involved nodes. Level 1B is usually not included, but included if 1B node is positive, submandibular gland is involved, there's a level 2 lymph node with extracapsular extension or involvement of structures that drain into 1B, especially the oral cavity, anterior nasal cavity, or the oropharynx. In terms of CTV-N3, this is only this is level 4 and 5B down to the clavicle, is included only when the nodes are positive outside the retropharyngeal region. So the next question we have is, can we reduce the target volumes after neoadjuvant chemotherapy? There is now in 2018 a randomized control trial which tested this hypothesis. This was done in stage 3 to stage 4B patients, 212 patients randomized after neoadjuvant chemotherapy. If you notice the volumes that are used, the dose to the GTV nasopharynx in group A, which included the pre-induction chemotherapy volume, was all the gross primary and nodal disease pre-induction chemotherapy. In group B, it was the gross primary and nodal disease post-induction chemotherapy. They were treated to 70 gray. The GTV-ND, or the nodal disease, was similar in the two arms. The gross nodal disease post-induction chemotherapy, including pre-IC extracapsular regions. The CTV-1 was a margin around the GTV-NX, and the CTV-2 was the elective nodal region. So what happened in effect was that the primary disease post-induction, primary and nodal disease post-induction chemotherapy in group B received a dose of 64 gray instead of 70 gray. So there was a 6 gray dose reduction. So in terms of results, we found that there was no difference. There was no detriment in the 3-year overall survival, progression-free survival, local regional control, or distant metastases. You can see the survival curves which support that. But what about the toxicity and quality of life? They found that the group B had lower doses to normal tissues. So there was a dosimetric benefit. There was better recovery from xerostomia. And there were better QOL scores, mainly in the pain domain, as you can see in the table. However, there were no differences in acute toxicities, which were dominated by hematological toxicities. So that is not surprising. And apart from xerostomia, there was no difference in other late toxicities in the duration of follow-up. So what can we conclude? We can conclude that you can safely reduce the dose moderately to around 64 gray on the basis of the results of this trial. However, the difference will basically be in terms of better xerostomia and slightly better QOL scores in the pain domain. So what do the consensus guidelines of 2018 say about the target volumes after NSCT? They do not give a very detailed comment. They say that there are 2 schools of thought. Careful volume reduction can be considered, but they do have some caveats. They say that it is important to ensure that the pre-induction gross tumor volume is still covered by at least the CTVP2. They caution about skull base involvement, which can be difficult to see the response on the MRI. So we should be careful about making sure that the skull base disease is adequately covered, preferably to pre-induction chemotherapy volumes. And in terms of soft tissue involvement, often leads to displacement of the organs at risk. And therefore, it is the post-induction chemotherapy scans which should be used to delineate the organs at risk. Finally, a quick note on the dose to elective volumes. Here we see that there are several studies going on or reported large observational studies which have shown that lowering the elective nodal doses could be safely performed. There are in fact quite a few studies in nasopharyngeal cancer. These are the two bigger studies of 347 and 446 patients. These are observational retrospective data, which show that the first one gave 36 gray below, about 2 centimeters distal to the lowest involved node. The second one gave 46 gray to all the subclinical regions, and the local regional control rates are comparable, or the regional control rates are comparable with what is reported in literature. And in the second study, they compared it with a smaller cohort of high doses, and they found no difference in any of the oncological outcome parameters. So there is a case of giving a lower dose to the elective nodal volumes. So this is a short summary from my side. Thank you very much. And for any of the students, I'd like to point out some open positions in our department if you're interested. Thank you very much.
Thank you, Dr. Indranil. Next talk is on maintenance treatment in carcinoma nasopharynx. The talk will be given by Dr. Amit Joshi, who is a consultant medical oncologist at Tata Memorial Hospital, Mumbai.
Good morning, everyone. So my today's topic is the role of maintenance therapy in nasopharyngeal carcinoma. So we'll just quickly go through that. Before starting this presentation, I want to highlight regarding the what we call as known as locally advanced or high risk disease, because that is the subgroup where the benefit of adjuvant or the maintenance capacity after the definitive chemotherapy lies. So mostly it's the N2 disease, T4 disease. So this is the subset where the after completion of the planned treatment, the adjuvant or maintenance treatment has helped. So stage 3 and onwards disease. So as discussed by previous speakers, the chemotherapy in nasopharyngeal carcinoma can be considered in various settings that may be in concurrent, neoadjuvant, adjuvant, and palliative chemotherapy. So we, since today's topic is about maintenance therapy, after the completion of adjuvant therapy, let's just quickly discuss about this. So we all know that the induction chemotherapy with either the TPF 3 cycle of DCF followed by CTRT at a dose of 100 mg per meter square with the IMRT, or the second thing which has been commonly used is the cisplatin gemcitabine followed by in a neoadjuvant setting, followed by the cisplatin 100 mg per meter square with IMRT is the current standard of care. Either of this regime is now considered to be the standard of care if we are planning to do neoadjuvant followed by CTRT. So this regime has also shown very good disease control rate, and this paper was published in NEG. Now come to the today's topic, that adjuvant chemotherapy with maintenance capacity. So there were two presentation in 2021. The one was the adjuvant capacity locally advanced nasopharyngeal cancer. This was a normal dose capacity as an adjuvant for high risk nasopharyngeal cancer. So the second abstract was metronomic dosing of capacity in high risk. So both were presented in 2021 ASCO, and this second one, this by Ma et al., this was subsequently published as a full paper in Lancet Oncology. So we will first see the metronomic capacity as an adjuvant therapy, followed by the normal dose capacity in high risk nasopharyngeal cancer. So coming to the trial schema of this study, as I explained you, the patient of a stage 3-4A disease of nasopharyngeal, excluding the T3, T4, N0 or T3, N1. So these patients were excluded. That means the patient, if the T3 disease, then it should be associated with N2 disease, or T4 disease, then N2 should be there. So they have taken the patients who are at very high risk of recurrence, whether the adjuvant maintenance capacity will help those group of the patient. So stage 3-4A, excluding the T3, T4, N0 or T3, N1 patients who completes their treatment, that is the either a neoadjuvant chemo followed by CTRT or CTRT. So within the so this time period is important. So completion of CTRT within 3 to 4 months of completion of CTRT. This patient were divided into two groups. One patient went on receiving the metronomic capecitabine. The dose of capecitabine was taken is 650 mg per meter square twice a day for 1 year. And the standard therapy, that is the clinical observation. So those patients who were in a complete remission, divided into two groups of 650 mg per meter square, and the other group received the standard of care, that is the observation. Coming to the primary endpoint was of this study was the failure-free survival. And failure-free survival was defined as a recurrence, either local recurrence or distance recurrence, or death due to any cause. So local as well as distance recurrence as well as death due to any cause was the primary endpoint for this study, and this point is defined as failure-free survival. This paper was subsequently published in the Lancet in 2021, and the last number of patient study, around 406 patients were randomly assigned, around 200 patients to the metronomic capecitabine and around 200 patients to the intention to the standard therapy, that is the observation following the completion of CTRT. So 204 patients into metronomic capecitabine and 202 patients to the standard observation. If you compare these two groups, the metronomic capecitabine, if you see, so the most important point for our discussion is the patient in the stage 3 and stage 4 and the induction chemotherapy. If you see this group, around 2/3 of patients received the induction chemotherapy. That means 158 patients in the metronomic capecitabine and 158 in the observation received some sort new adjuvant chemotherapy, and this was well balanced. Similarly, the type of chemotherapy was also balanced. The most common induction chemotherapy used at that point of time was docetaxel cisplatin in more than 2/3 of the patient, and this was also balanced between the metronomic capecitabine and the standard observation in both groups. Coming to the result of this study, the primary endpoint, as I told you, failure-free survival, which was the either local recurrence or a distance recurrence or death due to any cause. So at the end of the 3-year follow-up, the metronomic capecitabine, the 3-year failure-free survival was around 85% compared to the standard observation was around 75%. And this turned out to be in the hazard ratio of 0.5. So there is a 50% reduction in the either local recurrence or a distance recurrence or death with the use of metronomic capecitabine for 1 year. So hence this study was considered to be a positive study for a metronomic capecitabine in terms of the failure-free survival. The other important endpoint of this study was the overall survival. If you see the results, the metronomic capecitabine, the blue one, the 3-year survival was around 93% compared to the standard treatment, and the p-value was again significant. So it has not only improved the failure-free survival, but it also had improvement in the overall survival with the use of metronomic capecitabine after completion of CTRT. The other endpoint of failure-free survival and local regional failure-free survival, both were favorable in the metronomic capecitabine with a p-value of 0.014 and 0.041 for the distance failure-free survival. So that means with the use of the maintenance capecitabine at a metronomic dosing of 650 mg per meter square BD for 1 year, not in terms of the failure-free survival, it also benefited in terms of the survival. Coming to the various subgroup, if you see the p-value, all of them significant. So whether the patient has received the induction chemotherapy or not, both groups benefited in terms of the failure-free survival. And the second question, which was most important, is the toxicity. So if you see the toxicity in the metronomic adjuvant, toxicity which was seen is, and as was expected, around 10% patient developed the grade 3 hand-foot syndrome, and around 3% patient develop some sort of this, since the dose was less compared to the standard dose of 1000 mg per meter square or 1250, which is used commonly. The hematological toxicity was very, very less. The only significant toxicity was the hand-foot syndrome, which is seen in around 10% of that grade 3 toxicity. So that means it's fairly well tolerated. If we follow the patient carefully, this toxicity can be easily observed, and subsequently dose modification can be done in this group of the patients. So this was the first study of a metronomic maintenance capecitabine. In the same ASCO, there was another study of a standard dose of capecitabine as a maintenance, and the inclusion criteria was a little bit different. They also included the T3, T4 tumor with one of the following. So stage 3, 4B with one of the following, either T3, T4 or N2DG, or EBV titer, gross tumor volume, and the SUV uptake. So all, and the tumor size, neck node. So the inclusion criteria was a little bit broader than the initial study, and the patient were divided into capecitabine maintenance 1000 mg per minute for 8 cycles. That is important. In the previously metronomic maintenance, the therapy was given for 1 year, whereas in the full dose, that is 1000 mg per meter square, 2 weekly on, 1 weekly off, this was done for only 8 cycles. So similarly, the patient, one group of the patient received adjuvant capecitabine, and the other group received the standard care, that is the observation. So the result of this similarly, the failure-free survival, again, the patient who received the adjuvant capecitabine at full dose, like in previous study, there was a clear-cut benefit in terms of the failure-free survival. In the 3-year failure-free survival was around 88% in the adjuvant capecitabine group, compared to the standard observation around 48%. Similarly, the in this study, still the OS data is not mature, and it has not shown that benefit in terms of OS. The other benefit in terms of the adjuvant capecitabine full dose. So with the result of these 2 large studies, what we can conclude that patients who are receiving NACT followed by CTRT, it is still standard of care. So I think with the availability of the 2 large randomized trial, the patient who receive NACT for a locally advanced disease, this regime, that is NACT followed by CTRT, followed by maintenance capecitabine, either in a metronomic dosing or a standard 1000 mg per meter square, 2 weekly on, 1 weekly off for 8 cycles, is the current standard of care. And this should be integrated in day-to-day management of this patient. With this, we are still awaiting the full paper of the second public presentation, but still the first publication has clearly shown the benefit. Even if you go to the NCCN line, there is some sort of adjuvant chemotherapy in terms of the has come into the picture. So this was the role of the maintenance capecitabine in an adjuvant setting. The second scenario where the maintenance capecitabine has come into the role is the metastatic carcinoma nasopharynx. So we all know that patients who present with a metastatic disease, mostly the platinum-based the chemotherapy, either with combination of 5-fluorouracil or with combination of taxane or with combination of gemcitabine, is being very commonly used. There was a randomized trial of a cisplatin gemcitabine versus cisplatin 5-FU in a patient of a metastatic nasopharynx. And this trial has clearly shown that there is a clear-cut benefit of the cisplatin gemcitabine in terms, not only in terms of the survival, but in terms of the toxicity. So this trial has established the cisplatin gemcitabine as one of the standard treatment for a metastatic nasopharyngeal carcinoma. Now comes there are various chemotherapy regime which have been used to the 3-drug combination with the DFS of around 6 to 7 months and an OS benefit of around 20 to 30 months in various combinations. So that means the standard treatment for a metastatic nasopharynx is with the combination of a cisplatin chemotherapy. The most widely used, and as per the data, the cisplatin gemcitabine is the most benefited and less toxic regime in terms of that. Is there any in this scenario, patient who received the initial chemotherapy has a stabilization of the disease? The usual standard of care was to observe And when the disease comes back, then chemotherapy to be used. But with publication published in that role of versus just care in the management of patient with metastatic nasopharyngeal carcinoma. So patient metastatic nasopharyngeal carcinoma who completed the treatment, usual care, 104 patients were randomized into so hello. Sir, am I audible?
No, sir. The slides are not visible. Sir, I guess in the interest of time, we will conclude the session. So the next talk was from Dr. Gautam Panda. We will take that before lunch. He also had some issue in joining online. So we'll break for tea now for 10 minutes. We'll come back and start with science presentation.
Is it visible now? Hello? Can I ask the organizers to, is the slides visible? Hello, Vijay, is it visible?
सर वो टेक्निकल इश्यूज हो गया है सर, तो सेशन कंक्लूड हो गया है सर.
ओह,
हेलो, ओके, सॉरी सर.
नहीं बट मतलब इट वाज फ्रॉम देयर एंड और कि यहाँ से तो अच्छा, ओके, नो इश्यूज.
आपके एंड से होगा सर.
चलेगा, इट्स ओके, नो इश्यू.
So we can start the session post tea break. So we'll begin with a continuation of the nasopharynx session. So the talk now going to be by Dr. Sayan Paul, our good friend and a senior radiation oncologist from Apollo, Kolkata. He'll be talking on follow-up in carcinoma nasopharynx. Sayan.
Good morning. I thank the organizers, especially Dr. Trinaranjan and Dr. Nikhil, for inviting me here today. So after the extensive talk on the management of nasopharynx, let us discuss a bit about the follow-up in nasopharyngeal carcinoma. So let us see what the guideline says, mainly the ESMO and the NCCN guidelines. So the latest ESMO guidelines 2020 says that imaging should be done 3 months after IMRT, then every 6 months after the 3rd year for T2, T4 disease, or MRI or PET-CT scan. And the nasal examination should be done endoscopic assessment every 3 months in the 1st year, every 6 months in the 2nd and 3rd year, and annually thereafter for the first 5 years. And plasma EBV DNA 1 to 4 weeks after IMRT, then every year should be done. And thyroid and pituitary assessment, thyroid function assessment every year, pituitary function assessment in case there is any signs and symptoms of pituitary deficiency. And let's see what the NCCN says. It is actually the general guideline for the head and neck cancers. So history and physical examination, which includes a complete head and neck examination and mirror and fiber optic examination. First year, every 1 to 3 months. Year 2, every 2 to 6 months. Year 3 to 5, every 4 to 8 months. And in more than 5 years, it is every 12 months or yearly. So imaging should be done. Thyroid stimulating hormone should be tested every 6 to 12 months if neck is irradiated. Dental evaluation for oral cavity, that is not in our topic. So consider EBV DNA monitoring for nasopharyngeal cancer. Supportive care and rehabilitation, speech and hearing, swallowing evaluation and rehabilitation, nutritional evaluation and rehabilitation as clinically indicated until nutritional status is stabilized, smoking cessation, alcohol counseling as clinically indicated, ongoing surveillance for depression, and lymphedema evaluation and rehabilitation as clinically indicated, and integration of survivorship care and care plan within 1 year. So in the flow chart, they have said after systemic therapy, RT or CT-RT, after 4 to 8 weeks, clinical assessment as appropriate. If there is a residual disease, then they have advised for imaging, CT or MRI or FDG PET. And if there is a confirmed residual disease, then should treat accordingly. And if there is a response, then you need to assess the extent of disease or distant metastasis with FDG PET CT scan at minimum of 12 weeks time. If FDG PET negative, it's observation. If it is equivocal, you should observe and repeat FDG PET or CT every 3 to 6 months. And if FDG is positive, then they have advised another imaging CT or MRI and then biopsy and treat accordingly. And in CT is done for primary and neck or MRI with contrast at 8 to 12 weeks. If imaging is positive, then you have to repeat with FDG PET CT scan. On imaging is negative, you can go for observation. So now imaging, which imaging to order? So there has been comparison of FDG PET CT scan, MRI, and other diagnostic imaging tools. There has been many studies on that. Because I don't have much time, I will just show the meta-analysis. So in this meta-analysis, and meta-analysis by Jambo Wee et al. So they have shown that the pool specificity for FDG PET CT scan is better than MRI. So sensitivity of MRI and metabolic imaging are similar, whereas the specificity of PET CT is higher. So helps in differentiation between post-radiation changes and recurrent tumors. So when we do the imaging, when to do the imaging, and when we expect a complete metabolic response. So there has been studies, and they have shown that there is a study by Wen Fei Lee with 556 patients with nasopharyngeal carcinoma treated with IMRT, because nowadays we are treating with IMRT only nasopharynx. And they have seen that nearly half of the patients with partial response at 3 to 4 months achieve a complete clinical response by 6 to 9 months. And delayed complete response is not a poor prognosticator, because the overall survival and the failure-free survival is same compared to early clinical response and the delayed clinical response. That's why they have suggested a later assessment of complete clinical response at 6 to 9 months after IMRT, which is acceptable. So delayed clinical complete response to IMRT at 6 to 9 months do not jeopardize the patient's prognosis. The risk of recurrence in the era of IMRT seems to have a bimodal behavior, one after 1.5 years following the end of the treatment, mainly for T3, T4, N2, N3 diseases, and one after 3.5 years for all T stages and N2, N3 disease. So what the follow-up protocol they have used in this trial is a physical examination, EBV virus DNA assay, nasopharyngeal fiber optic endoscopy, nasopharyngeal and neck MRI, chest CT scan or CT, X-ray or CT, liver scan, whole body bone scan, and locoregional recurrence or distant metastasis were recommended to be confirmed by FNEC or biopsy. For recurrence or metastasis at inaccessible sites, clinical diagnosis was accepted if classical changes were observed on at least 2 imaging methods with or without clinical symptoms, including a FDG PET CT scan, MRI or CT scan, abdominal sonography, and whole body bone scan. So now let's see the ESMO recommendation. The first radiological examination should be done at 3 months after treatment completion. Further follow-up for patients include periodic every 3 months in the first year, every 6 months in the second and third year, and annually thereafter for the first 5 years. Examination of the nasopharynx and neck, cranial nerve function, and evaluation of systemic complaints to identify distant metastasis. For T2, T4 tumors, MRI might be used on a 6-monthly basis to evaluate the nasopharynx and the base of the skull, at least for the first 3 years after treatment. PET imaging may be used in case of equivocal imaging results. Plasma IBB DNA is a promising marker for the diagnosis of recurrence and should be evaluated at least every year. Evaluation of thyroid function in patients who have received RT to the neck is recommended annually. Pituitary function should also be evaluated periodically or in case of signs and symptoms of pituitary deficiency. Attention should be paid to the recognition of late treatment-related toxicities, mainly consisting of xerostomia, trismus, hearing impairment, temporal lobe necrosis, cognitive impairment, cranial nerve injuries, and second primary tumor possibly related to radiotherapy. The employment of IMRT instead of 2D RT has substantially reduced the late events with the exception of temporal lobe necrosis. Significant factors affecting the risk of temporal lobe necrosis include T-stage, the addition of chemotherapy, and the maximal RT dose to the temporal lobe. So now let us discuss a little bit about the plasma EBV DNA, because as we have seen, the surveillance protocol is quite extensive and quite costly. And in a third world country, the cost will be quite high if we do this imaging regularly. So can we get a marker which can guide us for the surveillance of nasopharyngeal cancers after the treatment? So as early as in 1919, Lowe et al. Had published one article and have shown a quantitative and temporal correlation between the circulating cell-free EB virus DNA and tumor recurrence in nasopharyngeal carcinoma. So they have shown that this is the first one when they use the RT-PCR technique to find the relationship between the level of EBV DNA and tumor recurrence. And the results showed that the level of plasma EBV DNA, the median copy number is 32,350 copies per ml. In 10 patients who had recurrence was significantly higher than the 15 patients who had a continued remission at 2 years. And their median copy number was 0 copies per ml. And the p-value was significant. These results indicated that the level of plasma EBV DNA could be used as a reliable indicator for the diagnosis of nasopharyngeal carcinoma recurrence or metastasis. So there is a meta-analysis recently published in 2019, and which included 25 studies who have tried to correlate EB virus DNA and the recurrence in NPC. And they have shown that the combined sensitivity is 0.86 and the combined specificity is 0.89, which is quite encouraging. And they have concluded that this currently available data provided reliable evidence that the level of plasma EBV DNA as a tumor marker for NPC with high sensitivity and good specificity has a high diagnostic efficacy in the diagnosis of recurrence or metastatic NPC. However, it is important to note that the level of plasma EBV DNA cannot replace nasopharyngeal endoscopy and imaging examination as a gold standard for the diagnosis of recurrence and metastatic NPC. So what it can help in the clinic, the frequency of nasopharyngeal endoscopy and imaging examination can be appropriately reduced according to the level of plasma EBV DNA, and the interval time of the above examination can be extended, which is a simple, effective, and economical diagnostic method during the follow-up of NPC. These measures are of great significance in improving the therapeutic effect and prognosis of the patient with malignant NPC. I'll take just 1 minute's time. This is the latest guideline from a Spanish group. Now, I'm skipping this because it's almost similar and I don't have time also. This is an interesting article. So I just want to highlight this. It's a 743 nasopharyngeal cancer patients data. And they have seen that if we follow the NCCN guidelines 2015 or the ESMO guideline 2012, so it can detect only 31.5% of the recurrences among the 743 patients. There was 168 recurrences, and the ESMO guideline can detect only 27.4%. So they have concluded that the surveillance guideline from NCCN and ESMO do not fully capture the recurrence of NPC after radical treatment. However, they have done a cost analysis, and extensive surveillance to capture 95% of the recurrence event would lead to a higher cost, while the cost per recurrence detected was much less than that incurred following the established guidelines. So detecting recurrence in patients with earlier disease was much more costly than those with advanced disease. Therefore, the direction of further research should be to identify personalized review strategies to balance the benefit of patients with medical cost. So long-term survivorship and toxicity issues will be discussed by the next speaker. So thank you all for your time, and I acknowledge Dr. Sarvani Ghosh-Laskar, who has guided me for preparing this presentation, and the team Apollo Oncology. Thank you.
Thank you, Sayan. It was wonderful to see the Van Gogh picture as well. So the next talk is by Dr. Monali. She's associate professor in radiation oncology TMH. She'll be talking on long-term radiation-related morbidities after treatment of carcinoma nasopharynx. Monali.
Thank you, Dr. Triranjan. Thank you, organizers for inviting me here. And already Dr. Sayan has explained about how to follow up and what are the important things and following up for the toxicities. So as it has been already been discussed several times that nasopharyngeal carcinoma, they are unique in terms of its location, adjacent to very critical structures, in terms of the failure, in terms of sensitivity to treatment. And this is the only site which has improved survival with a change of a radiation technique to IMRT. And the survival is increased up to 70 to 80%. So as the survival is increased, these patients are more likely to experience late and long-term toxicities. So this is the dream of the radiation oncologist, to get a maximum probability of tumor control with less complications. But despite all the attempts, the patients experience certain acute and late toxicities. These non-neural toxicities has been always discussed in different head neck cancer, so I'll not be covering that. So the toxicities which are unique to nasopharyngeal cancers, these are neurooptic and the endocrine toxicities. It could be cerebral radiation necrosis, of which most common is the temporal lobe necrosis, neurocognitive impairment, brainstem injury, cranial nerve palsy, ophthalmic toxicity, ototoxicity, carotid artery stenosis, endocrine toxicity, and many more. So as you see, it's this kind of tumors, they present with a very advanced stage sometimes, and it is very close to the critical structure. So it is bound to happen, these toxicities. So the temporal lobe toxicity, this is the most late toxicity of radiation. But however, with the implementation of IMRT, the toxicity has been decreasing. And with IMRT, the temporal lobe necrosis is mostly confined to ipsilateral side compared to bilateral in 3D CRT era. And the mean latency time is 4 years or more, and it increases with further follow-up. The accurate incidence is very difficult to define because the different follow-up schedules in different studies. The symptoms may vary from dizziness, lethargy, debilitation, personality change to more serious epileptic attacks, cognitive failure, and it can affect the quality of life significantly. So the three models, the vascular injury, the progenitor cell injury, and the immune inflammation, all in combination play a role in the development of the temporal lobe necrosis. So as you already know, the radiation technique, the radiation parameters are the most important. The maximum dose, the volume receiving the specific dose, the dose for fraction are important. And it is more commonly seen in patients with T3, T4 advanced tumors and after RT. There are several non-radiation related factors, like the genome-wide association study has shown that the downregulation of CEP128 protein is also associated with a higher chance of temporal lobe necrosis. Chemotherapy is associated with a 5-fold increase, and the targeted therapy cetuximab also has been shown to be associated with increased risk of temporal lobe necrosis. So basically in different studies, when the dose volume parameters has been analyzed, mostly it is focused on the maximum dose to the temporal lobe. But this is an interesting study in which the dose as well as the volume of low dose radiation that is being studied. So the risk of temporal lobe necrosis increases with the increase of the volume, which is receiving more than 70 gray. And the V45, that the volume receiving 45 gray is one of the strongest predictor for the volume of necrosis. When the volume of V45 is less than 15.1 centimeter cube, it is relatively safe, considering the risk of temporal lobe necrosis size less than 5 centimeter cube, which they have considered as a smaller size compared to more than 5 centimeter. So it is very important to adopt the dual strategy, like decreasing the max dose as well as the volume receiving the low dose also. So this is one of our patients. Patient developed temporal lobe necrosis after RT. So MRI is generally done, and there are some characteristic features like homogeneous lesion in the white matter, the finger-like sign, the cyst and round oval lesions. However, the functional MRI, PET and SPECT is also being used to diagnose temporal lobe necrosis. So what are the treatment options? It is basically symptomatic, and the conventional treatment most commonly includes corticosteroids. Generally, oral dexamethasone is being used for about 4 to 6 weeks and gradually tapered over 3 to 4 months. However, in recent studies, the pulse dose intravenous methylprednisolone has been also used for a shorter period, followed by oral corticosteroids. The other options are anticoagulant, hyperbaric oxygen, surgery, but none of them has been proven very useful. And there has been always attempt to apply some novel treatments like the bevacizumab, free radical scavenger, gangliosides, and nerve growth factor. So this is a table which have compared the different treatment options. None of them so really very useful. All these symptoms, they are not completely reversible. They provide a temporary relief. Bevacizumab has shown to partially reverse the symptoms. So if you classify these patients, like for asymptomatic patients with a radiological evidence of necrosis can be observed closely with follow-up and imaging. Those with mild symptomatic and clear evidence of progression can be treated with steroid and close follow-up. Those patients symptomatic but unresponsive to the conventional treatment, bevacizumab could be tried. And the patients who are totally unresponsive to the medical treatment, surgical intervention can be used. So another late toxicity is the neurocognitive impairment. This is also related to the radiation dose to the temporal lobe. This is in this study, the patients treated with IMRT and have at least 4 years of follow-up has been longitudinally evaluated using the Montreal Cognitive Assessment Scale, and the other symptom report by the patient and family also been evaluated, and the quality of life also been evaluated. So the Montreal Cognitive Assessment Scale showed 32% impairment in the neurocognitive in 32% of the patients. There is significant disturbances, post-treatment disturbances as reported by the patient and family in terms of apathy, disinhibition, and executive function. And this has been also correlated with lower quality of life. And this is associated with a temporal lobe dose of greater than 75 gray. So now coming to the cranial nerve palsy, this is again another late complication, and usually the pre-treatment or the cranial nerve palsy or the presentation is an important predictor of subsequent development. Hypoglossal nerve is the most commonly affected. The incidence can vary from 3.7% to 30% over a period of 10 years and subsequently. In this picture, I have shown the tongue atrophy on the left lateral side. So the symptoms would be based on whichever nerve is affected. But however, it is very important to rule out the recurrence also. It is difficult to spare even with IMRT because contouring and giving dose restriction is really difficult. So another late toxicity is a brainstem injury. It has always been thought to be a dreaded complication. This is a beautiful study in which they have shown the evolution dosimetric analysis with followed up with MR. So about 6,200 plus patients they treated between with IMRT in from 2009 to 15 were analyzed when only 24 patients developed brainstem injury with a median latency of 14.5 months. And about 40% were symptomatic. The best part was that with subsequent follow-up, more than half of the patients, they have a complete remission and about 20% have a partial remission, irrespective of any symptomatic treatment. So in the dosimetric analysis, they showed the patients, in patients who received a Dmax of more than 67.4 gray was significantly more likely to develop brainstem injury. So this probably provides a room for a relaxation of constraint to the brainstem, but it needs to be proven and studied further. So there are different late toxicities. It could range from radiation-induced optic neuropathy, radiation retinopathy, cataract, corneal ulcer, tearing, and light sensitivity. The radiation-induced optic neuropathy is an acute, rapid, profound, irreversible visual loss in one or both eyes. The latency period can range from 3 months to up to 8 years. And it will again depends upon the radiation dose. This is basically because of the ischemic necrosis of the anterior visual pathway because the tolerance is 50 gray and not in more than 2 gray per fraction. The most severely affected eye, they have a final visual acuity of less than 20 to 200, and some may progress into complete blindness, as it can be detected with different methods like ophthalmoscopy, optical coherence tomography, electrophysiology. So this is a very old study, but this has beautifully analyzed the radiation dose as well as the dose per fraction. So with a dose per fraction of less than 1.9 gray, there is significant reduction of the radiation induced optic neuropathy. So that needs to be kept in mind when it is difficult to achieve the dose constraint. So as it is known, the radiation dose fraction are very important. Along with concurrent chemotherapy, female gender, they are associated with increased risk of radiation-induced optic neuropathy. So the treatment per se, there is no definitive treatment. All the different options has been tried, but VEGF inhibitors like bevacizumab, systemic or intravitreal, they have shown to improve of the color vision and stabilization at a follow-up of 3 years. So these are no randomized trials. These are few case reports and case series they have seen. And the ACE inhibitors, they have been tried only preclinical, not in the clinical setting. So similarly, radiation retinopathy, the risk of retinopathy increases steeply with doses more than 50 gray in 5 weeks. It can develop from 3 years to 15 years, and even in cases after 3 months when the radiation dose is really, really high. And the risk increases with coexistent diabetic retinopathy, hypertension, collagen vascular disease, simultaneous chemotherapy, and pregnancy. And the different treatment options tried, the intravitreal anti-VEGF therapy, intravitreal steroids, and laser photocoagulation. So coming to the endocrine toxicity, Dr. Nalini was supposed to cover, but in her absence, I'm going to give a short overview, not in detail. So endocrine toxicity is one of the important toxicities that is especially important for childhood nasopharyngeal cancers. As you know, radiation causes dysfunction of the hypothalamic pituitary axis and subsequent release of the releasing hormones, which in the downstream pathway affect the other hormones released at the periphery. So it occurs about 80% of cases, may occur even doses as low as 20 gray, and it is variable time course. And patient, the hormonal levels may be abnormal even before detection of any symptoms. And the prevalence, it increases as the year passes by. So this is a systematic review meta-analysis which have included both nasopharynx and intracerebral tumors. I have just shown the data of patients treated with nasopharynx. So the prevalence was up to 37 to 77%, and it increases as the follow-up period increases. The growth hormone is the most commonly detected endocrine abnormality, and it is the earliest detected one, and which is followed by gonadotropin releasing hormone, prolactin, ACTH, and central hypothyroidism. So this is a short overview of the symptoms of growth hormone deficiency. This is basically important in children because it affects the growth and the final stature. In adults, it may lead to a poor quality of life, decreased bone mineral density, tiredness, and all that. Similarly, gonadotropin releasing hormone, it might be subclinical, or maybe there is a decrease in the circulating sex hormones, delayed puberty, and linear growth in children. In adults, this is encountered more frequently and lead to the decreased sexual activity, tiredness, and reduced quality of life. So how we are going to manage it is actually you need to evaluate in nasopharynx cancer specifically. Pre-treatment evaluation of the endocrine function is very, very essential to establish a baseline and to see if there is any pre-existing endocrine dysfunction. And it should be planned properly post-treatment follow for long-term monitoring in the children, adults, so that timely detection and intervention can be done. So insulin tolerance test is the gold standard for evaluating growth hormone deficiency. And it should not be done until the time it is feasible to give growth hormone replacement. Typically, the period is 1 to 3 years, considering there is an increased risk of tumor growth. And it is very important, childhood cancers, childhood nasopharyngeal carcinoma. And if a normal insulin tolerant test 10 years after radiation exposure generally eliminates the further need of testing, annual testing. And for adults, the growth hormones like FSH, LHS can be done for the testing. So another endocrine toxicity is radiation-induced hypothyroidism, which is most commonly encountered in clinic in other head neck cancer, as well as nasopharyngeal cancer. However, in nasopharyngeal cancer, there is a central component, and the hypothalamus, which releases the thyrotropin releasing hormone and ultimately releases T4 in the peripheral tissue, which is converted to T3, the most active form. And the incidence varies from 14 to 54% depending upon the mean thyroid doses, and usually occurs, the maximum hypothyroidism occurs within the first 2 years. It may lead to increased risk of heart disease, myxedema, and birth defects in pregnant. So this is the two studies in the same group has done two different studies to assess what is the cause and what is happening with the patients who are developing hypothyroidism. So generally there is a damage to the follicular cells, and there is a shrinkage of thyroid gland up to 20% in the first 6 months, and subsequently it can shrink up to 40% in the next 30 months. Capsular fibrosis, iodine deficiency may occur, and there is also an autoimmune component. So the general treatment is thyroid supplement, which is probably the most common toxicity that can be managed easily. This is just to show that, well, IMRT is shown to improve the toxicity in other different toxicities, but for thyroid toxicity, 3D CRT is better because of the midline block, and there is a lower dose. So ototoxicity, another toxicity encountered in nasopharyngeal cancer patient, this chance is relatively higher. It is non-fatal, but it affects the psychological status and quality of life. Both sensory and conductive component happens. It damages to the sensory hair cell, microcirculation, and impair the auditory pathway. So this will be probably more detail discussed by Dr. Nandini. And for radiation induced, initially the frequencies at the higher side, then subsequently the threshold for this, it happens in a threshold for the speech frequency. So there is no effective treatment. Aim is to monitor for the early detection, preventing the progression and permanent damage, and rehabilitation. So another important toxicity is carotid artery stenosis. In general population, it is 4.2%. However, post-RT, it ranges up to 30%. We can see the carotid artery is at risk in our entire course. So this is a meta-analysis which showed RT significantly increases the incidence of overall stenosis, and significant stenosis has a greater incidence. And it has shown that it affects all the segments: common carotid, external carotid, carotid bulb, internal carotid, or combination of both. And recommendation for screening is given. So we should not forget the radiation-induced second malignancies. The incidence is less, but the radiation-induced malignancies, it could be osteosarcoma, soft tissue sarcoma. Now there has been also reports of increased incidence of tongue cancers, and there is also risk of nose and nasal cavity cancer. So this is a big data platform-based analysis of a large number of nasopharyngeal cancer survivors. This includes all, both radiation as well as chemotherapy. And the latency for the start of IMRT is about 37 months. It can range up to 102 months. And older male smoking history are the more common risk factor, with the lung cancer is the most common second primary. So as you see, there is a lot of late toxicities and really less to manage. There is less options are available. So what can we do? We can try to reduce the toxicity. That's the prevention is the best for this. There are different ways we can use advanced technique, control the RT dose, target volume, proton therapy, and adaptive. I'll go one by one. So RT technique, it has already been established. This is a randomized trial, and as well as the subsequent meta-analysis, which have shown that using IMRT reduces the late xerostomia, trismus, temporal lobe toxicities. And regarding radiation dose constant, there are contact guidelines. However, for nasopharynx, there are specific guidelines has been published, and here they have given out priority, which organs should be given priority when you are stuck at the planning, which how to control the dose. So the brainstem, spinal cord, optic chiasma, they are the #1 priority, followed by temporal lobe, followed by optic nerve, eyeball, pituitary, and hypothalamus. Thyroid and cochlea is given the next priority. And target volume delineation, Dr. Indranil has already discussed about that. Just to highlight that they have this uniform guideline, so there is no discrepancy in that. And when there is a critical OR is there, so for high dose clinical target volume, 1 millimeter margin should be enough, should be given. And for the intermediate dose, 2 millimeter can be given. Just 1 minute. And there is also recommendation for contouring. So there is no discrepancy, and you can do it in a better way. So proton therapy, this is a systematic review of proton therapy in nasopharyngeal cancer. There is definitive reduction in the acute toxicity, lower feeding tube rates, and lower mucositis. However, the long-term toxicity, we need to wait for that to come up to these toxicities because they really appear quite late. So adaptive radiotherapy is one of the options, though it is not generally practiced, not practically feasible to do, but this is one of the options. This is a 3-phase adaptive radiation therapy, which has shown that adaptive planning was done in 3 phases and lead to a decreased max dose to the brainstem temporal lobe, also to the optic nerves. So these are the different options. So to conclude, the incidence of the late neuro-optic and endocrine toxicity is low and decreases with improvement of the newer radiation technique. Pre-treatment evaluation is very essential to establish a baseline. Appropriate target and OAR delineation is crucial, and as well as the dose constraint. Treatment is feasible, though in few cases can reduce the symptom burden, and prevention is key. Thank you very much for the patient.
So moving on, the next talk would be by Dr. Nandini Menon, consultant medical oncologist at TMH Mumbai. She'll be talking on long-term chemotherapy-related morbidity in carcinoma nasopharynx. Nandini.
Good morning, everyone. So without wasting much time, I'll move to the topic. The topic allotted to me today is chemotherapy-related late morbidity in nasopharyngeal carcinoma. And the previous speaker, Dr. Monali, had already discussed most of the toxicities. Here, I'll just focus on specific toxicities which are related to chemotherapy. We know that the treatment of nasopharyngeal carcinoma is always a multimodality approach, and hence a lot of patients will have toxicities of both the approaches as well as cumulative toxicities and synergistic toxicities of both. These are the common chemotherapy agents that we use in routine practice in nasopharyngeal carcinoma, and a large number of toxicities are related to the platinum, which is a backbone of treatment of nasopharyngeal carcinoma. So the late toxicities which are seen specific to chemotherapy include nephrotoxicity, neurotoxicity, predominantly ototoxicity and peripheral neuropathy. Also autonomic dysfunction in terms of autonomic neuropathy, metabolic syndrome and cardiovascular toxicities. And one thing which I've forgotten to put on the slide is infertility and endocrine dysfunction. So this is a paper which was published where patients who were randomized to induction chemo versus no induction chemo and received chemo radiation. This was a long-term toxicity analysis of that, which was published. And if you look at all the toxicities here, the most common are hearing loss, bone necrosis, cranial nerve involvement, trismus, eye damage, and dysphagia, of which auditory or hearing toxicities are significant, were similar in both groups, that is those who received induction chemotherapy and those who did not. And here, these patients received significant amount of cisplatin, and the grade 3 or higher toxicities were around the tune of 14 and 13%. And this was seen in both the groups. So we know that toxicities related to chemotherapy are significant. A large number of long-term survivors of nasopharyngeal carcinoma will live with the toxicities for a long period of time. Multiple studies in different chemotherapy interventions, that is the use of chemoradiation with or without adjuvant, neoadjuvant therapy, have reported toxicities in long-term analysis. And most of them have reported on xerostomia radiation, temporal lobe necrosis, neuropathies, cranial neuropathies, and hearing loss. Significantly, most of these are radiation-related toxicities. Some, like the one which has induction gemcitabine cisplatin, has also reported on peripheral neuropathy, which was slightly higher in those who received induction chemotherapy. So this was the NPC update, which was in 2015. And they noted that most of the long-term toxicities in patients with nasopharyngeal carcinomas were related to radiotherapy. And only the main cranial nerve palsy and hearing defects were worsened by the use of chemotherapy. However, these did not use the newer, did not include the newer studies with induction chemotherapy. So the first toxicity that is commonly seen in both acute and delayed or late survivors is renal toxicity, and mainly due to platinum, that is cisplatin and carboplatin, that is widely used. These are the manifestations. They present commonly with acute kidney injury and electrolyte imbalances, and some of the rarer things like Fanconi syndrome, tubular acidosis, salt wasting, and also a percentage of patients can develop chronic kidney injury. Multiple mechanisms have been postulated, mainly due to the active species or the reactive, ROS species generated by cisplatin and the damage to the proximal tubule. Certain drug transporters play a role in this. These are anion and cation transporters, which play a role to in the cisplatin uptake by the tubule, and these are predispose the injury to selectively to the proximal tubule. There are also other mechanisms that are postulated, like vasoconstriction in the renal microvasculature leading to ischemic injury, and pro-inflammatory cytokines, which are stimulated by cisplatin. So what are the risk factors for a patient for developing chronic late toxicity because of chemotherapy in patients with nasopharyngeal carcinoma? That is peak plasma free platinum concentrations. Patients who have received prior platinum therapy, especially those who have recurrent disease, patients with poor renal function, and common use of other nephrotoxic drugs. Most commonly in this setting, we use NSAIDs for pain management during concurrent chemoradiation, and they can contribute. This is data from the more recent study of gemcitabine cisplatin as induction therapy. And as you can see that at least 2% to 3% of patients do have nephrotoxic events as late toxicities. That means most of the patients that we treat, we are going to see a small percentage of patients who are not only going to have acute toxicity because of the cisplatin or other platinum compounds, but a percentage who will have chronic kidney injury. So this is another study which also shows that around 0.5% of patients in those receiving adjuvant chemotherapy had nephrotoxicity. Multiple strategies are used to prevent platinum-induced nephrotoxicity with cisplatin, most commonly hydration with saline and avoiding nephrotoxic drugs. There are some debates about the use of mannitol and also the doses and infusion rates of cisplatin. Certain renoprotective drugs that is been studied both for the prevention of nephrotoxicity as well as autotoxicity with cisplatin, such as amifostine, but it is not used anymore and it is not recommended, mostly because there is no significant benefit in multiple studies, and also the toxicities of amifostine, and there is some evidence that there is a possible interference with the anti-tumor efficacy of cisplatin, compromising outcomes, so it is not recommended for use. The second important toxicity that Dr. Manali had already discussed is autotoxicity. And this is very important in patients who are long-term survivors with nasopharyngeal carcinoma, because there are two mechanisms that lead to it. They receive radiation, and that induces damage to the cochlea and the vestibular apparatus, as well as the chemotherapy backbone in nasopharyngeal carcinoma is highly autotoxic. Cisplatin is the most autotoxic, carboplatin is far less. The main mechanism is similar. It is a reactive oxygen species and the DNA damage because of adduct formation. And because the cochlea is a closed system, all the accumulated cisplatin cannot be expelled. And this impaired antioxidant system in that leads to damage to the hair cells and the stria vascularis, which is within the cochlea. So there have been studies in mice models and as well as where they have measured the level of cisplatin, and it is known that platinum can remain for a long time in the cochlea, even indefinitely. And in this mouse model below, they have shown that in various parts of the cochlea, that is the stria vascularis, organ of Corti, and the spiral ganglion, the doses of cisplatin, that is 42 on day 42, that is the end of concurrent chemoradiation, and 60 days later, you can see that the levels of cisplatin have significantly been retained in the stria vascularis, and this is especially sensitive to cisplatin-related damage. So what are the long-term toxicities or the long-term complications of this autological toxicity? One which we commonly see is sensory neural hearing loss, which might present as deafness. It is important to rule out this from the conductive component, which is seen as otitis, serous otitis because of radiation. Some patients might present with tinnitus. Some may present with vestibulopathy, such as dizziness, vertigo, and gait imbalances. So these are various studies which have shown hearing impairment in patients, and even in the older studies, this is one of the older studies by Al-Saraf where chemotherapy was added to radiation in the concurrent and adjuvant setting. And even in these studies, we have seen that around 3 patients here and 9 patients here had a grade 3 ototoxicity. So it is a significant side effect and it has to be noted. And even newer studies have shown, as I mentioned earlier, around 5% of grade 3-4 toxicities and 6% in the standard therapy group of deafness or otitis. So it is an important toxicity that we need to know. I won't go through this slide, I already discussed it previously. But again, hearing deficit was significantly worsened by the addition of platinum chemotherapy in this meta-analysis. So what are the risk factors? Young age or extremes of age, that is very elderly patients, those who have received radiation, poor renal function, and a cumulative dose of platinum compounds if the patient has received treatment earlier. Carboplatin, slightly lower risk. Whether the infusion duration of the platinum compounds alters, we do not know. Some genetic polymorphisms are also responsible. And sodium thiosulfate, for lack of time, there has been a study in the pediatric population with hepatoblastoma, not nasopharyngeal carcinoma, but some benefit with the use of sodium thiosulfate in this population. So these are the guidelines. The only guideline for adolescent and young pediatric patients, and the only recommendation is for sodium thiosulfate. Other thiol group drugs have very poor quality of evidence, or some of them have strong evidence against the use. Peripheral neuropathy is another important complication. I'll quickly finish this. So platinum compounds again damage the dorsal root ganglion and cause apoptosis of the cells. Usually we see the onset of peripheral neuropathy at very high doses, that is more than 300 milligram per meter square. So the patient who has received neoadjuvant and concurrent chemo radiation, or probably in the recurrent setting. And this may happen even after treatment completion. And there may be a coasting effect where the symptoms might worsen after discontinuing cisplatin. There are genetic polymorphisms which are reported that may interfere, and these are for the glutathione synthetase enzymes. And they have noted, this is the data from a testicular cancer population, but they have noted that certain polymorphisms in people predispose them to developing more severe neuropathy, and that is responsible for the interpopulation variation. The other toxicities important are hyperlipidemia and metabolic syndrome that can be found in up to 80% with dyslipidemia and up to 40% with metabolic syndrome. Cardiovascular risk dysfunctions, which are seen in the form of cardiovascular events as well as vasospasm and Raynaud syndrome. Remember that these two can combine, and also endocrine dysfunction seen in patients with nasopharyngeal carcinoma because of cranial radiation or radiation to the neck can add to the dyslipidemia and cardiovascular risk. And it is important to monitor these patients at every follow-up in the long term for these toxicities. A large the reason for this cardiovascular toxicity and dyslipidemia is attributed to cisplatin and the other platinum compounds to a lower extent. So with this, I will conclude, and I would like to thank the organizers for the opportunity. Thank you.
So now we have the panel discussion, and this is one of the moment from someone most of us have learned N to X of nasopharynx and A to Z of nasopharynx is Sharvani ma'am. So I have the proud privilege to call madam to moderate the panel. Madam needs no introduction, so I'm skipping those part. Rather, I call the panelists. So we have an ensemble of radiation, medical, and surgical oncologists. So Dr. Shikha, Dr. Saurav, Dr. Nikhil, and Dr. Sameep, the radiation oncologists in the panel. Dr. Siddharth Turkar, Dr. Prahlad, and Dr. Avinash Talele, the medical oncologist, and Prashant, you're the sole surgical oncologist in this panel discussion. Over to you, ma'am.
Good afternoon, everybody. While we get set for starting the panel discussion and the IT is looked into, I thank the organizers for this invitation, and I would encourage all my panelists, and also if there are any questions from the floor, to please participate in the discussion. And my aim will actually be to kind of reiterate and reinforce what has already been discussed. The stage has already been set. We've heard right from diagnosis, staging, to management of early stage disease, late stage disease, toxicities, both chemo and radiotherapy related. And hence I will use these case examples to only reinforce these issues. Sorry. So welcome all of you on the stage. And I won't address you by name. Please feel free to pick up the mic and join in. So we understand that though we describe this disease as a disease of the Orient, it is different from other head and neck cancers. And unlike other head and neck cancers, the most common cause is, of course, multifactorial, environmental, genetic, familial, and various viral factors have been implicated. Majority, of course, present in advanced stage disease, and we've heard from the speakers through the day about the advanced nodal stage at presentation. The other important thing is that the site is very complex, very close to important organs at risk. But fortunately for us, most of the nasopharyngeal cancer that we see are the undifferentiated cancers. And because they are radiochemosensitive, they're also amenable to effective treatment. I'm not talking about the world, but about India itself. We have a definite pocket of high incidence in the Northeast, especially in Manipur, Nagaland, Sikkim and Arunachal. And these areas have incidence as high as certain parts of Southeast China. Now, in the TMH, where we see about 10,000 to 12,000 new cases of head and neck every year, nasopharyngeal cancers form a very small proportion. However, what we also have to realize that we are a tertiary referral center, and hence we do get very advanced cases. So now coming on to the panel discussion, as I've already said, this is what I will be doing through the panel discussion. So coming to case one, he's a 51-year-old gentleman who presented with complaints of a left-sided neck swelling for 2 months in October 2020. There was a large conglomerated lymph node mass extending from levels 2 to 4. The DNA revealed a left-sided nasopharyngeal mass. So I'd like one of you to just take on this question. Prashant, why don't you do it, because you're the only surgeon on the group. So what is the staging evaluation that you would undertake for this patient, or would you directly send this patient off to the radiation oncologist?
That would be actually the most convenient thing to do. But of course, we would like to first get a histological diagnosis. As you said, he has a nasopharyngeal mass, so we would want to do an endoscopic biopsy, which is the best investigation to prove histology. In terms of imaging, we all know that for nasopharynx, MRI is the most sensitive investigation. And he has level 2 to 4 nodes. So we may want to do a PET CT as well, or maybe just additionally, we would want to get a CT thorax with upper abdomen ultrasound just to get the distant metastasis workup done.
Okay. Since we don't have a pathologist on the panel, how many of you would ask for an EBERISH on the histopath specimen? Would you ask for an EBERISH, an EBV DNA? You wouldn't. And what about doing serum EBV titers or any other IHC on your tissue?
If we have a nasopharyngeal mass, then we may not be doing.
Okay,
in case
fine.
of unknown primary nodal mass, we may be doing.
Okay, fine. So the thing that I want to highlight here is, and I think Sayan covered this in his talk, was that in endemic regions, there is a definite role for estimation of EBV titers as well as doing EBERISH in the tissue. The reason to do serum EBV titers is something that you can use for several reasons. And the most common, of course, would be helping in the diagnosis. If you've got very high titers in the endemic population, it would guide you towards the existence of a cancer, because otherwise it's a ubiquitous virus, especially in the endemic population. And what could also happen is that this could help you monitor treatment and later on prognosticate, and of course, even tailor treatment. So I think Sayan did allude to this paper, and there is a wonderful paper. I don't know whether there are students online, but there's this wonderful review article by Ann Lee, which actually talks about what kind of EBV estimation, what is the tool to be used, what are the probes to be used for EBV estimation. And of course, this is an important trial that all of us are looking out for, and that is the NRG HN001, which in its adaptive design actually allows for intensification of therapy based on the EBV copy numbers and response post-treatment. So EBV titer estimation today has the role of doing everything, meaning from diagnosis to staging, to monitoring treatment, and perhaps intensification and prognosis. So that's another important part of EBV estimation. The other thing is, of course, it's easy to say that estimate EBV titers, but remember that these estimations are very, very lab and center oriented. So standardization of the EBV estimation is very, very important. The probe that you use is very important for estimation of EBV titers. And that may be one of the reasons why we haven't been able to standardize, though in all our patients, we are doing EBV estimation. So forget this. Now imaging. Prashant did touch upon imaging. So Nikhil, what is the imaging that you would choose for these patients?
So for distant metastatic workup of PET-CT, and if local disease, which especially has the intracranial extension with a cavernous involvement or something, then the MRI of the PNS. So would like to do both the MRI.
So you'd like to do both. The medical oncologist, do you have a preference?
Because it is a node is extending into level 4 and it is below the cricoid cartilage, both MRI as well as PET-CT is advised.
Yeah. So I would agree with the panelists that it would be preferable to do both because they would be complementary. And PET-CT would be a one-stop shop as the metastatic workup, though it has also been suggested that the conventional workup may be okay for the abdomen and for the pelvis, but if for the lungs, it is important to do a PET-CT simply to be able to identify metastasis. And the other role is, of course, above the clavicle to look for nodes that were otherwise not seen on conventional imaging. So we know all this theory about DMR being super sensitive. So for the local disease, it's again important to have an MRI, especially if you've got disease that's located more cranially, because you would require it for radiotherapy planning afterwards, right? So that would be the most important role, I think, of the MR prior to starting treatment. Remember, what I'm talking about is essentially baseline evaluation. So this patient, this 51-year-old man, this is his MRI. If you look at the disease, he's got bulky disease in the nodes. In the neck, he's got disease extending right from level 2 to level 4. And this is his primary disease. So the primary disease is not so much of a problem, but the neck, as you saw, was extending right from level 2 to level 4. And so it was involving bilateral fossa of Rosenmuller, eustachian tube openings on both sides. The pharyngobasilar fascia was also involved. Levator villi palatini was involved bilaterally. The tensor was not involved. And of course, you had nodes right from level 2 to level 4. Now, what is the role of PET-CT? I think somebody in the panel, Nikhil did say that he would prefer doing a PET-CT simply because of the extent of nodal disease that this patient has. Would anybody on this side of the panel do anything different? Would you do anything else, anything additional for your workup? Okay, fine. So everybody is in agreement. Anybody in the audience has any difference of opinion? Because I think this was the only part that we didn't have a lecture dedicated to. But I think most of us are in agreement, the radiation oncologists and the medical oncologists, that we would prefer to have both an MRI as well as a PET-CT, especially with advanced stage nodal disease. So this was his PET-CT. If you look at it, you have nodes extending from above down below with retropharyngeal nodes too, and this is his small primary. So I don't think I need to read out the report. So what we did in this patient was an endoscopic examination, a PET-CT, and you can, depending on the facilities that you have. But other important thing, I think, which we learned through Monali and Nandini's lecture is that we need to do other ancillary workup, which is very important because we know that this treatment that we offer the patients is effective, but at the same time has the ability to cause a lot of morbidity. So we do need to have baseline evaluation for all the other things that we can possibly cause toxicity with. So are you in agreement with that? Fine. Anybody in the audience wants to say anything differently? Deepak, you don't agree with me? It's okay. No, I'm just saying because it's good if you could have some opinion also. So this man had actually an undifferentiated carcinoma of the nasopharynx. His serum EBV titers 22.85. We don't have a cutoff in our lab. Primary disease was then staged as a T2N3M0. We had a baseline ophthalm evaluation. A PTA showed the right ear hearing to be normal. The left ear had a mild conductive hearing loss, and the thyroid function tests were normal. It would actually be ideal to do a complete hormonal evaluation at baseline, a complete endocrine evaluation. So now based on this, we have a T2N3 tumor, which is stage 4A. So what would be your plan of management? So why don't you take it?
So, because it's a locally advanced,
Avinash, right?
I'm Dr. Avinash. It's a locally advanced nasopharyngeal cancer, and it's a potentially intention is curative. We would begin with induction chemotherapy followed by response evaluation.
Will everybody agree to induction chemotherapy, or does anybody want to do concurrent CTRT?
Agree with induction.
Agree with induction.
Okay, anybody in the audience? So everybody is in agreement. They want to start with induction. So our plan was also the same. We did induction chemotherapy followed by reassessment, followed by CTRT. So this, again, we've seen this through some of the lectures in the morning. So we chose this regime for our patient. And so now coming to the medical oncologist on the panel, Siddharth, what would you do? What would be your chemotherapy schedule? What would be your cycles? And how would you sequence this?
So, I would prefer gemcitabine plus cisplatin for 3 cycles, followed by response evaluation and CTRT cisplatin.
So what would be your response evaluation? What would you do?
For response evaluation, I will repeat the MRI.
MRI, you don't want to do PET-CT?
If the response is there, no, I will.
Okay. What about you, Avinash? And
no, because we did the PET-CT at the baseline. I think it has to be, I would again get a local PET-CT.
Okay. What about you?
MRI evaluation.
MRI evaluation. Would you do the EBV titer now at this level?
I'm not routinely doing it, but if it is being observed at baseline, then I would like to know how much levels have decreased.
And why would you choose gemcitabine and cisplatinum and not the triple drug regime?
Because of toxicity, and second thing, even logistics is easy. TCF takes 5 to 6, even 10 days of admission for the patient. Gemcis is relatively easy for the patient.
Easier to administer. Anybody in the audience uses a different combination of chemotherapy, or do you still use cisplatinum 5-FU? Any hands for cisplatinum 5-FU still? Okay. So we'll go to, so we've heard why. So this patient again received 3 cycles of neoadjuvant chemotherapy. It was gemcite plus cisplatinum. And of course, we know the evidence. We have Sun's paper, we have Zhang's paper to support the use of cisplatin of induction chemotherapy. And there's this study, which actually is a small study which compared between TPF and GP. And they actually found what Siddharth has already said, that maybe the GP regime is easier to administer as compared to the 3-drug regime. Of course, this is our own experience using the taxane-based induction regime. And we also found that this was pretty easy to use and our patients did tolerate it. And we've also seen this meta-analysis through the day. And this is the updated meta-analysis published in 2021-26 trial, 7,000 plus patients. And it clearly confirms the benefit of concurrent chemotherapy definitely, and concurrent chemotherapy plus adjuvant chemotherapy, and suggests that the addition of induction or adjuvant to concomitant chemotherapy improves tumor control and survival. So now we don't have a doubt. We are going to be using induction chemotherapy followed by concurrent chemoradiotherapy, or to the ones who follow Al-Saraf, you may want to use concurrent chemoradiotherapy followed by adjuvant chemotherapy, but we will do concurrent in the locally advanced chemotherapy, nasopharynx cancers. So now in this patient, what happened post-induction chemotherapy was this. The nasopharyngeal mass kind of disappeared, the nodes remained, and this is what you see. So there has been some kind of a response, but there is still residual lymphadenopathy. So now what? Please go ahead, somebody talk, somebody say something. So what will you do next?
We'll go ahead with concurrent CTRT.
Very good. So there are 3 options. One is re-challenge with a different induction chemotherapy, move on to CTRT, go on for neck dissection. Prashant, do you want to do neck dissection?
Not right away.
Very good, thank you. What about the radiation oncologist? So who hasn't answered? Samir, Shikha?
I would prefer CTRT.
Shika, you also agree? Okay. So I think we are in agreement that we don't want to re-challenge. We don't want to do anything different. We'll just go the concurrent CTRT way. And we do have some study. You know, I really appreciate the Chinese. There is no aspect of nasopharyngeal cancer that they've not addressed. So again, this is a propensity score matched analysis where they've looked at actually using reinduction after poor response, and they've found that it is of no use. So what you could do perhaps is again, go ahead with CTRT in this patient and then wait and see what happens. Okay. So now, Shikha, tell us what is the pre-radiotherapy evaluation that you would do in these patients?
This patient has already received cisplatin earlier. So, I would do a renal function at this point and also assess his dental status and nutrition now as well, because this patient should receive concurrent chemotherapy with radiation. The dental evaluation, odometry are important from the radiation toxicity point of view also, because both the induction and the concurrent chemotherapy as well as the radiation would contribute to these toxicities.
Thank you. So again, we are going to do the basic biochemical evaluation to ascertain that our patient is still fit to go on to receive concurrent chemoradiotherapy with whatever is now the best or the most effective concurrent agent. And we would also do the other ancillary workup, which would include speech swallowing review, dental prophylaxis, and we do repeat an ophthalmic evaluation and a PTA also prior to starting radiotherapy, simply because this patient has already had a baseline. Patient has then received chemotherapy. We want to know what is the deficit prior to starting radiotherapy. Now, this patient was planned for concurrent chemoradiotherapy. So now let's discuss the radiotherapy nitty-gritty. Okay, so I actually would be trying to just cover the entire thing in one case, and if time permits, we'll go to another case, which is a little different. So what are the doses? We've heard, who told us? Yeah, I think Tanveer and Kaustav spoke about the radiotherapy part. So what are the doses, volumes, techniques, and what is the verification protocol that you use, Nikhil? One line each for all of these.
So dose which I follow is for a younger fit patient, a 66 in 30 gray in 30 fractions, and the elective volume is 54 in 30. For elderly patients who are frail, so I try to follow the conventional protocol around 66 to 70 gray in 33 to 35 fractions. Volumes wise, the high risk volume will be the involved nodes and the primary nasopharynx, and the elective will be the contralateral nodes which are uninvolved regions. The technique is IMRT for all patients, and the verification is daily CBCT.
Samir, what do you do?
I agree with, but the only thing is we usually prefer sequential boost only. We do not prefer SIP.
Okay. Saurabh?
I agree with whatever.
Okay, so none of you here follow the guidelines. Why so? Because the guidelines tell you to do a 70 gray in 35 or 33 fractions. Then you do an intermediate risk, then you do a low risk, okay? And also, what is the volume that you treat? Do you treat the pre-NSCT volume or do you treat the post-NSCT volume? Pre-NSCT volume. So the pre-NSCT volume gets the full 70 gray?
Whatever is in the air, wherever we do not have interfaces, where it is the air, we can reduce comfortably. Wherever there is soft tissue infiltration, there is still hesitation in reducing the volumes of high dose or high risk volume. But in pediatric patients, we are looking at dose reduction as well as volume reduction.
Okay. And so, I mean, cases of intracranial extension, we tend to give around 60 gray, not the 66 gray.
So I think in the interest of the patients, you know, you do have evidence, and I think Indranil did allude to this trial from Hongru. What clearly said that there was nothing wrong in doing or treating the post-induction volume. But here again, you have to be very careful, simply because if you treat the post-induction volume, you also have to have the pre-induction scans so that you can appropriately fuse those scans, identify the volumes, and accordingly treat. So to ensure that at least the pre-induction volume has received at least the dose that is necessary for subclinical disease, which means a 60 gray 30 fraction equivalent. So I guess that's what all of you do. Okay.
I have a question here. This patient has a level 5 disease as well and quite bulky nodes there, multiple nodes, if not individually bulky. So would you try to give 70 to those nodes as well, or restrict the dose to a lower dose level? Those nodes did not respond as well. So
I think the panelists have to answer. So Nikhil, Saurabh, Samir, what would you want to do?
We will give 70. I'll give 70 grade to them.
I'll give 70.
Okay, because you also have to understand that guidelines talk about doing whatever is the gross node, give a 5 millimeter margin to that. They don't talk about delivering 70 gray to the entire level. The entire level gets a dose of around 60 gray in 35 fractions. So that is what the guidelines say. But then there is a little bit of ambiguity there, because depending on the risk as well as the kind of response, you may want to include the level to the high dose, especially in a patient who's had poor response.
Yes, this patient has a bulky, there are multiple level 5 nodes. So almost involving the entire level 5. So, but still I would prefer giving 70 gray to the entire volume.
So now I have a question. Now, supposing this patient was N0, didn't have any of those nodes, what would you do? What would your nodal levels be and dose levels be?
Retropharyngeal and bilateral level 2 will receive the high dose, or maybe the intermediate dose if we are doing a 3 dose. And the other level 3 to 5 will receive the lower dose.
So you would still do a whole neck irradiation. Is that what you're saying? And do the panelists agree?
No, level 5 will not treat.
What about you, Samir?
I would skip level 5 in that case.
Okay. There are a lot of radiation oncologists in the audience. Would you also agree to this and do a whole neck irradiation to 50 gray 25 fractions equivalent? Okay. So I think though we now have level 1 evidence to talk about the practice of doing only upper neck irradiation, people still are taking some time to kind of get out of the habit of not radiating electively bilateral neck. But we need to understand that luckily for us, unlike a lot of other head and neck cancers, nasopharyngeal cancers typically have a very orderly spread of lymph nodes, involvement of lymph nodes. So there is room, and this is especially possible today because we've got guidance, we've got image guidance, we've got the ability to dose reduce, we've got the ability to actually have, we have techniques to reduce morbidity, and especially in the young and adolescents, we should try and reduce morbidity. So I guess this is one of the ways that you could do it. Okay, so now this is what we did for the patient. We used the pre-treatment volume, and we included retropharyngeal lymph nodes, level 1, left level 1B and bilateral level 2 to 5, simply because there was extension to level 1B, but we do not normally include level 1B. And I think Monali alluded to this, the international guideline, but once more, I'd like to go through it simply to talk about what is the priorities that this paper talks about. Now, it's important for us radiation oncologists to understand these priorities, because often in our zeal to actually reduce morbidity, we forget these priorities and we try to, save the parotids, the cochlea, the submandibular glands. And in that, we may sometimes see to it that the GTB also gets compromised. The CTB, the PTB, of course, is a priority too, but we have to remember that the GTB is priority 1 and PTB is priority 2. And all these structures that we are so careful about and concerned about are actually priority 4. But that is not to say that you do not pay attention to morbidity. You do pay attention, but at the same time, take care of this too. So this is what we got in this patient, and this is the final DVH that we got in this patient. So we were within the Quantec guidelines, and these are just the studies, the usual PENG, and so I'm not going to talk about this because Sapna is going to give a good lecture on this after my session, so we'll leave it for her. And so in summary, I could say that perhaps RT volume selective radiation is recommended, but today you could possibly do UNI. RT dose is 70 gray. The other very important thing, and Monali has alluded to it from the toxicity point of view, is the dose per fraction and the volume of the OARs. So that is something which is very sacrosanct. And if you want to restrict morbidity, you have to look into that. The other thing, of course, is if you're using any form of altered fractionation, and this emanates from the what you call the Hong Kong trials, 9901 and 9902, because if you want to combine any of these altered fractionations with chemotherapy, you again have to be very careful because toxicity then becomes unacceptable. And we all know that we are going to use the best form of conformal radiotherapy. Now for a minute, just think that this patient had disease like this, okay? You so far saw a disease that was restricted to the nasopharynx, bulky lymph nodes. But this gentleman now has disease that's extending into the anterior, into the nasal cavity, parapharyngeal extension, very close posterior to the vessels. And this is the appearance on the PET-CT. Now, what would you do for your planning, even post-induction? Post-induction, this is what you see. Very good response at the primary. Medical oncologist, still go ahead with CTRT? Okay. Radiation oncologist for your volumes and for your priorities and constraints.
So the initial plan would be similar to what we had discussed earlier, but we would like to do an adaptive replan maybe 3 weeks down the line too.
No, Shikha, 1 minute. You got me wrong. This is at baseline. This is post-induction. This is post-induction. So this is pre-RT post-induction. Okay. So now you tell me about your volumes, your OARs, and the constraints that you're going to give your OARs.
My high dose volume would include I would still contour the GTV based on the pre-chemotherapy volume and tailor it according to what I said earlier. Wherever there is extension into the bones, I would extend to that level. Wherever there is extension in the muscles, I would extend to that level. In the airspace, I would restrict the volume.
Unfortunately, I don't have images that are more cranial. My concern here is to do with the optic nerves and the optic chiasm. So this is the kind of dose distribution I have managed to get at the end. This is a 54 grade dose distribution. This is not a 95%. Is this acceptable to you?
If the Crohn's disease is covered, yes.
Anybody in the audience has a different point? So this is the kind of DVH and DVH parameter that have been able to accept in this patient, that have been able to achieve in this patient. So kind of borderline. So what would your verification protocol be now?
Daily CBCT.
Daily CBCT, right? Okay. Okay, now coming to now, I leave the radiation oncologist for some time and come to the medical oncologist. What is your plan of concurrent chemotherapy? The drug, the schedule, and what are the points that you consider when choosing your agent?
So if patients, there is no autotoxicity and all other profiles are okay, renal function, then I would consider cisplatin 100 mg per meter.
So what grade of autotoxicity would you find acceptable to give your concurrent chemotherapy?
More than sensory, if patient has on pure tone audiometry any grade 2 sensory neural hearing loss, and especially if patient is symptomatic for it, then I will not consider cisplatin in those patients.
Okay, then what would you be your substitute?
In this patient, because carboplatin is found to be non-inferior to cisplatin, I can use carboplatin.
AUC?
AUC 2 weekly.
2 weekly.
Yeah.
What about you?
AUC 2, madam, but the trial they followed was 100 mg per meter square in that trial. But we follow AUC 2 in the concurrence.
But your preference would be for cisplatinum, right?
Yes, ma'am.
So weekly or 3 weekly? Avinash?
3 weekly.
3 weekly.
Gemcitabine cisplatin, if we are giving, if we have previously given DCF, then we consider weekly only. Yeah.
Okay.
So
And yes.
I assume this to be a young fit patient. So 3 weekly cisplatin 100 mg per meter square.
Okay, you would still do 300 milligram per meter square. Yeah. Okay, because this is perhaps the only site which we really had evidence even before the non-nasopharynx sites for using 40 milligram per meter square. So let's finish that. So what happened is this patient had 6630 concurrent weekly cisplatinum 40 milligram per meter square, and at first follow-up, the patient had a CMR. So now let's revise the follow-up regime. So when will you do the evaluation at follow-up?
3 months post CTRT, we first do a
so what will you do?
We'll do MRI, madam.
MRI only?
Still like to do a PET-CT for.
Okay, how many would do PET-CT?
PET-CT.
PET-CT. You know, in this case, it may be better to do a PET-CT simply because this man had too many nodes. Though it's a CMR, now you want to be sure that he hasn't metastasized in this interval. And you would all do it at 3 months, yes, right? And PET-CT, and thereafter, when would you image?
6 to 12 monthly MRI.
You would still do. What about the others?
Maybe yearly PET-CT.
Yearly PET-CT. Anybody else in the audience?
I think after the first one at 3 months is CMR, we can do around 10 to 12 months. Even if you take the broad PET-NEC data, that is what they have done for PET-based surveillance.
Don't extrapolate PET-NEC to nasopharynx. And that to N3 in PET-NEC was only 7 patients. So don't extrapolate that. But yes, I agree to your 10 to 12 months because that's the regime that's followed most often. What about you, Shayan?
Yeah, so first follow-up I will do it after 4 to 6 weeks to evaluate the toxicities has resolved or not. And maybe I'll do a nasal and nasopharyngeal examination, clinical examination. And then the imaging will be at 3 months' time. If there is a complete response, then it can be repeated after 6 to 9 months' time. And if there is residual, then a follow-up scan at 6 months' time and then do accordingly.
So we've heard from him. He has delivered the talk on follow-up. So don't forget to send your patient to Prashant. Let him do a nasal endoscopy or a DNE or at least an office examination because you have to be sure of your mucosal examination. Look at toxicity, and essentially the toxicity that we will look at would be dental as well as we look, of course, at disease response, but we would look at toxic hormonal. But at the first follow-up at 3 months, you need not do your thyroid function test. You can defer it for 6 months. And of course, very importantly, because you have adolescents and young adults, you may want to look at various psychosocial issues. I won't go into this. Now, just a hypothetical question. What if there was residual disease at the neck after completion of CTRT? What would you do? And when would you do?
So we can, the patient can go for a salvage neck dissection if there's proven on the PET-CT that there's a residual nodal disease.
How soon would the radiation oncologist and the medical oncologists be comfortable sending the patient across for a neck dissection?
3 months.
Sure. So early? We did see something else.
We can wait up to 6 months if there is
yeah. So in this cancer, we wouldn't be in so much of a hurry to actually send the patient across to the surgeon for neck dissection. Unless there was, yes, please go ahead.
So I have seen some of the cases where the SUV uptake has reduced after 4 to 5 months. So we can safely wait for some time.
So exactly. So what you do is you could do a CECT to begin with at 4 to 6 weeks to see how the patient is doing in terms of toxicity and early response, but do a PET CECT only after 3 months. Then at that time, you could do an EBV titer estimation if you are doing it routinely and if you've got a baseline. And then follow up the patient both clinico-radiologically, repeat the scan at 6 months and maybe even the EBV titer then, because many of them are late responders, especially with bulky disease. But there is evidence to suggest that if you have rising EBV titers or circulating EBV in the serum, you may want to send this patient across for a neck dissection. And there is evidence to suggest that perhaps a neck dissection, and this, of course, these are older papers, but you have to remember that there is a role and place for doing neck dissection in nasopharyngeal cancers also. Now, this is a case that I'm just quickly going to go through. This is a patient from Manipur, 67 years old, has presented with multiple lymph nodes in the neck. The histopathology, what will you do for this patient quickly because we've got just about 2 minutes.
Again, the full baseline examination with PET-CT and MRI, biopsy of the lesion, the workup for audiometry and the ophthal examination.
Okay, so now audiometry, why do you want to do it right now? I think we'll just do the staging workup first. Okay, so the staging workup will be a thorough mucosal examination. You would do Iberish because the examination has not revealed anything in the mucosa. So that is why you are now going to go ahead and decide what you want to do. So imaging,
PET-CT.
PET-CT, okay. And this is what you are seeing. Bilateral neck nodes coming down like this. Nothing in the nasopharynx on the PET-CT. No lesion detected. And you have only this node, which is EBV LMP positive and weakly staining for P16. So what will you stage this patient as?
P0N2.
And how will you treat this patient?
I guess same. We'll start with induction.
So you will treat it like a nasopharynx and
Nasopharynx
go
only.
the same way. Okay, fine. Thank you very much, all the panelists as well as the audience. Thank you very much for the organizers for this opportunity.
So from the curative aspect, we move to the bit of recurrent session. So the first talk would be online. Dr. Narayanan P is a consultant surgical oncologist joining us from Kuala Lumpur, Malaysia. He'll be talking on role of salvage surgery or endoscopic nasopharyngectomy in carcinoma nasopharynx.
Hi, good afternoon, everyone. My name is Prabhakar Narayanan. I'm from Malaysia, and I apologize that I may not be online as I'm doing this from overseas in between the conference. I'm going to be speaking about endoscopic nasopharyngectomy for salvage NPC. So, what are the problems with endoscopic nasopharyngectomy? As well, and then cut midline all the way up to the prevertebral space and to the clivus. Then we used a frozen section. That's the prevertebral region, prevertebral space, and that's the depth of the FOR. By removing all this, we were able to get negative frozen section and remove everything until we come to the prevertebral fascia. This is the final view after the excision of SNPC is done. And here you can see how that's the levator valentini. This is the depth of the FOR. That's the prevertebral muscles, as you can see. And we are just a few millimeters next to the ICA. You can see by the pulsation of the carotid artery. And this is then we put a supple flap on top of it. This is how the patient looked like 4.5 years down the line. Now, this was almost 10 years ago. So the patient is now almost 10 years tumor-free. So the results are good if we do it in early cases, in T1 cases, and these are the results are. So a patient who had a recurrent NPC going to the infratemporal fossa, post-radiotherapy and endoscopic excision was done by a colleague of mine, and the tumor recurred. And one of the reasons why I don't like to put a septal flap now is because the tumor tends to grow under the septal flap, and the tumor starts invading into the infratemporal fossa, the tegopalatine, and you can't even see. So this is after the dissection of the infratemporal fossa. That's the tumor that is stuck to the maxillary artery, as you can see. There's a tumor stuck to the maxillary artery. That's the infraorbital nerve. So what we need to do is we need to clip the maxillary artery and excise the tumor away. We put 2 clips to make sure the clip does not accidentally fall off and there is no substantial bleeding. And then subsequently, we dissect the pterygoid muscles so that we are able to expose the pterygoid wedge. And then we drill off the pterygoid wedge until we have we drill off the entire pterygoid wedge. And this is the final view of the end of the surgery. You can see that now as the infraorbital nerve, that's the maxillary artery with a clip, and that's the pterygoid wedge that's been drilled. And this is how the patient looks like 3 years down the line. This must be almost 7 years now, and the patient is still quite well. So basically, let me show you a few more cases before I show you our results. 47-year-old Chinese male who was diagnosed with T2N2 in September 2018, completed CCLT in 2018 December. And here, these are the scans. You can see the lesion is quite small. And this is the pre-op view. That's the lesion right in the center. And this is the post-operative view, as you can see after the surgery is done. The clivus exposed, the prevertebral muscle exposed. We've actually done all the way up to the clivus, up to the junction of the C1 and the clivus. Pre-op and post-op view that shows the anatomy as well. Case number 2, radiotherapy done in Hong Kong. Recurrence at right of the nasopharynx, and this shows the lesion quite nicely here. So again, this is the final view after the surgery is done, where the tumor is removed according to the location, all the way to the clival bone, the prevertebral muscles, and this is the depth of the FOR and the foramen restrum that will be here as well. The preoperative view and the postoperative view that shows the exposure. Case number 3, this is a Malay gentleman who had multiple recurrence and had 2 nasopharyngectomies with negative biopsies, negative margins. The PET scan was negative as well. So by the time, and then he had tumor recurrence. So by the time we did the surgery, it was the 3rd endoscopic nasopharyngectomy. Again, you can see the lesion is quite extensive here. And this is the pre-operative view. You can see how extensive the tumor is, going to the infratemporal fossa or the tegopontine plate. And that's the final view after the dissection that I did. The clival is completely exposed all the way to the on the right side. This now is the pterygoid muscles, as you can see. Now we've drilled off the pterygoid plate. There's a lateral pterygoid plate, and this is the remnants of the tensor valley palati, as you can see here. Pre-op, post-op view, all the way up to the lateral pterygoid plates, the fibrocartilage tissue of the eustachian tube, the pictoclival feature, the sphenoid sinus has been completely removed as well. So what are our results? We published the T1, T3 nasopharyngectomies for recurrent NPCs, and we had a 96% negative microscopic margins, and 86% of these cases had an en bloc tumor resection. And then the 2-year local disease-free was 96%, and 2-year local overall survival rate was 96% as well. Then we published a recurrent T3, T4. I think we were among the first to publish in the world of an exclusive T3, T4 nasopharyngectomy. I believe this was published in the European Archives a few years ago. And again, we had a result of in T3 we had 100% negative surgical margin. In T4 we had a 53.8 negative surgical margin, which actually is better than an open surgery by William Way, who had only 50% surgical margin. The survival and the disease survival rate was 66.7%. That's 100% in T3. However, T4 dropped significantly to 61.5%, and disease-free survival 50%, as well as 38.5%. So these are the series that's published. At that time of the publication, ours was among the very few series of T3, T4, but I think there are newer publications, especially from China now. So when do we know that we will not be able to get positive or negative margins? So this is a patient who's got a tumor. That's the petrous carotid artery. That's the vertical aspect of the carotid artery. And that's a junction of the carotid artery between the petrous bone, that is the horizontal segment. And this is the junction, and you can see tumor that is involving this junction as well. And although we have removed whatever we can, that's the V2, going to foramen rotunda. That's the maxillary artery. But again, you can see how there is still some tumor left behind along the junctions of the carotid artery. Because the carotid artery is completely decent with tumor along the artery as well. This is the final view of the surgery. You can see how there's the infraorbital nerve with foramen rotundum. And again, infraorbital nerve with foramen rotundum, very nicely seen. The maxillary artery that is clipped. The pterygoid plates that's been drilled off. The pterygoid plates that's been drilled off. But however, we left some tumor around the margins at the petrous apex. That is the vertical segment of the carotid artery. And this is the horizontal segment of the carotid artery. And that's the tumor that is left behind at the junction because it was actually involved in the carotid artery. So this is the evidence of when we are not able to get a positive, a negative margin. So again, the key points is to get clear negative margin. That are the most important factor. Piecemeal resection is fine. And endoscopic surgery is excellent for this. And again, I thank you very much for the kind attention. And I apologize if I'm not there in person. Thank you.
Hello. Hello, sir. I would like to ask you 2-3 questions, if you permit.
So moving on, the next talk would be by Dr. Ashwini Budrukar. Also, again, madam needs no introduction. Those all of us who has worked with her and in head neck unit. So madam will be talking on re-radiation in recurrent cases with both role of external as well as brachytherapy.
First of all, I would like to thank the organizers for giving me this opportunity to talk on this challenging topic of re-radiation in recurrent nasopharyngeal cancers. So in this era of IMRT, the recurrence rates for the local recurrence after IMRT are quite less, and only 10% of patients will have locally recurrent nasopharyngeal cancer. Most of these recurrences, they occur within first 3 years, and there are some important prognostic factors which decide the outcomes of the treatment, which we will see in subsequent slides. There is no one treatment that fits all the patients, and we will have to individualize the treatment in such scenarios. When we give chemotherapy, we can expect the median progression-free survival of around 7 to 11 months, and the overall survival is also not very great, to the extent of around 20 months. We are all aware of these algorithm for the locally recurrent nasopharyngeal cancer, and in which we know that in presence of distant metastasis, we will prefer chemotherapy, and when there is only nodal metastasis, we will consider for surgical option. However, when there is a nasopharyngeal recurrence, then there are various options available, and these will depend on whether it is an early stage tumor or an advanced stage tumor. For early stage tumors, the options are re-radiation or chemotherapy and surgery, and there are clinical trials ongoing about immunotherapy. And in advanced disease, we need to consider neoadjuvant chemotherapy and followed by re-radiation. So we need to evaluate the patient thoroughly before giving a re-radiation, and various patient factors need to be taken into account. These include age of the patient, performance status, comorbidities, and preference of the patient. Complete physical examination in terms of disease extent of the primary nodal disease and metastatic extent is necessary. We need a FDG PET scan. MRI is also important for looking at the local extensions of the disease, and circulating plasma EBV DNA may have some role. We need to know various treatment related factors, and this include we need to differentiate whether it is a persistent primary or a recurrent tumor, because our decision making might change depending on what it is. Disease-free survival is important, because if the disease-free survival is long, we can expect better outcomes. Also, we need to have details of original radiotherapy plan, and we need to know whether it is a geographical miss or an failure within the high dose region, in which case our treatment modality will change. We need to know the OAR doses of the previous radiotherapy, and if the patient has suffered any long-term toxicities of the previous radiation. This is a very important paper, which is a guideline for the treatment of locally recurrent nasopharyngeal carcinoma. And it says that we should try aggressively for salvaging these patients. And in early recurrence, we can expect long-term survival if we detect the recurrence early. And in extensive disease, we can achieve good palliation with radiotherapy. However, we need to balance risk versus benefit in this patient. So the treatment options include salvage surgery, intensity modulated re-radiotherapy with or without chemotherapy, SRS, SRT or SBRT, and brachytherapy. So salvage surgery is actually the first choice of treatment for nasopharyngeal recurrence, and the aim is to get the surgical resection with clear margins. However, the availability of such surgical expertise is a serious consideration, because such kind of surgeries are not done routinely, and we need very high expertise. But in expert hand, 5-year post recurrence free survival is quite good, up to 56%. However, there is a perioperative mortality of around 2.4%. So there are approaches. There is an open approach or endoscopic approach, and more recently, endoscopic approach is more frequently considered. And in fact, there is a randomized trial which has compared endoscopic surgery versus intensity modulated radiotherapy for locally recurrent nasopharyngeal carcinoma. And in this trial of 200 patients, they compared endoscopic nasal surgery versus IMRT, and they showed that endoscopic resection, it led to the superior outcomes in terms of 3-year overall survival, which was 85%, while IMRT led to only 68% overall survival. There was no issue of mucositis, of course, in endoscopic surgery, and as high as 20% of the patient died due to the late effects of radiotherapy. So they concluded that endoscopic surgery should be considered as a standard of care in locally recurrent nasopharyngeal cancer. However, it may not be feasible, or the facilities may not be available everywhere, and we may have to consider re-RT. And to do that, we need to take into account age of the patient, performance status, the disease-free interval, recurrence staging, whether there is any intracranial extension, and advanced stage disease where we need to give induction chemotherapy. Size of the recurrent tumor is also important, because when the size exceeds beyond 80 centimeter cube, then the local control rate rapidly decreases to less than 10%. Presence of prior complications is also important, and proximity to the critical structures of the present disease is very important, because this will impact the doses to the critical structures. So if the surgery is done, then the indications of re-RT are essentially positive cut margin or close cut margin. There are situations when the close cut margin, even if the margin is between 2 to 5 mm, then we may consider giving re-radiotherapy. However, generally, re-RT is not considered if the disease-free interval is less than 12 months and in presence of the neural toxicity. Presence of xerostomia, hearing loss, or endocrine toxicity is no exclusion for considering re-RT, and same is true about the bulkiness of the tumor. We need to delineate our target volumes very carefully, and we can take a help of radiotherapy planning, MRI, or FDG PET scan for doing so. Generally for CTV, 5 millimeter expansion is done, which is then curtailed from the critical structures and air. PTV margins are very tight, and sometimes there have been studies where no PTV margins have been given in presence of daily image guidance. So total dose that is aimed is around 60 to 66 gray, and fractionation choice is hyperfractionation. And if hyperfractionation is not feasible, then convention fractionation is the second option, wherein the dose per fraction should be around 1.8 to 2 gray per fraction. And these are the dose prioritization and acceptance criteria, where we can see that along with the GTV, the neural structures get the first priority. This is then followed by PTV and the temporal lobe, and the third priority is for the carotid artery. And these are the desired doses of the both primary and second course. So for the neural structure, 130% of the tolerance dose is generally considered as an acceptable criteria. So for the brainstem and optic chiasm and optic apparatus, it is 70.2 gray cumulative dose, while for the spinal cord, it is around 58.5 gray. For the temporal lobes, it is less than 91 gray, and for the carotid, it is cumulative dose of 125 gray. There is a meta-analysis of patients who have been treated with intensity modulated radiotherapy, and it has shown that the 5-year loco-regional free survival is 72%, and the overall survival is around 42%. But they have also shown a very high toxicity, and death due to IMRT is as high as 33%. So we have to be really careful in deciding IMRT as a re-RT. And these are some of the series of IMRT which I've shown that can I take 2 more minutes? So which I have shown that the 3-year local control rates, they extend up to as high as 50 to 60%, and the overall survival is somewhere between 60 to 70%. There are various prognostic factors, which I don't think I can go into detail of, but they essentially are younger age, better colonoscopy performance status, lesser stage, lesser volume of the disease, and absence of grade 3 toxicities from previous radiation. And based on that, a model has been developed, and I don't think I can go into detail, but they have categorized patients into low risk and high risk, and they have very clearly shown that the overall survival is better in patients who have low risk prognostic index, while it is poorer in patients who have poorer risk. SRT can also be considered, and there are trials which have, there are studies which have shown outcomes with single fraction conventional RT as well as hypofractionated RT, and they all have shown good outcomes, but at the same time there is neural toxicity and chances of brain necrosis in most of the series. So this is our own patient, and I obviously cannot go into the details of this because of the time, but we could deliver hypofractionated RT. In this case, we took delineated the tumor using RT planning MRI, and we could deliver 35 gray in 5 fractions to the disease. A patient showed no evidence of disease on follow-up, however, progressed distally. Brachytherapy can also be considered, but it can be done only for a localized tumor, and extension into the parapharyngeal region is contraindication. We can do it as a boost or as radical brachytherapy alone. This can be done with the use of endocavitary nasal applicator, or can be done as a transpalatal interstitial brachytherapy. In addition, gold seeds or iodine seeds can be considered, and these are some of the series which have shown good results ranging from 50 to 80% 5-year local control rate. However, if we look at toxicities, the toxicities are also quite high to the extent of 45 to 50%, which clearly are not very acceptable. So overall, with any of the technique, if you see, the toxicities of re-RT are very high. Grade 5 toxicities, that is death due to treatment, is as high as 30 to 40% using any of the technique. In addition, we have mucosal necrosis, hemorrhage, temporal lobe necrosis, cranial neuropathy, trismus dysphagia, and hearing loss. And therefore, we have to be very careful. So to conclude, management of locally recurrent nasopharyngeal carcinoma is challenging. Surgery is the preferred modality of treatment. Re-RT can be considered in very select group of patients. IMRT with a dose per fraction of 1.8 to 2 gray is a preferred treatment modality, and total dose should be 60 to 66 gray. Toxicity is quite high and we have to be very careful. I would like to thank Dr. Sheetal and Dr. Naveen for their inputs to my presentation. Thank you.
So our next speaker is Dr. Sapna Nangia. Madam is a senior consultant radiation oncologist at Apollo Proton, Chennai. She'll be talking on role of proton therapy, both in definitive and re-radiation setting in nasopharynx.
Good afternoon, and thank you very much, Srinanjan, for this opportunity. I will be discussing the role of proton therapy for definitive and re-radiation setting in nasopharyngeal cancer. Very recently, 12-year data has been published from the MD Anderson Cancer Center, talking about 573 patients who have been treated with proton therapy, and at a median follow-up of about 2.4 years. The overall survival is about 87% at 2 years. So this is a data that we are all looking at in terms of the long-term outcomes of patients undergoing proton therapy for head and neck cancer. What is important to note here is the long-term grade 3 toxicity is about 26% and grade 4, 0.3%, and these were all ocular toxicities. For the non-radiation oncologists, protons do not cross beyond the specified energy, and that means that the tissues distal to the point where the proton is stopping, the Bragg peak, can be spared. That allows sparing of distal tissues. It might allow for dose escalation, and possibly there is a higher proportion of double-strand DNA breaks which are more difficult to repair, and that is something that we can harness, and that may be the reason why this modality seems to be effective for traditionally radio-resistant tumors, such as adenoid cystic carcinomas, chordomas, etc. The current generation proton therapy machines use pencil beam scanning techniques. This is the third generation of proton therapy after passive scattering and universal scanning. In this, there is a beam of protons, which can treat the tumor layer by layer. But the important thing to note here is that the treatments are more conformal. They don't require the creation of a cumbersome compensator. It allows for treatment of irregular targets, which is why proton therapy has become applicable for head and neck cancers over the last 10 years that this last 20 years that this treatment modality has been available, pencil beam scanning techniques. Early on, the application was primarily for brain tumors. It also allows for better proximal sparing that was not possible with the earlier techniques. We already know from other sites that with proton therapy, the requirement of opioids goes down, tube feeding goes down, hospital admission is less from various MASH pair analyses. I have put up only one. Now, coming specifically to nasopharynx, there have been approximately 9 studies that have been published, and a recent systematic review by Ann Lee has tabulated them, and I'm picking the one that has been published most recently. This is from the University of Washington in Seattle, and this is 26 patients, primarily stage 3 and stage 4 cancers. But what is important to note is the fact that the late grade 3 toxicity is 0, and the late grade 2 toxicity is in the range of about 4 to 8%. And the reason for that is that proton therapy allows for better sparing of normal tissues. So we can see usual cochlear doses would be in the range of about 50 with photon treatments. Oral cavity would be ranging between 25 to 35. And the constrictors and larynx would be more in the range of about 40 to 50. And there is a significant reduction as compared to that, as you can see in the slide. We do know, of course, from Molali's lecture that there is a significant impact, long-term toxicity. And if one is to tabulate that in the study published in 2020, about 50% of patients have at least grade 3 or more toxicity at 5 years, according to various studies. So, which is where the relevance of proton therapy or exploring proton therapy comes in the treatment of nasopharyngeal cancer. There have been a number of planning studies, and what is highlightable in these planning studies is a 50% reduction in the dose being received by various organs at risk, such as the temporal lobe or the inner ear, the TMJ, the larynx, as well as the thyroid in this case, not always possible. In this situation, of course, the oral cavity D mean has actually reduced not very significantly, but that is in variance with the reports, variance with other reports. There are other data that have been published. One is 40 patients data from the Czech Republic, from a proton center in the Czech Republic. What is important to note, though they did have not very good outcomes, which they have attributed to very high number of stage 4 patients, is that only 5% risk of grade 3 reactions and only 10% requirement of tube feeding. Another study published from MD Anderson, excuse me, gentlemen, if you don't mind. For 13 disease OAR sites, there was an advantage for proton therapy, as you can see in this waterfall plot. So this is also clinical data of 9 patients. When we look at using proton therapy as a part of the treatment, not as a full treatment, there are some studies which have looked at mixed beams. And so this is from Korea, 18 fractions treated with nearly about 100 patients. 18 fractions treated with helical tomotherapy, and following that, patients were divided either into helical tomotherapy, about 63-64%, and 35 patients received IMPT. And what we see here is a significant improvement in mucositis and a non-significant advantage for dermatitis, weight loss, and analgesic usage. The authors here have suggested that their approach allows for cost saving, some benefits of proton therapy, logistics in terms of using a scarce resource. At APCC, we have treated about 56 patients of head and neck total for de novo and post-op, and about 28 patients have undergone re-irradiation. Bulk of our work is oral cavity, but nasopharynx constitutes 7% of patients treated with radical intent and 15% of patients irradiated. The striking thing in our has been the absence of mucositis. This is our first patient, oropharyngeal, after 18 and 26 fractions. And we have subsequently worked further on it and also submitted our data. This is a CA tongue patient in which you can see at completion of treatment, the palate and cheek are being spared. And this data is under review. What is remarkable is the 50% dose reduction in oral cavity tumors in the spared mucosa. And what has also been remarkable in our group of patients is the fact that the NGT requirement is very, very minimal. And the average planned breaks have been in the region of only about 1 to 2 days. So coming to some case studies of patients we have treated for CA nasopharynx, this is a T3N0 41-year-old male. And this is the comparative dose distribution of the proton versus photon. As you can see, significantly better sparing of the oral cavity and a reduction in the integral dose being received, relevant for a 41-year-old who's expected to live long. And also better sparing of the hippocampus. This is the 700, 1400 and 2100 gray isodose. Which is sparing the hippocampus. So there is a significant reduction in the dose received by various organs compared to helical tomotherapy. Of course, helical tomotherapy is achieving almost all the aims that have been specified by Quantec, but it might become relevant in a situation where there is proximity of the optic nerve and the brainstem. But most importantly, as you can see, there's a very significant reduction in the mucosal doses being received. I'll just take 2 minutes more. In the mucosal doses being received, which has naturally some impact on the tolerance of treatment and the ability to undergo chemotherapy. Even more relevant in an elderly patient, this is a dose differential. So this is the proton plan. This is a helical tomotherapy plan, good helical tomotherapy plan. And this is the radiation dose not delivered to the patient who is receiving proton. Again, very significant reduction in the doses being received by various organs which impact cognition, something that impacts an elderly person, as would the ability to undergo chemotherapy. There is, as I mentioned, the mucosal sparing is very significant, and we've noted about a 30 to 34% reduction in the normal tissue complication probability for grade 3 mucositis. Pediatric patients too, both 2 patients whom we have treated, my courtesy to Dr. Srinivas Chulkuri, who shared these slides. 70 gray in the first patient, and then after that, the new guidelines were adopted, and this patient has been treated. Both patients are doing well, did not have grade 3 reactions, and did not require any NG tube feeds. And finally, re-irradiation, as Dr. Ashwini mentioned, there are concerns about temporal lobe necrosis, brainstem injury, various OARs that are in the vicinity. This is a proton therapy plan, a helical tomotherapy plan, and a combination. And when we see the dose distribution, the DVH here, the combination plan of 20 protons and 10 helical tomotherapies has allowed us to reduce the dose of the brainstem quite significantly, as well as of the hippocampus quite significantly. This patient has resumed working and drives to work every day. However, sometimes there are surprises. So this gentleman, we treated him post an endoscopic resection and recurrence. He did well after treatment, but unfortunately developed a recurrence outside our treatment area at 3 months post-treatment. So at APCC, we've treated, sorry, I think I have something missing here. We've treated 4 patients of nasopharynx, 2, in addition to pediatric patients. I think I don't have the slides saved correctly. One of these patients had a grade 3 reaction. The elderly patient had a grade 3 reaction. We've also treated 4 re-irradiations, of which 2 are alive. We've had 1 carotid blowout. One of these elderly patients has required dilatation of stricture of nasal choanae, which is something that we have not seen earlier. What is important to note here is that most of these patients did not have any significant weight loss. Only one elderly patient had an 11.3% weight loss. And my last slide, not nasopharynx, but sort of highlighting the role of proton therapy in sparing neural OAR in a re-irradiation setting. Esthesioneuroblastoma, 32 now and 20 something at the time of his first treatment. Had already received a dose to the optic nerves and the optic chiasm. And these were our constraints: 27 to the brainstem, optic chiasm 19, optic nerve right 16, and optic nerve left 24. And what you are seeing here is the 15 gray isodose and the 25 gray isodose, sparing both the optic nerves, which was not possible using a helical tomotherapy plan. For reasons of paucity of time, I have not discussed anything about the technique, but typically it's a 4-beam technique. Occasionally, we may add a 5th beam, which is a vertex beam. And most patients are planned using robust evaluation. As far as the data is concerned for re-irradiation, there is an Italian study comprising 17 patients. who have reported that their grade 3 toxicity was in the range of about 23%. Survival is the same as Dr. Ashwini mentioned, 50% at 2 years, sorry. So definite reduction in radiation side effects and toxicity, reduction in tube feeding requirement and grade 3 mucositis, likely impact on tolerance of chemotherapy, of course, judicious selection of recurrent patients because they may have very poor prognosis, and a reduction in the integral dose, which would be important in the adolescent and young adults. These have all been highlighted in a recently published systematic review of 369 patients. I'd like to acknowledge the team at APCC with special mention to Dr. Nofal, our physicist who looks after head and neck, Dr. Utpal Gaikwad, and Dr. Nagarjuna Burela. Thank you.
So moving on, the next talk would be first line palliative chemo in carcinoma nasopharynx by Dr. Vikas Talreja. He is a medical oncologist from Kanpur.
A very good afternoon, and I won't be keeping you long between your lunch. We'll be keeping this session very crisp and concise. My talk will be divided as how we decide our therapies on the subgroups and the prognostic factors, the treatment options, the biomarkers, the response assessment, and how we monitor it. So the first is whether when we classify metastatic, whether it's a de novo metastatic or it's a recurrent metastatic, it's a widely metastatic or it's an oligometastatic, it's a local recurrence or a regional recurrence. And we have seen the nasopharyngeal cancers throughout the incidence is increasing a lot, and it is third most deadly cancers right now. And with the advent of the IMRT era, we are seeing a lot of differences in how we manage the oligo recurrences, as well as a single site recurrences, as well as the de novo metastasis. So if it's a loco-regional recurrences, IMRT does have a very good loco-regional control. Most of these patients, in fact, you could see this Olympic champion also getting cured out of this disease. And that's why when we classify the heterogeneity of the metastatic nasopharyngeal cancers, we divide on the basis of the onset of metastasis, whether it was a synchronous metastasis or a metachronous metastasis, whether it's a pulmonary metastasis, which has a good prognostic factors as compared to an extrapulmonary metastasis. A solitary metastasis has a better prognostic factors, and also we'll be discussing in the later part of my talk as what is the baseline EBV DNA and how fast the EBV DNA was cleared from the system. So the points which favors the loco-regional failure was the baseline T staging, the age, the gender, the tumor volume which was radiated, the interval time from the last radiation, the plasma EBV DNA in all loco-regional failure cases, what was the dose given, what was the fractional dose given, if the patient had taken up a surgery, what was the margin status, whether the parapharyngeal space or the dura or the brain is involved or not. And that's where we will be taking the heights of the guidelines, where we have seen, especially with the ASCO 2021 and 2022, the first line data for the chemo IO has come up quite a huge. So when we deal with the residual or the loco-regional recurrences, we have to look at what is the volume, location, extent of the recurrent tumor, what is the DFI, what are the comorbidities, what was the pre-existing organ dysfunctions. Surgery, if it is not invading the carotid artery and not extending intracranially, are the candidates for the nasopharyngectomy, endoscopic, robotic, open, whichever is you take. There is a good 5-year data of 55% overall survival and 5-year control of around 50 to 85%. Post-op artery, if it is positive margins, regional recurrences, selective neck dissections, and based on it. And all of these factors do play a role into it. Now, coming to the systemic therapy, chemotherapy was is and will be one of the mainstay of the palliative treatment because it gives those responses and gives the overall survival. So 1 year overall survival with the platinum doublet, the data is 70%, which is not translated into the subsequent lines where it gets reduced if we take capecitabine as 35 to 54% and gemcitabine as 46%. The first line, the palliation chemotherapy does very good in terms of the median PFS of around 10 months, but subsequent lines is where it fails. And that's where there is this paper where the cisplatin gemcitabine was compared with the cis5FU, and you could see that 1 year overall survival rate of 80% plus patients, overall response rate of 64%, the PFS of around 20%, prove the superiority of the cis-gem combination as compared to the cis5FU combination. And the similar benefit was observed with cis-gem, whether it was an oligometastatic or a widely metastatic pulmonary or extrapulmonary disease. Now, if after the chemotherapy there is oligometastasis, it depends upon how many lesions are there, how many organs are involved. And if there's less than 6 discrete mets, there are options of giving local radiation, SBRT, or doing a metastectomy or a radiofrequency ablations, and especially for the pulmonary metastasis, as we discussed. Maintenance chemotherapy do have an emerging data, and we had this ASCO presentation in 2021, where 4 to 6 cycles of induction chemo, and they were randomized whether to the observation or the capecitabine for maximum 2 years. And you could see the drastic PFS difference between 35 months versus 9 months with a significant hazard ratio and a p-value. Also, the loco-regional radiation also improves the survival after the induction chemotherapies in this meta-analysis also. Now, next, what could be there? Cetuximab was added. Unfortunately, didn't have much statistically and clinical benefit. Nimotuzumab, there is a data which is a Chinese origin and emerging, but still it's not a great level 1 evidence. But what has come over the past 4 years is the immunotherapy, the PD-L1 inhibitors in the recurrent metastatic as a maintenance and as well as in the first line. We have the Keynote 28 trial, we have the Jupiter trial, we have the Captain trial, which has pushed these molecules upfront and also in the maintenance. And all of these across, you could look at the median overall survival not achieved in all of them. And overall response rates somewhere reaching from 90% to 40% across these various molecules. The various molecules which were tried were the camrelizumab, the tislelizumab, the spartalizumab, the nivolumab, the pembrolizumab, and the atezolizumab. And all of these are based on a similar design. So primary metastatic, you give the baseline chemotherapies, you add the PD-L1 inhibitors, and you put them as a maintenance throughout. With the primary endpoint of PFS, we have 3 beautiful trials, the Jupiter 2, the Captain 1, and the Rational 309, all of having a hazard ratio of PFS around 0.5, meaning a 50% reduced risk of progression when you add the PD-L1 inhibitors to the combination, with a good response rate jumping up to 77 to 88%, and the durability of the response. And you could look at the Jupiter trial where the toprelumab was added. The median progression-free survival was 11.7 months as compared to the chemo alone, where was 8 months, with a hazard ratio of 0.5, meaning a 50% reduced risk of progression when you add the PD-L1 inhibitors. And with subgroups, it benefits all across. You could see the forest plot was lying left to the side, baseline EBV DNA, the age, and the PD-L1 status. Also, the Jupiter has an overall survival update to it, which was present in the ASCO, 0.6, meaning a 40% reduced risk of deaths when you add this molecule upfront and put it as maintenance. So 2-year survival rates of 78% as compared to 63% with the chemo. And also with the Captain 1, we could see the camrelizumab plus the chemotherapy hazard ratio, again 0.54, meaning this does have a statistically and a clinically meaningful benefit of reduced chances of progression when you by a tune of 50% when you add to the first line therapy. And what are the subgroups that benefits? It is across all subgroups, and also it does have an increased objective response rates. And we have 2 subsequent randomized trials also, which are comparing single agent PD-L1 with chemos and with a crossover design showing some superiority, pembro alone versus chemo alone. You could look at the 2-year survival rate of 40% with pembro alone as compared to the chemo. The hazard ratio still unity, so it means that you have to add it. What has the EBV DNA done to it? You could look at the baseline EBV DNA and also the post-treatment EBV DNA. Hazard ratio 0.6, meaning that it does have a treatment implication of doing baseline and also post-treatment, so that you can have a careful selection of where you could add these therapies. To summarize, management of recurrent metastatic nasopharyngeal cancer should be a risk-adapted approach in a multidisciplinary setting. Distinct patient groups have diverse prognosis and should be treated in risk-adapted approach. Chemotherapy remains the backbone of the palliative treatment. Concurrent chemo IMRT may improve the survival in de novo metastatic nasopharyngeal cancers. PD-L1 inhibitors improves the PFS when added to the chemotherapies. Benefit across all subgroups. Approval status will change in the new futures. Longer follow-ups is required. The PD-1 inhibitors in subsequent lines is not superior to chemo alone in unselected population. And that's it. Thank you.
So moving on, as Vikas has set the stage, so now it's for the palliative chemo in carcinoma nasopharynx, second line and beyond, by Dr. Rushabh Kothari. He's from Narayana Hridayalaya, Ahmedabad, right?
So thank you for the invite. Vikas has already covered 30-40% of my topic. So I am going to discuss palliative chemotherapy, rather systemic therapy in nasopharyngeal cancer, second line and beyond. So why we are discussing second line and beyond? So as we saw, first line platinum-based chemotherapy, median progression-free survival is between 5 to 7 months, and median overall survival is 19 to 22 months. So this being a chemosensitive disease, we can give a clinically meaningful quantity and quality of life if we treat patient with more lines of treatment. Though available data for second line and beyond is sparse, there were no randomized phase 3 trial until an abstract is published for Keynote 122 last year. There is no comparison between monotherapy versus combination versus polychemotherapy. There is no comparison of palliative chemo versus best supportive care. Most of the data are based on phase 2, phase 1 and retrospective data, little or no data on quality of life. So what are the available options which are effective? So for chemotherapy, taxanes, paclitaxel or docetaxel, 5-FU or capecitabine, gemcitabine and platinums. Immunotherapy, nivolumab, pembrolizumab are the available ones. There are 2 or 3 molecules which are not available in India, available in China, and they have shown activity. EGFR inhibitors, cetuximab, nimotuzumab, there is some data, but a doubtful efficacy. So for taxanes, these are the studies for second line and beyond. Again, most of the studies are mixed bag. Some are first line, some are second line. But we can see that overall response rate is in most of the time beyond 30% with reasonable progression-free survival. So it looks like taxanes are active, and in some of the regimens, platinum are added. So that would be dependent on what previous treatment patient has taken and what progression-free or platinum-free interval is there. Gemcitabine looks like an active molecule. Overall response rate are more than 40% in all 3 studies. Median progression-free survival more than 5 months in most of the studies. 5-FU analogs, again, around 25% plus response rate in all the studies with more than 4 months of PFS in all the studies. So there were some other chemotherapies which we routinely don't use currently, vinorelbine in combination with gemcitabine, ifosfamide, irinotecan, pemetrexed-based treatment. It looks like that there is some response with vinorelbine, especially it was combined with gemcitabine in both the studies. So we don't know whether vinorelbine is contributing or gemcitabine is contributing. There is some response rate with irinotecan. Pemetrexed doesn't seem to have a significant response rate. It is 2.9%. EGFR inhibitors have been tried. Cetuximab with overall response rate of 11.7%. Median PFS of 2.7 months is not very exciting. Nimotuzumab has been tried in concurrent and induction setting. There is some response rate, increment in response rate when nimotuzumab was added to standard treatment, but we don't have significant data. Even TKIs were tried, pazopanib and geftinib. Geftinib, there were 2 studies, both showing 0 response rate. Pazopanib, there was 6% response rate, but VEGF inhibitors had risk of hemorrhage because some of the patients had intracranial disease also. So we need to be careful while giving these TKIs. Checkpoint inhibitors, some of it has been shown by Dr. Vikas. For pembrolizumab and nivolumab, we have 3 studies and now 4. Pembrolizumab in second line has shown 26% of response rate with median PFS of 16.5 months. Nivolumab in 2 studies, one with 44 patients and one with 24 patients, had shown response rate of 21%, showing that there is some activity of IO drugs. Now they are trying to take IO drugs to first line. There are autologous EBV specific cytotoxic T cells. There are some reports where around 48% response rates has been quoted. So again, this is an exciting field which may evolve. So this is the only phase 3 study which is published in as an abstract form, where in second line they have given pembrolizumab as a monotherapy versus chemotherapy of physician's choice. All the chemotherapy in control arm were reasonable. Either it was 5FU based, either it was taxane based or gemcitabine based. So was a fair trial with 117 patients in pembro arm and 116 in chemotherapy arm. Overall survival was 17.2 months versus 15.3 months with hazard ratio of 0.9. Crossing unity, p-value not significant. PFS of 4.1 month versus 5.5 months. Hazard ratio more than 1. Overall response rate 21.4% versus 23.3%. Disease control rate of 50.4% versus 63.8%. And duration of response was 12 months versus 13.1 months. So seeing this data, it is sobering that pembrolizumab as a single agent versus chemo as single agent in platinum pretreated patient, we are not improving overall survival, not improving progression-free survival, not improving overall response rate. So whether it was significant in patients who had PD-L1 positive or CPS score of more than equal to 1. So again, it was overall survival of 17.2 months versus 18 months and overall response rate of 23% versus 26%. So this is something which is sobering. But the data in first line with chemotherapy looks exciting. So this is a real world data from TMH, where second line treatment, only 46% of the patients are taking second line treatment and only 26% of the patients are taking third line treatment. So we are missing a majority of patients when we are treating subsequent line of treatment. So this is something which we should consider. Again, we know that IO access to most of our patients is not there. Less than 5% of patients would be able to take immunotherapy at any point of time. So my conclusions would be for a patient of nasopharyngeal carcinoma, these are the active drugs: gemcitabine, platinum, taxane, 5FU or capecitabine. And if patient is fit, in sequential fashion, patient should receive most of the drugs. This has shown a reasonable response rate. Which drug to give, in which sequence to give will be determined based on prior treatment, performance status, comorbidities, finances, and preferences. Because we don't have head-to-head trial for most of the drugs, or rather we don't have phase 3 trials for most of the drugs. Checkpoint inhibitors are active and should be given in eligible patients. EGFR inhibitors and VEGF inhibitors, we don't have even a good phase 2 data. So I'm a bit skeptical on using them. Thank you.
So the last talk before we break for lunch will be by Dr. Pratik Chandrani from TMH Mumbai. We'll be talking on mutations in carcinoma nasopharynx.
Good afternoon, everyone. I am Dr. Pratik Chandrani, PI and Assistant Professor at Medical Oncology Molecular Lab and Center for Computational Biology, Tata Memorial Center, Mumbai. I'll be talking about molecular profiles of nasopharyngeal cancer and some other salient features which we are able to learn from genomic assay. So before we move on to the data part, let me first highlight, I'm sure we all know about this, but what we have seen in nasopharyngeal cancer is a multi-step development from a normal epithelium to precancerous lesion, which are often coupled with loss of chromosome 3p, 9p, and upregulation of cyclin D1, followed by EBV infection. Epstein-Barr virus is very commonly observed in all the nasopharyngeal cancers and few other cancer types. After this infection of virus, there is a rapid tumor formation and progression phase, which is often coupled by EBV gene, which plays very significant role in the early stage of tumor formation. And at the later stage, this EBV gene LMP1 is lost, which is required for advanced development of the tumor. So these all step-by-step events are happening, and usually in the practice, we are able to detect tumor around this stage, and we generally are not able to detect tumor at this very early stage. But using several laboratory models, this has been figured out that this is most likely a step-by-step event happening in the tumor. Now, what we have seen in a single gene-based study is that TP53 mutant nasopharyngeal carcinoma have very less tendency to go for metastasis as opposed to the TP53 negative tumors. And this is very interesting because a majority of the virus infected tumors are also known to harbor much less rate of mutation, and that is indirect reason of less rate of TP53 mutations. So the EBV positive nasopharyngeal cancers harbor more metastasis compared to the EBV negative and TP53 positive tumors. Moving on to the genome-wide assay, we figured out that TP53 is present in some proportion of patients, but overall NF-kappa B pathway genes are most predominant, followed by cell cycle, cell death, and chromatin modifier genes. Now again, these chromatin modifier genes are working along with EBV to mediate their carcinogenesis, and that's why these patients are not harboring too many of receptor tyrosine kinase and other targetable drugs. However, further study has revealed that there is some activation of ERBB pathway genes as well as KRAS and other MEP kinase pathway genes, which can be useful for therapeutic targeting, although in lower frequency, but they can be very useful. And apart from NF-kappa B, TGF beta pathway is also heavily deregulated. So some of the PARP inhibitors and other similar kind of treatment strategies could be more useful compared to direct oncogene targeted therapies. We have also seen that P53 pathway is heavily deregulated irrespective of EBV infection, although the mutation rate is very low, but overall pathway deregulation is very significantly observed. The cell cycle pathway genes like CDKN2A and B are both deregulated, underregulated in the NPC tumors, and CDK4 and CCND1 are often observed to be upregulated, and these two can again be a potent therapeutic target after rigorous testing. So this basically summarizes the landscape of mutations and alterations in NPC tumors, and we have observed that majority of them are driven by tumor suppressor pathways, and hence the therapeutic strategy is different here. It is more targeting not the oncogenic pathways, but the tumor suppressor pathways. In this genomic assay, we have also learned that EBV is having 3 different variants, similar to like all the variants we are seeing today in COVID. EBV is also having 3 different variants, and that is very important here because we can see that in the GWAS data, EBR gene, which is a gene of EBV virus, is highly significant to determine and distinguish between the healthy saliva sample and NPC tumor sample. And when we do the detailed genomic analysis, we get to know that these 2 variants are more predominant in the control cases as opposed to this 3rd variant, which has these all genetic alterations in the EBR gene, and they are highly predominant in NPC cases. So that entails that maybe NPC cancer is endemic driven disease in local regional places where EBV variant 3 is more predominant. We also get to see more cases of NPC. So that's very interesting, and more detailed study of further variants of EBV should be conducted. This is only single report as of now. So that brings us to the overall summary. NPC is an aggressive and predominant in Asia. A step-by-step carcinogenesis process of NPC has been very well documented with predominant role of chromosome 3p, 9p, and NF-kappa B and PI3K pathway alterations. Furthermore, T53 and RAS alterations are also reported in lower frequency, which can be useful for direct therapeutic target. EBV infection and T53 mutations are mutually exclusive in NPC, and the metastatic potential of EBV positive T53 negative patients is much more compared to the other subset. And genomic analysis has also helped us understand the variants of EBV, specifically variant number 3 is more predominant in carcinomas, and we should keep an eye onto it. As we have seen previously, several other consultants have shown data with respect to EBV viral load at the baseline and therapeutic outcome. Along with that, we should also pay attention to the EBV variant and understand whether that has direct relation to therapeutic outcome or not. So that's about this presentation. I would like to thank the organizers and medical oncology and computational biology departments of Tata Memorial Center, all the lab members who have worked very hard. I hope next year we'll have more of genomic data. We have sequenced several of adenic cancer patients, and I'll be more excited to present our in-house data and compare it with other countries and other ethnicity. Thank you all.
Thank you, Dr. Pratik, for finishing before time. So we'll break for lunch for 20 minutes because I suppose many people already had lunch. So roughly around 2:30, we can start the last session.
Good afternoon, everyone.
Good afternoon. We will start the post-lunch session. The first topic will be what new can be expected in next 3 years for carcinoma nasopharynx. The talk will be delivered by Dr. Gautam Panda, who is a consultant medical oncologist at Tata Memorial Hospital, Mumbai.
Carcinoma. I will be talking about it in a few slides. I am not an astrologer. I cannot predict exactly what can be expected in next 2 years, but I am going to talk a bit about what can be expected in next 3 years. Next. So the flow of the talk will be little bit about the epidemiology and the risk factor for carcinoma nasopharynx, incorporation of the second dose into the TNM study, use of capecitabine and other chemotherapeutic agents in adjuvant and peripheral metastatic setting, use of intensity modulated photon therapy and intensity modulated argon therapy, use of therapeutic vaccine in carcinoma nasopharynx, adaptive cell therapy in the same, and one or two slides about the molecularly targeted agents in the carcinoma nasopharynx. We all know carcinoma nasopharynx is rare neoplasm in most part of the world. However, the incidence is more common in the Asia. The risk factors are basically some of the genetic markers, Epstein-Barr virus, nitrosamines, polycyclic hydrocarbons, chronic sinus-nasal infection, and poor hygiene. As per the WHO, there are three histological types. Type 1 is basically non-keratinizing type. It is less associated with Epstein-Barr virus, and it is a radio-resistant tumor. On the other hand, type 2 and type 3 are basically keratinizing type, associated with EBV virus and radio sensitive. Metastatic carcinoma is strongly associated with Epstein-Barr virus, and EBV has diagnostic, therapeutic, and prognostic implications in the carcinoma. Next, coming to the incorporation of the Epstein-Barr virus into the TNM study. Next. So, as we all know, Epstein-Barr virus has a prognostic implication. So, this was a study by Lee et al., in which she incorporated EBV DNA post radiation into the TNM staging. So, all the patients who were stage 2 to stage 4B and they completed radiation or concurrent radiation with the adjuvant chemotherapy and did not receive any adjuvant therapy were included, and these all patients had post-active DNA tested within the 120 days. And they classified these patients into 3 groups as per the prognostication. And there is distinct prognostic phenotype based on the EBV dynamics also. And it has been shown by authors in the Nature Communication, which was published in 2019. And they have classified the carcinoma into 4 types, that is early responder, intermediate responder, late responder, and treatment resistant, depending upon the clinical complete biological response after induction chemotherapy 1 and after induction chemotherapy 2. If it is an early responder, then you can think about running doing a future randomized trial of induction chemotherapy followed by radiation only versus induction chemotherapy followed by concurrent chemotherapy.
So in this way, the induction chemotherapy has a definitive role in the carcinoma nasopharynx in the treatment and also in the prognostic classification. Next, coming to the role of and recurrent metastatic setting. As you all know, systemic chemotherapy has a role in the management of carcinoma nasopharynx, either in the neoadjuvant setting, frontend setting, or adjuvant setting. So, addition of the adjuvant chemotherapy post-frontend chemoradiation leads to 5-year benefit of approximately 12% and 10-year benefit of approximately 13%. However, the addition of neoadjuvant chemotherapy has a benefit of approximately 6% in the 5-year OS, and it is approximately 9% in the 10 years. The point which should be taken into consideration is the divergent nature of the two graphs. The benefit at 5 years is less than the benefit of the 10 years. That is, the benefit increases as the time goes on. So you can see the OS benefit is greater with the adjuvant group rather than the induction group. However, there are some caveats in the comparison, whereas the control arm were different. The induction group was more heterogeneous, and the relative benefit in these two groups were similar. Next. So there are few issues with the adjuvant therapy. Generally, the platinum doublets are recommended. Only 60 to 70% complete the 2 to 3 cycles of adjuvant therapy, and up to 35% cannot embark on adjuvant therapy. Next. So there was search for more tolerable chemotherapy regimen. Right. So came the adjuvant capecitabine trial, which was presented in ESCO 2021 by Mia et al. So this was a randomized phase 3 trial which was done between March 2014 to July 2018. 180 patients were recruited, and adjuvant capecitabine was given at a dose of 1000 mg per meter square bidaily for 14 days, every 21 days for 8 cycles after completion of chemoradiotherapy, and the other arm was only chemoradiotherapy. Next. So we found the capecitabine as adjuvant was associated with better compliance than platinum as adjuvant, and the outcomes were comparable with the gemcitabine platinum as induction and platinum as adjuvant therapy. Next. In the same year, ESCO 2021, there was another presentation by Ma et al. In which we randomized patients into two parts, that is standard therapy versus standard therapy plus metronomic chemotherapy. After completion of standard therapy, the chemotherapy was capecitabine given at the 650 mg per meter square daily for 1 year, and the outcome was better with the metronomic chemotherapy, that is capecitabine group. Now comparing the metronomic capecitabine versus standard dose capecitabine, both are tolerable with similar side effects. Next. And coming to the outcome, also the outcome of the adjuvant capecitabine previous slide, please. Previous slide. Now coming to the outcome conclusion, this is very important. The outcome of the adjuvant capecitabine was compared to the outcome of metronomic capecitabine. However, the very important point is that 75% of the patients in the metronomic capecitabine group had already received induction chemotherapy, where the 3-year failure-free survival was comparable in the both groups. So the questions that arise is basically, is it because the metronomic capecitabine is less effective or not effective? And are we not choosing the most appropriate patient for the treatment? And what is the role of induction therapy? And does the use of adjuvant chemotherapy from any benefit brought by the induction chemotherapy? So it is very difficult to choose between them. So it takes path for the next trials, which can be basically induction chemotherapy followed by concurrent chemoradiation and adjuvant capecitabine versus concurrent chemotherapy followed by adjuvant capecitabine. There can be another trial of metronomic chemotherapy, that is capecitabine versus standard dose capecitabine. Now coming to the capecitabine in recurrent and metastatic setting. in maintenance. Next. In gamma oncology, there was a trial published in 2022. So it compared basically, next slide. So it compared basically patients for 4 to 6 cycles of paclitaxel cisplatin in category to best supported versus maintenance category. Next. So they found the median PFS in the maintenance category group was 35.9 months compared to the best supportive group, which was 8.2 months. So definitely the maintenance category group has benefit in terms of survival in recurrent metastatic setting. Next. Now there is another drug, Tegafar, which has benefit in maintenance therapy in recurrent metastatic setting. Next. In the same Reddish 2021 testing, there are only 2 minutes left. So those patients, metastatic nasopharyngeal patients who benefit from the first line therapy will randomized to maintenance therapy with S1 versus observation. Next. So they found benefit in terms of PFS and OS by using maintenance S1. Next. Next. Same. So next, coming to the use of intensity modulated proton therapy. Currently, the preferred modality is basically intensity modulated therapy because of the location of the tumor. However, proton therapy and fiber therapy has volumetric advantage over the IMRT. So there are ongoing trials which are using this. Next, immunotherapy. Next slide, please. So in the 2021 SPO, there was a presentation by Zhang et al. About the pembrolizumab versus placebo in the maintenance setting. Next. So this was a trial of approximately. So this was a trial of patients who were basically 18 to 75 years, and they had not received previous systemic therapy for the recurrent metastatic setting. However, they might have received the therapy and they have progressed at least 6 months. These were randomized into Gemcis plus placebo versus Gemcis plus pembrolizumab and pembrolizumab maintenance therapy. So in this trial, they showed benefit of pembrolizumab in terms of PFS.
Next talk will be by Dr. Vijay Patil, Professor of Medical Oncology at Tata Hospital. He will be speaking on role of checkpoint inhibitors and CAR T therapy in carcinoma nasopharynx.
Yeah, thank you. And without any wasting time, I'll move to the next slide. I don't have any conflicts for this talk. So we all know about the Zhang study. It was first time when a palliative chemotherapy gemcite cisplatin was compared against cisplatin 5FU. And to a lot of our surprise, this came out to be a positive trial both for PFS and for overall survival. There was a good increment in outcomes which was seen in this trial. The interesting part of this trial was the median PFS was around 10 months and the median OS for in the Gemcis arm was around 30 months, giving two important information. One, that Gemcis improved outcomes versus cisplatin 5FU. Second, that the subsequent PFS actually make up for a lot of part of lifespan of the patients, which suggests that in nasopharyngeal cancer, second line, third line, fourth line, and subsequent therapies need to be done. But what is now, which has come new is, a lot of immunotherapy molecules have come in the first line setting. My previous speakers have covered a lot, so I will restrict myself to this table and would point out the highlights. There are actually 3 molecules which have come. The first study was Jupiter-02. The Jupiter-02 actually enrolled patients who were either metastatic upfront or who were non-platinum refractory CA nasopharynx. GemCis versus GemCis plus toripalimab, and the PFS by an independent review was the primary endpoint. This study did show that it led to an increment in progression-free survival, and this was independent of the PD-L1 inhibition. It also showed that it led to an improvement in response rate, and the response rate was high as nearly 70% with addition of toripalimab. And what about the overall survival? You could see that overall survival curve, it's for 30 months, and that value is around 70%, which means that the 2.5-year overall survival in CA nasopharynx was around 30%. If you remember, at the start, I told about that GemCis, the median survival was around 30 months, which means by 30 months, 50% of the patients would have expired. Here we are talking about at 2.5 years, 70% of the patients were doing well. This data for overall survival was not mature, and hence the authors would be doing an analysis in future to tell us more about this data. The next study actually was again from the same institute, was called Captain, and this was with respect to exactly the same design. Just for toripalimab, they had carfilzomib, which was put in this study. See nearly similar results, very similar hazard ratio of improvement in progression-free survival, with limited events which have been happened for overall survival, and hence the overall survival data was not provided. If you could see again the response rates in the carfilzomib, the overall response rate was around 87.3%. In the previous study I had shown you, it was around 68%. Again, very, very interesting time in nasopharyngeal cancers, which we see that addition of these immunotherapy to chemotherapy are giving a response rate which are nearing now 90%. So the last one, which has not got published yet, initially was presented in ESMO. And after that, this was presented in the ASCO plenary series, which is a new program started by ASCO. And this was presented in the April 2022 ASCO plenary series. The study called Rational 309, and this is with a drug called tislelizumab. Exactly the same design what was for Captain and Jupiter, where tislelizumab has been combined with gemcitabine and cisplatin. You give gemcitabine or cisplatin for 4 to 6 cycles, and the tislelizumab continues further for these patients. And an option of crossover, which was there given in all of these studies. The updated analysis again confirmed that there was a PFS benefit in these patients. And if you looked at again, how much was the PFS2? This PFS2 was not covered in the other studies. It's not been given in detail, but tislelizumab paper again shows that there was a good advantage which is seen in PFS2, which is we have been commonly seeing in IO drugs, that if you give an IO, then the subsequent therapies also, the patient responds better and the response is sustained better. The duration of response in most of the studies of these drugs is anywhere between 8 to 14 months, which is substantially longer than what you see with gemcitabine and cisplatin, which is in the range of 4 to 6 months. What is the common theme in all these trials? All were similar trials. All had similar design, all had a very similar hazard ratio of around 0.6. OS data has not been matured for these trials. In fact, all these Chinese universities needs to be congratulated, because all of these studies were done in similar institutes, or nearly the same institute participating, and they recruited the patient within 1 to 2 years itself. So the data of OS is not yet mature. Interestingly, there is a crossover, and it would be interesting to see what impact this crossover has on survival. But another interesting thing which has come for nasopharynx is all these benefits are irrespective of the PD-L1 status. Most of these immunotherapies surprisingly do not have side effects like pneumonitis. Or mainly these side effects in this set of patients were seen with respect to the hematological side effects and fatigue. And these were manageable toxicities. And we must remember all this data has come from China. So all this data, 98% of the patients were well, which were EBV related. Whether it can be applicable to the non-endemic nasopharyngeal cancer, we actually don't have an answer yet. But this actually gives you a good glimpse that yes, not one, not two, but there are 3 molecules which can give substantial improvement in progression-free survival, and probably would lead to an improvement in overall survival in future. Now, this is about a patient who has a metastatic setting or upfront you want to treat, or a patient who has failed your multimodality treatment 6 months post. What if the patient has failed within 6 months of platinum? What in head and neck squamous cell carcinoma, we would say platinum refractory. There is a keynote 122 study in which investigator choice of therapy was compared against pembrolizumab. And if you could see this therapy, 90% of the patients still were from Asia in this, and most of the patients had at least received 2 lines of therapies in this setting. So that pembro was actually given as a second line. If you see the overall survival, surprisingly, in this study, in second line setting, pembrolizumab didn't improve the overall survival. Again, giving a clue. And I'll tell you why I'm saying that probably all immunotherapies don't work similarly. Something which carfilzomab, tocilizumab, and topotelimab would do in the first line setting, this could not be done by pembrolizumab in the second line setting. And this is where I get a surprise when I see the head and neck cancer guideline of NCCN. Because all these 3 drugs are been made by the Chinese, a surprising thing has happened in NCCN, in which the first line they do recommend gemcitabine and cisplatin as category 1 recommendation, but amongst the other recommendations, they have actually given a recommendation of adding a PD-L1 inhibitor, either pembrolizumab or nivolumab, on the basis of the data of these 3 drugs, which at my personal level, I may not agree with that, because if it needs to be recommended, they need to show that there is an improvement in outcome with these drugs, especially going by the keynote data, which shows that there is no overall survival benefit with pembrolizumab. I would restrict myself to the this thing. So the conclusion, what I wanted to point out, that yes, IO can be added to gemcitabine cisplatin. The preferable IO should be one of the 3 Chinese IOs which have got developed. I actually had contacted quite a few of these, and within a year, quite a few of them would be launching their products in India. So we might be having them. And in second line setting, pembrolizumab is a choice, but it is not the choice. It can be one of the options for your patients, but it is not the option for your patients. Now, there is a lot of going around about cardiac anti-CAR therapies. And it is more so in solid tumors which are associated with viral diseases. And hence this, Dr. Bharat had requested me to speak about them. I did a thorough PubMed search. I could find only 3 papers which are dealing in CA nasopharynx with CAR. And actually 2 of these are from the same institute. And unfortunately, both of them are in Chinese, and my Chinese is not good. So I restricted myself to the abstract. And what you got from that, this is they have developed it into the cell line. They have done first phase 1s, and they have developed it against the latent membrane protein 2A. And it does have a lethal effect on nasopharyngeal carcinoma cells. However, we need to have at least phase 2's data coming forward before we could actually recommend or even talk about more. So to conclude, it seems that IO plus chemo, the Chinese IOs of IOs, seem to be the first line therapy if it can be accessed by the patient. Second line IO, pembrolizumab can be one of the choices. It's not the choices, as other drugs, chemotherapy drugs, which are less costly, do equally well. Thank you.
Thank you, Vijay. The next talk will be on the management of oligometastatic disease in carcinoma nasopharynx. It will be given by Dr. Trinanjan Basu. He is a consultant radiation oncologist at SCG Cancer, Mumbai.
So thank you. On behalf of the organizing team, I hope everybody enjoyed our conference. So this is the last talk before we break for the panel discussion. So it's a huge topic in today's time and era to discuss about oligometastatic carcinoma nasopharynx. I'll try to just briefly highlight what local therapy role is in that. So let's start with a case scenario. So there's a 33-year-old male, no comorbs, good performance status, and working IT professional, Mumbai based, and a family of 5, all are dependent on him. So he develops recurrent nasal blockade and epistaxis with no other important clinical signs or symptoms related to cranial nerves. A CT done as a baseline showed a mass in nasopharynx with bilateral level 2 nodes with necrosis. Then a scopy showed a mass with coming to posterior nasal cavity and level of tonsil. Biopsy came as undifferentiated carcinoma. with EBER positive, and MRI confirmed that it reaching till nasal cavity and had clival erosion as well. PET-CT had more or less similar finding with high uptake in primary and node, as well as picked up a left iliac bone 2 centimeter deposit with SUV close to the nodal uptake. The auditory ophthalm are acceptable with acceptable blood parameters. So about maybe a decade back or so, it would have been stamped as a metastatic disease and would have sent for chemotherapy. But how things have changed, let us try to see. So there are a few important points to understand in a metastatic scenario. That is, all M1 similar or are there subclassification? How does it matter to the prognosis? What would be the intent based on that? What should be the sequencing of treatment? Whether to treat local disease and how to treat it, as well as also to treat metastasis, like something called metastatic directed therapy. What evidences we have based on that, and what would be a future perspective? So the concept of this metastatic and oligometastatic disease, which is a very much in practice nowadays and in news, came a long back, about 25 years back, by Hellman and Weisselbaum. Then there are different definitions. For a radiation oncology perspective, the ASTRO and ISTRO has given a consensus statement about a year back. So we are more bothered about basically the synchronous oligometastatic disease, because that is what is bothersome for nasopharynx, because other subcategories of oligometastatic disease are dealt in a bit different manner. So the synchronous ones are which are diagnosed at the time of initial diagnosis with primary tumor and should be having a limited number of metastases, more or less accepted are less than 5 metastatic lesions with an active primary disease as well. So if you look at the AJCC 8 stating, it has still to come into it, and metastatic is metastatic in that, which is directly an M1 goes to a stage 4B. But once we talk about nasopharynx, there can be two kinds of M1. One based on the radiology, second is incorporating plasma EBV DNA. Now, most of these works, as we're hearing since morning in nasopharynx, is done by more or less a single institute in China with consortium of other institutes. And it's really commendable, like Vijay said, the way it is done, from the diagnosis to therapy, to recurrence, to retreatment, everything you have an answer for that. So what they first tried to do is do a radiological M1 subdivision, which is different people have done it different ways. Some have done M1A, M1B based on the number. Some have done with the organs involved and also classifying it into the different categories. So more or less on radiology, it can be an M1A, which means a single site with a single lesion. Moment it's multiple lesions in the single site, it's B, and multiple sites, multiple lesion goes into M1C. Now, some of the classifications also have considered distant lymph node, bone, lung, liver, and number of lesions and permutation combinations of them to classify as oligomets or polymetastatic. As we advance in technology, more of AI and advanced machine learning come into play. There are recent publications of doing a 10 variable of this M1 classification, which has 3 clinical and 7 hematological parameters, and dividing it into an M1 low and an M1B high risk. So you can see the different definitions given in here. And I feel, it is a personal opinion, it's just going to get more complicated. So now, after you incorporate plasma EBV DNA, it is going into a further subclassification. Whether you have a metastatic lesion, only one, a size low with a low EBV DNA copy, or more lesions with a low EBV DNA copy, or you have number of lesions less or involving a visceral organs and higher EBV DNA. So all these have also published data that how they're actually impacting the survival and why these works are being done. So this is also an important aspect in oligometastatic or a de novo metastatic nasopharynx. So does it impact prognosis? Yet it does. If you have a limited metastatic disease like the M1As, be it based on size, be it based on organ involved, or a low EBV DNA copy, then it definitely have better prognosis proven by all these studies which are quoted. It is important to do an aggressive treatment for them. There's definitely a role of local radiotherapy in them, and bone only M1 NPC have the best outcome. So across from 2015 onwards, these different authors and published their data limited metastasis, good performance status, and visceral involvement. All these impact the outcome. The more you have involvement, more the worse outcome. It also depends on less than 5 site or more disseminated on the overall survival. You can see about a year difference. Improved 3 years overall survival by adding loco-regional radiotherapy with concurrent chemo after the initial chemo on different publications. And bone-only oligometastatic nasopharynx actually has multiple publications with an improvement in overall survival by treating the local disease, but a conflicting data on treating the metastatic side, whether it is impacting the survival or not. But yes, definitely a more than 4 cycles of palliative chemo has a role in improving the overall survival across publications. So, and this is a review from in head neck recently on the a new proposed of 4C maybe for nasopharyngeal cancers, and depending on this different multivariate analysis factors, you can see in the survival curves that always when the local therapy is added, and always when you have limited number of lesions, limited site involves, and low EBV DNA copy, there's always a better outcome. Similar things is published in a Green Journal sometime back on the metastatic nasopharyngeal cancer patterns of care. And if you see both in 1 year, 2 year, 3 year, always the curves are separating when the local therapy is added. And if you see the forest plot, in fact, across all sub categories, it is showing benefit of adding the local therapy. Then we came this randomized data published in JAMA between adding a loco-regional therapy after the initial chemo or continue with the chemo alone for de novo metastatic nasopharynx, and the curve speaks for itself that how it has helped in progression-free as well as overall survival. So if I come back to this case, so this was a young fit male who is expecting a long-term cure. The point of all dependent family members is to highlight that. And he is a classically bone-only M1A oligometastatic nasopharynx, should be treated with curative intent. So the responding cohort of the oligometastatic should then receive a loco-regional radiotherapy. This concept is also an extrapolation of published non-head neck data of be it Saber Comet or the Stampede. These two trials, especially the Saber Comet, has hardly any head neck patients. They're not related to this, but it has given an overall paradigm that how this treatment can be improved in terms of survival. So there also parallelly advancement in technology as well as the concurrent regimens, and with acceptable toxicity, these patients can be treated with curative intent. So what should be the sequence? It's to begin with chemotherapy, no doubt, but there are definite a bit of confusion that how many cycles one should receive. Some articles or data suggest complete 6 cycles, then some do sort of a sandwich treatment and then do an interim response assessment before doing the local radiation. So it should be a platinum base beyond doubt. The cis-GEM is been proved by the Zhang Li data. Should be receiving total 6 cycles. Most of the data have done interim assessment and do a local treatment with concurrent chemo, and response to be assessed by both MRI and PET, and also to incorporate plasma EBV DNA, as we can see from the ESMO-European guideline, as it is important. We have seen in other data also. So for loco-regional radiotherapy, it is more or less a similar dose and volume as we would have covered in primary nasopharynx with a concurrent chemotherapy. It initially started with a symptom relief, but gradually with over the years, we have realized a definite survival benefit. There's a definite dose response as well. Dose more than 66 gray should be given. It should encompass primary as well as node. IMRT is highly recommended. Now, RT to the metastatic site can be a pure palliative or maybe an SBRT with some data coming up. There's some query in terms of survival benefit by treating the metastatic site, but definite benefit by treating the local site. And if you have lung or liver mets, then all these options of SBRT or metastatictomy or RFA can come into play. So these are various studies. I'll skip that can be that have used loco-regional radiotherapy with their outcome. And of course, as every field progresses, be it in the medical oncology, be it radiation, some different drugs and different trials, like Vijay has highlighted for anti-PD-1, and also in terms of SBRT, there are some data which is in abstract format published in Astro last year, which are doing after the initial chemo SBRT to all amenable sites, be it the primary, be it also the metastatic sites, up to 5. So these are the trials going on. Actually, I'll just need maybe half a minute. So for oligometastatic nasopharynx of different newer PD-L1 therapies and incorporating SBRT into that, so we'll have to wait how these paradigms would evolve over the years in treating these cases. So I'll take these take-home points. Sharvani ma'am has written an invited editorial, if I'm not wrong. This is the first issue of Bengal Journal of Cancer, which recently launched. There's a very good take-home points given in that 2-page editorial. It is very important to do a staging of M1 nasopharynx before jumping into treatment. There should be accurate assessment between limited and disseminated disease. Utilize your technology well. Consider strong and effective systemic therapy. Try and prognosticate them with EBV DNA, though there are logistic issues in that, and keep on documenting toxicity and quality of life. Thank you. So we have now the last panel discussion. So moderator would be Dr. Vamshi Krishna, is Director Medical Oncology from AIG Hyderabad. And I would call upon the panelists. So we have 3 medical oncologists, Dr. Sunil Chopre, Dr. Avinash Talele, and Dr. Rakesh Piniti. We have 2 radiation oncologists in this panel, Dr. Bhushan Jade from Pune and Dr. Kinjal from Ahmedabad. And we have 2 head neck surgical oncologists, Dr. Shilpi Sharma from Gurgaon and Dr. Saurav Datta from Calcutta. So over to you, Vamsi.
I think, yeah, Shruti is there online. Dr. Shruti, are you there?
Yes, I'm there.
Okay, great. So it's been a fascinating 2 days. It's very nice to discuss topics which are generally not discussed, and also nice to talk of things without MIBs and IBs and all that stuff only. So these 2 days have been very interesting because we have discussed some unusual or rather rarer tumors. Hopefully we'll end on a good note. I'll be just asking questions mostly. Okay, the case I have kept is more for illustrative purpose. I'm not going to go too much into the case. So request to the panelists, just don't hammer on points in the case itself. It's a 53-year-old male. He presented with neck masses bilaterally. Slides are not visible. There's visible here. Okay. Yeah, sorry. So 53-year-old male presented with neck masses. On evaluation, found to have a nasopharyngeal growth limited to the nasopharynx and bilateral neck nodes. Treated with induction, I'm sorry, that should be induction. 3 cycles of gemcitabine cisplatin followed by CTRT with concurrent cisplatin. Pretty much, I think, a standard option at this point. So let me start off with the surgeons first, because these patients do come to us. Dr. Saurav. Dr. Saurav, you're there? Yeah. Oh, there. Yeah. I'm sorry. I don't know everybody on this panel. We just met.
To be hidden somewhere in metastatic and recurrent.
So I am asking you a question, but so in a nasopharynx, patients would come back to you. What is your normal response that you expect in terms of response rates, and how do you assess these patients as a follow-up?
So normally these patients are treated by our radiation oncology and medical oncology colleagues. They follow up. The only thing they send us for a response assessment for clinical DNA. So they want, say, diagnostic nasal endoscopy for us.
Okay.
But at the same time, I think doing a PET CT scan for response assessment after maybe completion of 3 months treatment would be better.
Okay. Dr. Shilpi, do you agree with that? 3 monthly PET scans or 1 PET scan and then just clinical evaluation?
Yeah. So I would look at the, first of all, the pre-op staging. Like this patient had multiple lymph nodes and we had done PET CT before starting the treatment. So it would be a good idea to follow up with the PET CT at the first follow-up, which is done at 3 months.
Okay.
And then, of course, it is not necessary to repeat the imaging at every follow-up. But yes, clinical examination is must, which has to be done by endoscopic nasal, basically nasopharyngoscopy, which we do by using the nasal endoscope, and of course the clinical examination of the neck. So if the patient is controlled loco-regionally, then I would not do MRI or a PET CT at every follow-up.
Very good. Dr. Kinjal, you're agree with it by and large?
By and large, yes, but no, I would repeat the PET CT because this is a systemic disease. So I would be tempted to do a PET CT maybe after 6 months or maybe after a year if everything is under control.
Okay. Checking for a PET CT after 1 year, I'm not sure. I mean, these are not guidelines based, but yeah, I guess in practice we can do
one more thing, like if the patient has got intracranial extension to begin with, I'll do MR also.
You'll do MR also.
For the response assessment and the toxicity also.
Very good. So let's come to something which we all love, especially from TMH, maintenance metronomic therapy. Dr. Shruti, can you hear me? Dr. Shruti?
Yes, sir. Yes, sir.
Great. Maintenance metronomic therapy in CA nasopharynx. Would you go for it? Would you not go for it at this point?
So for a very advanced disease, I would want to go for it.
Drugs used?
Yes, metronomic capecitabine for at least a year. It has, yeah. So 650.
Yeah, Dr. Rakesh, do you agree? Do you do this routinely?
I don't do it routinely, but if the patient has a baseline EBV titers and at the completion of treatment, there is some amount of EBV that has not become undetectable, maybe that patient will be stressed with a bit more metronomic chemotherapy. The data is not there with us, but
are you doing this routinely on a practice? Because I have never done it. So I don't know. Vijay can give me example from TMH if you guys are doing it, or EBV DNA titers for all nasopharynx. Was as such, nasopharynx is mostly non-EBV in a lot of our patients. So I don't know. Are we doing it routinely?
Yeah, I am doing it.
And have you found it to be elevated?
Yes, it is elevated for most of them.
Most of
them. And it is coming down, and that coming down is actually undetectable in some and it is detectable in some, but we don't differentiate as of now in the adjuvant phase. But with metronomic therapy around, probably there's a good idea to continue metronomic therapy for those patients who have detectable EBV titers.
Wonderful. Dr. Avinash, do you do this in practice? Because again, like I said, honestly, I don't.
I have recently started doing that.
EBV DNA titers and then follow up in the fall. So EBV better than PET scan. So I think our medical oncologists have decided blood is easier to draw and check rather than doing a PET scan each time. I think that's a criticism which people make of oncologists, that we like doing PET scans. So we have graduated to doing liquid biopsies now.
So I'm not very habitual, but is this means exclusive? If I am doing EBV, then I don't have to do PET CT, or it's mutually, you have to do both?
Rakesh, you want to take that since you're doing it on a more regular basis than
EBV DNA for now is only academic. I don't think so I'm going to really bother by explaining to the patient regarding the importance of it. But it's mostly prognostic. It's probably useful for following up patients at the time of 1 year, 2 years, and subsequent. Because I think at any point of time, if the patient is going to relapse, I think the EBV titers are going to raise, if at all it is baseline raised, before he becoming, overt metastatic disease or something like that.
Rakesh, I really envy you. Your patients are very nice. My patients call me up when the ESR goes up, and your patients don't trouble you when your EBV DNA titers will go up. Great. So actually, whatever has been said, there is some basis for this. There are now papers coming out which say that you can follow up on EBV DNA, and that actually correlates with a relapse. And again, like he says, it's not as of now standard of care, but it is being done. Rakesh, any thoughts on ctDNA or CTC? Are you doing that or?
Not doing it, sir.
You're not doing it right now. Okay, great. So anyway, in this patient, it was a very advanced disease. Within 2 months of the disease getting over, this is what happened. Now the local relapse is there. It's a large lesion, right petrous body, right side of sphenoid. No real intracranial extension. I can't make out this, but they have not commented. But now there are lung mets as well. So within 2 months of completion of therapy, this is what has happened. So it's a bad disease to begin with. Right. So coming straight to therapy at relapse. So if I can ask Dr. Kinjal and then Dr. Bhushan, how often do you see this? I mean, properly treated CT, given CTRT, pre-induction also given. Is this something commonly seen? What do you look for?
So this is not a very common scenario because nasopharynx being a very sensitive tumor both to chemo and radiation, not that commonly seen.
Right. Okay. I think most of us would agree, like Vijay was telling us, these are diseases which respond well to treatment. So how do you decide on the first line therapy? Dr. Shruti, patient has come to you with a relapse. So what are the factors that you use to decide the first line therapy? Not necessarily this patient, as in general.
So the performance status of the patient, comorbidities, toxicities from the previous treatment, platinum-free interval, definitely. Whether it's an oligometastatic disease or not, locally recurrent disease, whether it is operable or not. And so re-radiation, any feasibility of that. So all that.
Okay. Dr. Avinash, time to relapse. Is it as defined as you have in the rest of the head and neck? You have that 6 months cutoff. Would you say that platinum-free interval is the same for nasopharynx?
But sir, it is usually what we follow is 6 months.
Okay. Is there any data to say this or any guidelines?
No, I'm not aware of
Dr. Rakesh, are you aware of a guideline to say? I couldn't find it actually. So I'm just asking.
I think, sir, the same principles that apply for the head and neck cancers should extrapolate to the nasopharynx. I won't be very keen on giving platinum for this patient who has relapsed within 2 months.
Okay. Doctor, I'm sorry, I didn't catch your name. You are also in the panel. I couldn't catch your name. Yeah, Dr. Sunil. Sorry, I couldn't catch your name when you were coming on stage. So your take on this, would you agree that you have a time to relapse? How important is that?
So as such, it is not defined, but as this patient is relapsing within 2 months, so definitely it's not a platinum sensitive disease.
Okay.
So would like to first assess for his performance status, and then would like to assess for the some molecular markers. Maybe we can.
Okay,
get
I'll come to molecular markers.
Testing, though there is no role in first line, but would like to
okay. So as soon as I said I'll ask, he said there's no role in first line. Great, we got your answer. Dr. Kinjal, patient has come to you with, say, the same patient with a single bone met. What's your thoughts on the oligometastatic treatment? Would you just radiate it with Saber, Comet, and what all Triranjan was talking about?
Yeah, so I agree. I agree with what Triranjan said. You know, if it's a patient is a fit patient and there is a oligometastatic, maybe one bone metastasis, and there is no other disease anywhere else, I would be definitely thinking about a curative attempt with an SBRT.
Even if there would the time platinum-free interval matter?
No,
it doesn't matter. I'm very surprised. Yeah. Disease remains the same. Medical oncologists put our head and say, no, this is platinum-free. We will not use this and do that. But radiation over 2 months later, single oligomet would still give only Saber. Yeah, it's an interesting thought.
Yeah, so Saber followed by some form of systemic treatment.
Saber followed by systemic. Yes, Dr. Saurabh, you are saying.
See, basically, the basic difference between the systemic treatment as a local treatment. Radiation is a local treatment. We are not re-radiating the same area. We are talking about a spatially different area. Okay. So we can, but if you give any chemotherapy, it goes everywhere. So giving chemotherapy, well, the treatment side is different, but the chemotherapy exposure is all over same. So probably that's the reason.
Okay, Dr. Rakesh, you agree with this because it's a systemic disease. That's what we started off by saying. Nasopharynx will relapse. That's what Dr. Saurabh started saying. It will relapse systemically. Do you agree with this? 2 months later, relapse with a single bone met. Just Saber it and leave it, or give Saber and systemic therapy as well?
I would agree with my radiation colleague, and I think this being a systemic disease, but the radiation is given for local site. I think there is still role for a palliative radiation therapy at the metastatic sites. If it is oligometastatic, then it will be Saber, and probably there's no role of any systemic treatment as of now.
No role, even if
there is no data to suggest that there is going to be some benefit.
Okay, so let me come back to the surgeon. Supposing this patient has an isolated neck relapse, Dr. Saurabh, would you be tempted to go in and do a neck dissection? Maybe if this happens after 1.5 to 2 years.
Oh, definitely. If there is an isolated neck recurrence, there is nothing else anywhere else, and if it is a operable neck node, definitely we can go ahead and do a neck dissection.
Okay, Dr. Shilpi, what about, say it's near the skull base? I mean, we have good skull base surgeons. A skull base surgeon says, yes, I can take it out. Would you still be okay with that?
You mean local plus regional?
Yes, local. Only local, no regional.
Yeah, so that also depends what is the amount of the relapse. I mean, whether it is a small recurrence or it is going into the skull base. And in general, what is the time interval between the two? Because if the prognosis is good and if it is worth operating, that I think that would be the best thing to do, because the surgery, yes, would be morbid with the skull base erosion, but if it is operable without much morbidity, then it would be worth giving the chance, because as we have seen, Dr. Ashwini also, she shared the data that in recurrent diseases with the randomized control trial, now we have evidence also that in recurrent cases, surgery has favorable results over the radiation.
Okay. So again, I'll ask you the same question as the radiation people. If it happens after 2 months, would you still go with a neck dissection? Or you would say give systemic only? Or do you have a time interval? Like we are saying 6 months in medical oncology.
You are asking me?
Yeah.
So 2 months, if you are, means there was if there is only uptake in PET CT, there is only uptake in the neck. There was a debate in Sarvani Madam's panel, and how long we should wait. So I think majority were in favor of waiting till 6 months, because a lot of time the uptake may go down. So if it persists beyond that, or if there is a large node we can palpate and we are not expecting it will go away, then we can go ahead with neck dissection again if it is an operable node.
Okay, so again, it's very interesting to see the difference in the medical oncologists. We are saying very clear, it relapses in 2 months. Let's give systemic first. A radiation guy says it's a single lesion, I can saber it. Surgeon says single lesion, we can remove it. So interesting. I mean, it's just the way it is. I think there are no guidelines here. So whatever we do is by and large pretty good. So long DFI is probably something that's going to work.
I think surgery role It's always, if it is a residual or recurrent, it is in the loco-regional region.
Yes, okay.
We're not talking about it is a distant metastasis or a systemic thing. Means we are not talking about it. If it is a residual or recurrent in the local or regional side, we can think about surgery.
Single lung met after 2 years. I'm putting you on the spot. Yeah, I know. I understand. I understood what you're saying. It's mostly a regional thing that you would like to operate, and as you very rightly,
single lung nodule, not only for nasopharynx, but also for a lot of one's other head and neck cancer. Also, the role of surgery, oligometastasis, is a matter of debate and lots of. So Japanese, they prefer to do surgery, but lot others they don't. So
very good, excellent. So what about re-radiation? Doctor, I'm talking now about loco-regional relapse. Say it occurs after 2 years, 3 years. You have some neck and surgeon for whatever reason, or you don't want to send to the surgeon, you can re-radiate. So what's your thought? Is there a role for re-radiation, and do you have again this time gap? Because head and neck, they say 2 years at least you should have. Dr. Bhushan, you can take it first, and then Dr. Kinjal.
Right. So basically, see in nasopharynx, whatever re-radiation data we have in head and neck region, I think nasopharynx is one of the most commonest site for re-radiation. And yes, disease-free interval matters on two aspects. First is disease biology. A disease which is coming back in 2 months, 6 months time is a bad disease as compared to what we get after 3-4 years. And feasibility of re-radiation, like body has got a radiation memory. So more the disease-free interval, or say interval between 2 radiation, we have a better chance of pushing a higher curative intent doses of radiation. And yes, if it's a small nodal recurrence which is pretty much operable, preference would be, instead of re-radiation, a different modality which is not used earlier is the radiation. But if it's something which is not operable, say stuck to some vital structure, nasopharynx, which is difficult for operate, we'll definitely go for radiation.
Okay. Dr. Kinjal, how much can you read? When my very poor knowledge of radiation, whatever I picked up from my colleagues in radiation oncology, they say that, okay, we are given 70 last time. Now probably we'll end up giving 40, 45. We can't give much more than that. Is that correct? Or do you think you can re-radiate?
Yeah. So again, it depends on the DFI. If there is a more amount of time, which has passed and patient has failed maybe after 2 years or maybe 3 years, you can go, but routinely for a re-radiation, we keep the dose around 60 to 66 gray. We don't go beyond, like we cannot go up to 70. It's very tough to go.
But you can go up to 60 post.
Yeah, we can go
after 2 years.
After 2 years. Again, we have to see the dose to the carotids. As ma'am mentioned very nicely in her presentation, that the structures which are to be given the first priority, specifically for the re-RT, you have to worry about the dose to the brainstem, the spinal cord, the carotids. We are not worried about the parotid here. We are worried about the carotids.
That's okay. IMRT doesn't cause problem to parotid. We all have been hammered, that thing has been hammered into all non-radiation oncologists. No, but anyway, I will quote you next time I talk to my colleague. IMPT, I think that's the new buzzword for everybody. So Dr. Bhushan, IMPT, yes, no?
Yeah. See, basically, these are all forms of conformal radiation therapy. We talk about 2D, 3D, IMRT, IMPT, or whatever. These are, so whatever tool you have to use a best tool for conformality of the particular, so that the toxicity of radiation to the surrounding structure would be less. Now, proton therapy is there in India, but we have a limitations of centers. We have limitation of
That's
cost.
okay. I'm asking you.
So whenever feasible, why not? Yes, why not?
Whenever feasible, IMPT is
perfect.
Okay, very good. So, Dr. Shruti, when patients come to you as a relapse, would you go through the normal MDT, go through all this, or directly, like all medical oncologists want to do, just jump the gun and start off your chemotherapy?
So I would definitely want to take the patient to the MDT whenever there's a relapse or recurrence for all head and neck cancers for that matter. And take the opinion of the radiation oncologist and surgeons. But many a times it is not practically possible. So it may not happen, but that's the ideal situation. Yeah.
Sure. No, wherever feasible. I think everyone is kind of saying the same thing, that where it is possible only we'll go. Okay. So Dr. Sunil, you started this thing of testing. Would you test PDL1? If yes, how and what probe or what clone? We'll come to core medical oncology territory now.
We'll do PDL1 testing.
You will do, okay?
Yes, yes.
Okay.
Though the role is dicey, but would like to do it. Maybe the PDL1 positivity will help us deciding second line immunotherapy.
Second line immunotherapy. Okay, Rakesh.
If it is a non-keratinizing, undifferentiated nasopharyngeal carcinoma, I don't think so. PDL1 is going to make any difference for systemic treatment. As of now, PDL1 has been shown to have no relevance in undifferentiated non-keratinizing nasopharyngeal carcinomas.
they actually, the study shows that most of them are PD-L1 positive. Some 70-80% are supposed to be PD-L1 positive. Dr. Avinash, your thoughts? Would you do PD-L1? Would you do NGS?
Now, front setting, there is I would go for a comprehensive NGS testing in this.
You would go for comprehensive NGS. Very good. What are you looking for? I mean, NGS can't be just done. We need to do something on the action.
So I will looking for the actionable
mutations. Nasopharynx, any idea what could be the actionable that you're finding? I mean, would you find a PIK3 mutant? Would you give alpelisib in the first line based on a PIK3?
So not on first line, maybe somewhere down the line.
Okay, Dr. Sunil, your thoughts. You started this saying that we will do comprehensive
Yes,
mutations.
I will do
You will do
NGS.
comprehensive. So
I would
same
like
question.
to do NGS
PIK3?
in all solid tumors.
Yes.
To search for actionable mutation.
Okay, what are the actionable that you expect to find in a nasopharynx?
I know there is a very limited data, or there are no such mutations at present. But if I get some mutation, would like to use the targeted therapy.
Okay.
Like as you said, sir, if I get PI3K, I would like to use maybe everolimus we can use.
Everolimus. Okay, PIK3 for everolimus for PIK3. I think that's a whole discussion. Rakesh, any personal experience of doing it? I think
I've never done NGS, sir. I think the discussion today during the molecular diagnostics, there was a session there, and it was clearly shown that none of the TK are going to effective here because the most of the tumor suppressor genes are getting affected rather than a oncogene that is getting affected. So probably there's no role of any
NGS. I kind of agree with you. I would, again, probably in a research setting, I think it's okay to do it. I wouldn't push it to be done in the first line normally, personally. And PD-L1, again, like Rakesh said, I don't do it because, well, we don't have any evidence right now that PD-L1 would impact our treatment. So that really brings us to the next question of what treatment do we give? Dr. Shruti, first line, yeah.
MSI.
Yes, MSI, please. The NGS covers MSI, but yes, other than that, MSI would you test for? I wouldn't normally do in head and neck, but
I have not done it before, so
yeah. Dr. Avinash, any thoughts? Have you done MSI for head and neck? I haven't done, so I really don't know. No, not done. Shruti, any experience of doing MSI head and neck?
No, sir. But I would want to do a TMB.
TMB, okay, that's the new, okay.
If really I want to, I have a patient, supposing, who is affording for immunotherapy, I would want to do a TMB and PD-L1 testing. And if the TMB lays like more than 10, then or even if the PD-L1 is negative, I would want to, keep immuno above chemotherapy. So,
okay, so let me put you on the spot, Shruti. Let me put you on the spot. You have a CPS of 5. What would you do? You have you have done your PD-L1 testing. CPS has come as 5. What would you do?
To CPS more than 1%, I would want to give immunotherapy. If the tumor
based on what data? Based on what data for nasopharynx? Again, I'm just asking because I am not aware of any data where they have actually looked at CPS and done it. So
though the data is not supporting, but the guidelines do say that you should choose immunotherapy, especially pembrolizumab, if the CPS is more than 1, and especially even for the TMB, the guidelines do say that that is what is the preferred dose. So
as a matter of interest, how do you test the TMB? Which panel? You use 200 gene or 500 gene panel, or you are testing based on a 500 gene panel, or?
So as of now, I have not done TMB in nasopharynx in isolation. As a part of NGS, I have done in other tumors.
Okay, as part of NGS. Very good. So anyway, let's come back to what is, I think, probably a bread and butter, that is the chemotherapy. To Dr. Sunil, your thoughts, which chemotherapy, doublet versus triplet, what would you want to use?
I would like to use doublet.
Which one?
Maybe Gemcis.
Okay. Avinash?
He has already received Gemcis.
Okay, forget about this patient. In general, let's say first line would be?
First line would be Gemcis because they are tolerated.
Rakesh, Gemcis?
Yes to Gemcis, sir, and even yes to the triplet as well.
Yes to triplet, okay.
Because the maintenance treatment of capecitabine was done in TPF. So say there is some credit to, if at all you are planning to use some sort of...
That was in an adjuvant setting, not in the metastatic
even in metastatic settings. Even in metastatic setting.
Okay. So metastatic, this is the only systemic review that I could find. It was very interesting to me. Actually, here Gem Platinum, Taxane Platinum, and triplet was used. Triplet had the maximum response rate, but otherwise did not show any benefit. And of course, triplet will have more toxicity. Interestingly, in this paper, the Packley the taxane platinum had a better response as compared to GEMS. I mean, I don't know. I mean, but still the category 1, as Vijay had also shown in NCCN, is GEMS only. So based on this, I don't know, but at least this is what was there. So again, Rakesh, Jupiter 2, Rationale 309, and whatever the third one was, names which Captain, yes, Captain. So randomized trials, toripalimab, tezepelumab, and the third one is I think
Cambrelizumab.
Cambrelizumab. Thank you very much. Yeah. So 3 things which even I can't pronounce. All of them have shown benefit. PFS going up to 11.7, OS going up. The final OS results are not available, but significant response everywhere. So based on this, would you give only chemo or chemo immuno?
Sir, I think there are at least 3 clinical trials now with similar numbers. I don't think so there is requirement of 4th or 5th with pembrolizumab and nivolumab. I think they are going to give the same results.
So you can extrapolate all IO data.
I would extrapolate to the existing IO data.
MSI stage 2 comes to you tomorrow, Rakesh. You're saying, okay, I will give pembrolizumab. I will not send to radiation oncologist. I will not send to surgeon.
No, I never said that. I'm
the
saying
same principle. It's the same principle.
No, it is not the same principle. So I think the metastatic disease has to be risk stratified. There is a nomogram saying that there will be high risk patients, there will be low risk patients.
Okay.
Those patients who can be taken up for the metastatic site, SBRT, as well as the primary site, IMRT. So we need to, tailor make it for individual patient.
But you are happy with the data to use a Nivo or a Pembro in India?
I'm more than happy to use it.
So Keynote 122 gives you negative OS in a second line, but you're happy to use this in first line.
That is completely a second line data. I think we cannot just extrapolate it to the first line data. I think it's a positive data saying that it has less toxicities. It is not completely out. And even in second line, the pembrolizumab even has a similar benefit with that of chemotherapy. It has a lot less toxicities.
Okay.
So I wouldn't completely disregard pembrolizumab in second line as well.
Avinash, you also thought of, so other than PDL1 and all, immuno in first line in nasopharynx?
No, so I will still wait for some.
You would wait for a Nivo or a Pembro to come in. Okay, Dr. Sunil. So
not in first line.
Not in first line. So Rakesh, you're isolated today. Shruti, what would you do? Would you add immunotherapy to your chemotherapy? Let's forget the PDL1 part of it. Supposing PDL1 negative, would you add the two? And do you agree with Rakesh that yes, all immuno are the same?
I agree that all immuno are same at some level, and the idea is to the idea is to the mechanism of action is different as compared to chemotherapy, and you cannot continue chemotherapy beyond a certain point. So I would definitely want to offer addition of immunotherapy, the available agents at the moment, to chemotherapy to an affordable patient, so that you bring the tumor down and then try to maintain it with immunotherapy. Get a result.
Okay, I can see Vijay is smiling, and I can see some smiles here and there. Again, I think this is going to be a divisive issue. I personally am a bit of a traditionalist. I think that if a drug, you cannot, these are not the same drugs. I don't personally feel that all immuno are the same drug and you can interchange one wherever you want. Otherwise, you would not have had durvalumab negative trial, atezo negative trial, so many negative and a few positives.
But sir, we have 3 clinical trials,
yes,
all from China, all from different immunotherapy drugs. All of them are PD-1 inhibitors.
Yes.
And at least one drug has some amount of open domain, some information that it is cambrelizumab is targeting some other, PD-1 epitope. But other 2 drugs, we don't have any data regarding how they are acting, how they are generated, how they are, what is the mechanism of action. So I'm just saying that 3 clinical trials have shown equal amount of benefit, absolutely same study design. Why to wait for a 3rd or 5th, 4th or 5th? I think available drugs are good enough.
Again, my counter argument to that is you knew pembrolizumab worked in lung. We know that Nivo EP works in lung. Why hasn't Durva worked? Why hasn't atezo worked?
It's a PD-1 inhibitor. It's a PD-1 inhibitor. So the class of drugs are different.
Okay.
And as long as the class of drugs are same, I don't think so there is a difference of clinical utility of those drugs. I think Nivo, Pembro are probably competing with each other in every domain.
So can I flip the question and ask you, this patient, for example, who is a platinum resistant or a platinum pre-treated patient, Pembro has been negative. So what's the point of adding Nivo there or any other immunotherapy? Would
so
that also
this patient is platinum refractory. So this, yes, I think it's still the same discussion. Okay. We have the data from pembrolizumab, so we should use pembrolizumab if at all the patient is not tolerating the chemotherapy.
Okay, so this is what Vijay showed, and I completely agree with him. I mean, I am not really sure how Pembro and Nivo can be added based on other immuno, because if that was the case, all these Chinese ones should have been approved in other cancers. But we see that FDA has rejected everything, saying that they are from China. So I am not sure how to take that. All right, let's see if the patient has been given chemo, has a very good response to it, almost a complete response. So Dr. Kinjal, back to you. Patient has either not received radiation previously or was an upfront metastatic disease. We give GemSys. 4 cycles later, there's almost a complete response. Would you like to do any consolidation RT here?
So patient is already metastatic, right?
Is metastatic to begin with a few lung mets, has been given 4 cycles GemSys, almost complete response in the lungs, little bit uptake still there in the neck, maybe or may not be. Would you want to do anything there?
Yeah. So again, depending on the burden of the metastatic disease, we would be thinking about the consolidation RT. So as you mentioned, if there are like few nodules in lung and they've responded to chemotherapy, yeah, I would be tempted to go for consolidated RT. Yeah.
Okay, Dr. Bhushan.
So basically, we are talking about de novo metastatic disease.
Non-irradiated.
Yeah, given chemotherapy, fantastic response. We will be consolidating primary. At the same time, we will be consolidating metastatic sites also, but depends upon how many number and what is the volume. But whenever possible, yes, definitely yes.
So this was actually a paper in ESMO 2019. A reasonable number, 2,170 patients, 126 who had a CR or even a PR after cis-5FU, not with GemSys, cis-5FU. They were randomized to continue only chemo or give CTRT, and they found that addition of RT significantly improves the overall survival with a hazard ratio of 0.42. Again, I think 0.42 hazard ratio is something we can't really debate. And it clearly says that if a patient has responded, please go ahead and give your consolidation CTRT. So I would personally push my patients for that. Coming to TKIs, Dr. Rakesh, thoughts on TKIs? Would you give it as a monotherapy? Would you want to combine it with a triple metronomic?
I think metronomic is only in the adjuvant and maintenance. In
the adjuvant trial was negative, by the way. Post CTRT head and neck adjuvant trial was negative.
Not head and neck, sir. No, the nasopharyngeal.
Yeah.
Nasopharyngeal adjuvant metronomic.
Okay.
Versus maintenance capecitabine is the only way I would use the.
In metastatic setting as well, would you give it?
No, I won't think so. In nasopharyngeal carcinoma, I would give it.
Okay, fine. Avinash, your thoughts? Would you, finish your GemSys, put the patient on an erlotinib, something like that, or would you just, since there's no data, I'm just asking what you would do?
No, so I'm not aware about any benefit.
There's no data. Yeah. There's no data. There is some data which has shown use of erlotinib, use of other such TKIs in the second line, but not as a maintenance.
Not in the maintenance.
Not as a maintenance. Very good. There is some risk which is there of TKIs. Yes,
I did actually show that giving oral capecitabine in this patient, if I'm not mistaken, did lead to an improvement in outcomes.
I am not aware of the paper, but in general, capecitabine metronomic has been given in adjuvant. That's what Rakesh is saying.
I'm not talking about adjuvant.
I know. I understood what you're saying. I'm not sure of that paper. I really don't know. Must be there. I have to look it up. Right. So that kind of brings us to the things we know about. So let's just spend a couple of minutes talking about things we don't know. At least I don't know anything about. CAR T cell therapy. Sunil, any interest giving CAR T cell or putting your patient into a CAR T cell? No idea. Okay. Avinash? No, Dr. Shruti, your side does lots and lots of trials. So any CAR T therapy comes in, would you like to push your solid tumor patients into it?
Yes, if a trial comes, definitely all the patients should be enrolled. The eligible ones should be enrolled in a therapy like this because it has been successful, and we definitely do not have a lot of options. So why not include the patient in the trial and reserve the rest for later, maybe.
Okay. Dr. Rakesh, CAR Ts, philosophically, should you put it in the first line? Should you wait till it relapses 4 or 5 lines and then push it? Just a philosophical question. We don't know the answer.
Absolutely no idea, sir. I think. I think CAR T cell therapy, I think any vaccine related, viral related carcinomas, I think there is some adaptive immunity that can come with the T cell transfer. That's what I read up for this talk, actually. I'm not very sure about the utility in India. Okay. Any center is doing that.
Okay. Any thoughts on adoptive vaccines, dendritic cell therapy? Again, that it has made a noise, and some dendritic cell therapy we have in India, and it does sometimes work. So any personal experience or any thoughts? Avinash, Sunil, anyone? Dr. Shruti, any thoughts on the dendritic cell vaccine?
So our center was a part of this trial some years back, and I have not personally been involved in that, but I've seen it working for some patients wonderfully. So for any such therapy which is which works on a different principle, my feeling is that it should definitely be used in the first line setting and not when the patient has multiply, been treated. And because in head and neck, especially with immunotherapy, also we know, I'm not talking about just nasopharynx, that immunotherapy absolutely doesn't do anything.
Okay, we lost your voice. Dr. Shruti, we lost your voice.
I was just saying that we should give it a thought if it is available in the first line.
The first line. Okay, interesting. So that's again something. So I think that was my panel, and I think in nasopharynx things have been improving, but we'll have to wait and watch whether we can use the same therapies as other part of the head and neck. So if anything else from my panel, any other questions or thoughts? Otherwise, we can close and call it a day. Okay, thank you, everyone. Thank you so much.
Thank you.
Yeah. Thank you.
So with that, we come to the end of the last session has got ended, and I need to thank people for this organization of this conference. First of all, I need to thank the committee chairperson of the scientific committee, Dr. Kumar Prabhash, Dr. Tiranjan Basu, Dr. Rakesh Katna, Dr. Nikhil Kalyani, Dr. Ashay Kalpe, though he didn't come on a single day, Dr. Bharat Bhosle, Dr. Nandini Menon for making the agenda. I need to thank multiple people who helped us with the agendas. Quite a few residents pitched in for giving those topics which they wanted to hear from us. I need to thank the academic partners, Crystal Mills and Squibb, Biocon Biologicals, Intas Oncology. I need to thank the Horizon team for helping us out to carry out this conference. I need to thank a lot of senior faculties who got their valuable time out, and not only from Bombay, but even from outside Bombay, who made it possible to come here. And this conference wouldn't have been that good and that scientifically nice if the contributions from the faculties won't have been there. I need to thank Dr. Sarbani Madam also. Dr. Sarbani Madam has been here from the first session up till the last session. Constantly we been here. Yes, we need to give a round of applause to her. Yeah. With that, I would invite all the faculties which are there and the residents, if we can come here for a group photo, and we'll conclude after the group photo.